served with the breakfast. Radical excision of what again? That's not breakfast. That's just like a piece. Today? No, I don't. Sure, somebody else is. What do you eat? Did I? I have very good. I don't have much. Every morning I have
It's time to start the next session on neoadjuvant therapy in carcinoma pancreas. The moderator for this session is Dr. Mahesh, and he will introduce.
Good morning and welcome to the second session of the day on neoadjuvant therapy in carcinoma of the pancreas. To discuss this matter, we have our eminent set of panelists, Adarsh sir, Dr. Anupama, who's a senior consultant in medical oncology at VPS Lakeshore Hospital, Dr. Baiju Kundal, who's a senior consultant GI surgery at LISI, and Dr. Madhu Murali, who's an additional professor surgical oncology at RCC Thiruvananthapuram. I welcome all my panelists on stage. So, starting on with the session. So, this is the set of pancreatic malignancy patients which you daily encounter in your clinical life. It could either be a resectable one or it could be a borderline resectable, which is defined as the lesion which may be abutting the arteries, or it may be partially encasing the vein, which may be reconstructable. And the next one is the locally advanced lesion, which has more than 180-degree of abutment of arteries and unreconstructable portomesenteric system. So in this regard, we start off with the discussion in neoadjuvant therapy in CF pancreas. So let me ask my first question to Dr. Madhu Murali. Why would you suggest neoadjuvant therapy in carcinoma of the pancreas?
Thank you, Mahesh. Can you go back to the previous slide? No, the previous one. Yeah. So if you look at this particular spectrum, it's a mixed bag. So at one end you have the localized resectable pancreatic cancer, and the other end you have the grossly inoperable ones. So the question comes: why do one in the BRPC and the LAPC, you would like to have something given pre-operatively to convert those patients into operable ones, or to not to end up having an R1 resection, or as somebody was saying yesterday, to look at the natural history. Will the patient progress during the neoadjuvant protocol period, or will he withstand that? So the question of neoadjuvant chemotherapy, I think it's pretty much straightforward in those two set of patients. But the question is, do you need to have neoadjuvant in an upfront operable patient? If that is the question, then I would say, I know that I'm working in a center, regional cancer center, so I want to operate, I'm a surgeon. But still, looking back at our own results and the patients who are referred to a center after having surgery elsewhere, and then looking at them in the long term, maybe at 1 year down the lane, 2 year down the lane, the picture is not very rosy. So it's surgery followed by adjuvant therapy, as you know, has got problems like the ability to withstand or the complete. So that is the reason why we want to give that in the neoadjuvant setting. We know that adjuvant chemotherapy is needed, definitely. But about 40 to 50% of the patients do not complete or do not tolerate or not even start the chemotherapy because of the morbidity of surgery. So naturally you want to shift it. And we know that, we know that neoadjuvant works in many other malignancies. We are shifted to, for example, if you take breast cancer, we are shifted to neoadjuvant. If you look at rectal cancer, it's total neoadjuvant now. And if you look at colon cancer, which we thought primary surgery, slowly we are moving to protocol where neoadjuvant may come in another couple of years. We have the many trials coming up. So most of the malignancy we have shifted to neoadjuvant. So this is one area we know that we are dealing with a very aggressive malignancy. So probably there is a scope for neoadjuvant. How to go forward, we'll discuss during the course of the treatment.
Fine. So you would like to think in lines of management of CA rectum or CA breast and extrapolate it to a carcinoma of the pancreas too.
Definitely.
Okay. So, what made you think, or what made you think in favor of giving a neoadjuvant therapy? What was the basis?
So because as I said in the during course of last talk, we know that adjuvant chemotherapy is needed, because without adjuvant therapy in pancreatic cancer, the survival is very dismal, maybe 18 months, 12 months. So with these two trials, the Concord trial and the Prodigy trial, we have either gemcitabine or gemcitabine cap-gem regime or the FOLFIRINOX regime, which is standard for all resected pancreatic cancers, adjuvant therapy. But we also know that in spite of this, about, as I said, 50 to 60% do not initiate or do not complete the treatment. So we need that, because we are not able to deliver what we want to deliver in the adjuvant setting. So why don't we give it in the neoadjuvant setting? Okay. That is the philosophy why we want to shift out to neoadjuvant.
All right. So as Madhu has already mentioned, only about 60% starting, and only 60% of them will complete the adjuvant therapy. And there is always a possibility of early recurrence and possibility of R1 resections.
Yeah, the same thing is with neoadjuvant treatment. Sometimes it is less than 70% will reach to the table after neoadjuvant treatment.
I mean, is that much patients will come onto the operating table?
70% of them, majority of the trials after neoadjuvant treatment, 70% of them reaching to the table or completing the proposed treatment.
All right.
That may be the reason that may be due to tumor biology itself. So why do you want to subject that patient who's not a candidate for a curative treatment? Even if you do a pancreatic surgery, he may relapse early, and we are selecting those patients and avoiding intensive surgery like a pancreatectomy for those patients.
Just to add on to what Baiju said, if you look at the neoadjuvant trials that have come up,
Yeah.
the Preopanc trial or the SPAC5 trial or the, see, if you look at the resectability was lesser in the neoadjuvant protocol. The upfront surgery patients had more surgery. Patients who were subjected to neoadjuvant protocols did not undergo the surgery as much as it would have been in the primary setting. But the survival data shows that the patients who did undergo resection with neoadjuvant did better than the upfront surgery, even though the resectability rates were, for example, this resectable rates are much higher in the primary. So you may think that you have resected the patient, but if you look back at those patients 1.5 years later or 2 years later, you find that they are doing worse than the patients who received. That is the data that comes out from the Preopanc 1, Preopanc 2, or the SPAC5 trial. So there is that question of neoadjuvant therapy.
Fine. So what are the practical issues which you have when you want to subject the patient for neoadjuvant therapy?
See, definitely, we all have come to even the need for you cannot start any form of neoadjuvant therapy. You can do surgery without a tissue diagnosis. You may attempt to have a tissue diagnosis. If you don't get it, you can operate the patient. But for starting any form of neoadjuvant therapy, I think most of the medical oncologists or radiation would agree that they need a tissue diagnosis. So in some cases, it may be difficult to comfort in spite of all your efforts like US or your endoscopic methods. Then again, the biliary drainage. You have to have biliary drainage is possible, but it should sustain for a longer period of time. So you end up having a short metallic stent. Your plastic stents may get blocked. Patient may have pancreatitis. Patient may have cholangitis. So you have to have a sustained drainage for a longer period of time. For optimizing a patient for a surgery, you may just 4 to 6 weeks. But for neoadjuvant protocol to complete and the patient to come back to you for surgery, maybe 2 to 3 months, we need to have that sustained drainage period, which may be difficult in some cases. So these are two practical issues which we face practically in our clinic when we want to send the patient for neoadjuvant protocol.
Dr. Anupama, would you like to add on to that?
Actually, theoretically, there are a lot of things which favor neoadjuvant therapy. That's first, as you mentioned, more patients are able to complete multimodal therapy in neoadjuvant setting than in adjuvant. So around 70 to 80% versus around 60%, up to 60%, 50 to 60% in upfront surgery. That's one. And second thing, the patients will tolerate neoadjuvant therapy better than adjuvant therapy, especially after a pancreatectomy. And it has shown that the post-op rates of complications or morbidity are similar compared to upfront surgery. And the problems there are, one is, as we know, when the tumor load is more, the chemotherapy may not act as effective as in an adjuvant setting. So they are likely to have resistant clones and they may develop resistance and progressive disease. That's one thing. And second, as you mentioned, complications related to biopsy. EUS or ERCP related complications like pancreatitis and cholangitis secondary to the stenting, which may preclude surgical intervention, curative resection. Complications of pancreatitis may lead to unfitness. I mean, the patient may not be fit for a surgery after that, even if it is a localized disease. And post-op gastric, the surgical time and post-op blood loss, as mentioned, is higher. Well, higher in neoadjuvant. And plus, one more concern with SBRT nerves, even SBRT induces sclerosis in the surrounding tissue. Those patients also maybe, if the surgeon is not trained in doing surgery for that, that also may preclude a surgery. So, and the studies have failed to show in operable patients survival or survival benefit in pancreatic cancer as of now, but further studies are awaited. As we know, most of the studies were in the single agent era, or the current multimodal therapy also initial studies failed, but maybe we are waiting for the FOLFIRINOX or pegylated irinotecan combinations, which may show a benefit like you mentioned, even in pancreatic cancer. And the second thing is, compared to a rectal or breast cancer, it's a less chemo and radiation sensitive tumor. That's another point. But with the current multimodality treatment, the response rates are coming up to 30 to 50%, even though the pathologic response rate is 5%. So we have 50 to 60% in triple negative breast cancer, around 25 to 30% in colorectal cancer. So compared to that, the rates here are much lower. So we can't compare these two tumors.
So would you suggest neoadjuvant therapy in a resectable cancer? That's the
Not as of now, but further studies are required. Maybe in selected patients, you can consider like some high-risk patients, not only the anatomical resectability, the conditional and biological resectability, like very high CA 19.9 values even after correcting the biliary obstruction, larger tumors, regional node involvement, proven regional node involvement, and suspicion in radiological suspicion of a metastatic thing, not proven, small lesions, or these patients may be candidates for neoadjuvant chemo as of now.
Adarsha, would you like to add?
No, I agree. I think there's a subgroup of patients, I totally agree. Young man, large tumor, very high CA 19-9, big nodes. Even if it's operable, I might put that patient on a neoadjuvant.
Okay, sir. Baiju.
Neoadjuvant treatment, 20 to 30% are responsive. How much of them will progress? Same almost 20 to 30% of progress. The disease is progress. So at present, neoadjuvant.
Yeah, yeah. I mean,
So I think the premise for giving neoadjuvant, besides the control of the systemic disease upfront, is that we are not able to deliver adjuvant treatment in 40 to 50% of the patient. So my question to Madhu is, today when the surgical skills have improved, the postoperative care has become much better than it was. How many patients in your practice, what percentage, do not reach the stage of chemotherapy, which has to be delivered in 12 weeks' time, right? So what percentage do not reach that stage?
You mean the neoadjuvant protocol, sir?
No.
Patient under
Post-operative adjuvant therapy, on the ground, what is the figure in, say, RCC as well as in Lakeshore? How many patients who are resected are unable to enter post-operative adjuvant therapy?
So at least
say 50% is the figure quoted. Is it 50% is the question?
No, even less. I think around only 30 to 40% patients are fit enough to undergo the full course of FOLFIRINOX adjuvant chemotherapy after the surgery in the stipulated period of time. So they have to start the chemotherapy within 4 to 6 weeks of your surgery. So the delay you create between the surgery and the benefit is gone. So if you want to start within 4 to 6 weeks, cycling 40-50% of the patients would
Dr.
maximum
Anupama?
would be starting up.
What is your...
Two things. One, delay in starting adjuvant treatment is one. Second is they may not be able to tolerate the usual dose. We may have to modify the dose. We may have to compromise with the schedule, single agent or
If it's
the thing.
FOLFIRINOX, it's tough. If it is single agent gemcitabine or even CAPGEM, they may tolerate. FOLFIRINOX entire 6 months of adjuvant therapy, about I think more than 70% not completing the entire chemotherapy.
Madhu, that is true about neoadjuvant setting.
Neoadjuvant also.
How many percentage you put on neoadjuvant?
I agree. Neoadjuvant
Why are
neoadjuvant.
we advocating that, in adjuvant
No, I'm
setting
not
it
saying
is-
that. I'm not advocating neoadjuvant. I'm saying
No,
that
I'm not
there
saying
is.
you or the,
No,
I'm
fine.
talking about literature.
There is a need for some sort of neoadjuvant therapy which would be tolerated by patients, which two ways. One is that they would do better on the oncological perspective. Second is that you would select out the patients who would progress during the time and avoid an unwanted surgery. They would have even done worse with the surgery and adjuvant therapy.
Problem. This is
That is what the data says.
Dr. Mahesh, can I ask a question? Yes. I want to ask Madhu and everybody in the panel. There are some contradictory statements floating around this morning. First, I appreciate Madhu's statement that, yes, this is a dreadful cancer and you must use every modality possible to treat it. At the same breath, you say this neoadjuvant regimen is far less, chemo-sensitive than other contemporary treatments for other cancers. So I'm now seeing the scenario of the patient who has borderline resectable cancer, or maybe even a resectable cancer, but it's somewhat large, as others mentioned. The patients asked me this question, I'm sure they asked you the question, that what are the realistic chances of my getting response with chemotherapy? What do you tell them? A. And if you say if you give them a figure of say 50% or 40% or 60%, I don't know what the figures you're going to come out with. If they say that means in 40% it's just not going to do any good, am I better off trying to do a trial exploration rather than? Does it mean really that that I'm cooked? Is there some way of finding out whether I'm going to be chemo sensitive? Isn't that the way to go rather than to say that we want newer trials, we want newer studies? We are doing newer studies to try and justify neoadjuvant. I almost think there is industry or the medical oncology, bias there, because what we need to do is to detect those who will respond. If we do studies to detect those who will respond, that is a win-win situation.
So
Because there are so many markers for response in other cancers.
Exactly.
But in pancreatic cancer, there are no studies on the pipeline even, which I'm aware of. If you are aware of, you may let me know.
I totally take your point, sir. Because if you look at the markers to assess the response and predict which among the patients would respond and turn out to be operable or are resectable, unfortunately, pancreas, we don't have much data. We have data only from breast cancer or from colonic cancer or rectal cancer, where we have at least some markers like MSI status or the ERP or HS to say. But in pancreatic cancer, in spite of that being one of the most aggressive malignancies, we don't have any marker. Probably in the pipeline there are some studies, I don't know whether medical oncology would add to that, we don't have. But the fact is that you may be able to operate, your surgical mortality may have come down, mortality may have come down, but still what the data says is that 2 years down the lane, these patients are recurring systemically. So
That's not the issue here. I'm asking, how do you counsel your patient when they ask you this question? That's the question.
That's exactly what others said during over the breakfast. If I say that neoadjuvant, the patient may go somewhere and get operated. But sitting in a center like ours, I can afford to say that I would give you neoadjuvant chemotherapy, then operate.
It's not a question of affording. It's a question of realistic.
No, that's what others said told me. So
I hope
Anupama, can you answer that question?
Sir, as of now, we have to tell them clearly that there is a 20%, but 20 to 30% chance that is progression. So, in an operable case, upfront operable case, I'd always suggest them to go for a primary surgery. But borderline resectable, I think the data is overwhelming to suggest neoadjuvant therapy.
Mahesh, there's been on this point, whether they're going to respond or not, there has been a study. But the problem is that you need new generation NGS to actually predict who is going to respond. And in the best of centers, it takes at least 6 weeks to get that NGS. So your waiting period increases and you need at least 2 to 3 biopsies.
Actually, even if you compare with CA breast or CA rectum or whatever, where neoadjuvant chemo or RT is going on, these are chemo or radio responsive tumors. So far, whatever, any setting, it is adjuvant or neoadjuvant, CA pancreas is not responsive. If 20% of them showing partial response, 20% of them are showing progress on therapy. So
I'm being the devil's advocate, sitting a surgeon and then and arguing for neoadjuvant. But the point is that whatever the data, we have to speak based on our own data or based on the published data. So the published data from the pre-OPANC trial or the SPAC trial or the NORPAC trial or the pre-OPANC 2 trial says that, I quote, resectability may be as good or even more in a primary setting. Resectability rates are lesser when you give neoadjuvant chemotherapy. But when you look at those patients 2 years down the lane, the picture reverts. The ones who got resected in the neoadjuvant are doing better than the ones who got resected in the primary surgery setting, in spite of all of them receiving adjuvant therapy. So the fact that you're not able to operate, there is progression, may be a positive thing, as Sudhindran sir was saying during the course of a panel discussion yesterday. You're taking out the bad ones. There's a natural selection process going on. So you may, at the end of it, end up not operating a patients who are primarily operable. But if you want to analyze your data 2 years down the line, you realize that it was better not having operated those patients because they would have even otherwise done bad. And again, as Anupama said, the medical say, today we don't have clear data to say that this is the best protocol, or this particular combination of drug is a better one, or this particular chemo is better in neoadjuvant setting, because the data is too much conflicting. We have 3 or 4 trials which came out in last 2 or 3 years. One saying FOLFIRINOX is good, neoadjuvant. One saying GemCap is good. One saying that gem setup with RT is good. One saying that FOLFIRINOX cannot be tolerated. So data is very murky. But I think it will evolve over next couple of years, and we may move on to neoadjuvant I'm talking about operable. We gradually may move on to neoadjuvant, some form of protocol in the next couple of years.
Dr. Anupama, can genetic profiling of the tumor help in some other way?
Actually, we don't have enough data, but as we know, it's a KRAS-driven malignancy. So KRAS usually confers a relative resistance to chemo, and the second commonest mutation is P53. That again confers a relative resistance to chemotherapy as well as radiation. And among the KRAS mutations also, the mutation seen in pancreas, we don't have any therapeutic option. The one which has a therapeutic option is very rare in pancreatic tumor. That may be that may be the reason for a relative resistance to these therapies.
And one more question, what level of bilirubin you want to bring down in order to start your neoadjuvant therapy?
Ideally, less than 5.
Fine. And what chemotherapy regime would you like to use in your patient? Ideal situation and the actual situation.
Ideal situation, if it is a young patient with good performance status, no comorbidities, the choice will be FOLFIRINOX or modified FOLFIRINOX. We modify 2 of the drugs and give 80% of the dose. So that is a better tolerated one, and it has shown equivalent efficacy to FOLFIRINOX. The problem is when we go through the trials both in locally advanced and metastatic, you can see that both gem-nab-paclitaxel combination as well as gem-capecitabine combination have shown equal efficacy to FOLFIRINOX. But somehow all people have started using FOLFIRINOX, and that is the maximum data available. More studies are available with that. So probably if even the NCC and all the recommendations say that if the patient's performance status and age is not favorable, we can consider gem-nab-paclitaxel and gem-capecitabine. The advantage being it can be given as given on OPD basis and a better tolerated regimen than FOLFIRINOX, at least in our experience.
Madhu, would you agree? Does your institution follow the same?
In a young fit patient, our medical oncologists tend to prefer FOLFIRINOX. If the patient's profile is a bit on the weaker side or the age is on the worse side, they would go by single agent gemcitabine or maybe combine with gem-capecitabine. Somehow our radiation oncologists are not very comfortable of neoadjuvant chemo radiotherapy, so we are not starting neoadjuvant chemo RT, but an adjuvant RT is not given. So still we stick on to some form of neoadjuvant protocol, FOLFIRINOX or gem-cap based on the profile of the patient.
So long and short of it is gem-cap or modified FOLFIRINOX without RT.
If I can add one point, one data which I can share from our own small set of series is that even though the data says that the complication rate are not much higher when compared to neoadjuvant versus adjuvant, one thing we have observed is that if at all the patient goes in for some sort of complication related to the neoadjuvant and the patient has got add-on surgical complication, it becomes very difficult to pull out the patient. So the ICU stay or the dependence of ventilator or support systems, the chance of him going into full-blown sepsis or MOTS is much higher if the patient has an associated surgical complication. All these patients who have had neoadjuvant will go in for some sort of count drop and all sorts of problems in the immediate post-operative period in spite of 4 weeks of waiting time. But if that patient develops a surgical complication, then it becomes a bit tougher to pull him out of. So that's what against the data.
All right. So this question is already answered, NACT or NACRT, it is NACT according to?
Because NACRT direct comparison studies fail to show benefit both with gem-cap and the FOLFIRINOX.
Also, the preferred chemotherapy regime also was answered. So now to Baiju, how do we assess the response to neoadjuvant therapy, and when should you be imaging or doing investigations to assess the response?
Yeah, this is more of a theoretical question, so experience is less. So basically, I discussed with my oncologist in Lisi and Amala. They said that after 3 cycles they will do. That's a CA99 if it was elevated primarily, and CT after 3 cycles. And after completion of the neoadjuvant therapy, if after 3 cycles or 4 cycles it becomes resectable, or if it is showing response, size is decreased, then they will go for a PET CT.
Dr. Anupama?
If it is not decreasing, if it is resectable, we go ahead with resection because we have the resection. The same thing is, I don't have. Yeah. No, because that's what I mean. This is not from the experience. I said it's not from experience.
The resectable ones, at least from the small experience we have, the resectable ones remain resectable. So in spite of that, we redo the imaging and the markers, CA99, which is a very good marker. And again, we don't take a decision based on if even the CA99 has gone up. If the CT shows a resect, we'll go ahead and resect the patient. So CA19 can be a marker for the long-term biological outcomes, but it can't be a factor for resectability in a resectable patient. So we re-image them after 4 weeks of chemotherapy and then go ahead. We give only 4 cycles of neoadjuvant and then re-image at 4 weeks and operate the patient, maybe 1 week prior to surgery. But the question is, regarding borderline operable. Borderline operable invariably in our center goes for some sort of neoadjuvant protocol. We re-image them, with both CT scans and again, if you ask me, how do you decide? If it has been non-progression, we go in for surgery. If it's a progression in front of nodal progression or the involvement of the artery or the vein, if it's a single vessel vein, we go ahead with surgery. But if it's a dual vessel, vein as well as artery involved at multiple points, a long segment, we take a call whether we need to really go in. But ultimately, we all agree that it's an on-table decision whether to operate, go ahead with surgery. CT can have its own problems. Again, during some journal discussion, there are some signs like halo signs, string sign, etc. But complete encasement of the artery, long segment with contour anomaly, I don't think we ever come out, unless you are prepared to go in for a vascular resection, I don't think we can able to divestment properly. If it's only a abutment, the divestment work out. So we reimage all our patients at 4 weeks after whatever protocol and then take a call.
Mahesh, just one question. Madhu, my issue is not with borderline resectable locally, only with resectable. You said resectable remain resectable, right?
That's what has been our experience. Progression to inoperability or throwing a metastasis is pretty rare.
No, it's common because we have already been recruiting patients for the last 3 years. We have almost done 120 patients. We find that patients who are upfront resectable, and I'm talking of the jaundiced resectable patients. They are stented, they are nutritionally depleted. We think that nutrition will improve, which they do, but then they get cholangitis because of some reason or other. They get toxicity of the chemotherapy. They are not able to complete this in a given frame of time, and then they don't come back for surgery. So we regret that. I mean, we still continue to, recruit patients because the study is ongoing. But then we do regret those patients who were upfront resectable, and we made them unresectable, with the,
complications of the chemotherapy.
The take here is that we probably improve survival by a few months by giving new adjuvant, and at the end of the day, we are actually making a resectable patient unresectable.
Yeah, your point is taken. So because the complications with the intervention you did to bring down the jaundice or the neutropenic sepsis or neutropenia associated with chemotherapy can convert an operable patient. So then you have to choose your patients, like Sir said, maybe a very high CA19 value, or you should some markers other than your anatomical resectability to choose whether you send the patient bulky nodal disease at the hepatic artery, celiac axis area.
I think that's the message you should give.
So the 2 points which, 2 points in resectable pancreas, the 2 factors based on which we unequally may agree to send the patient for neoadjuvant protocol would be a high CA99 value or probably a bulky nodal disease and a probably suspicious non-regional node where you want to look what's happening to the non-regional node, where the PET scan may not add on to your information already available.
If you look at all the studies, you see how the medical oncologists are manipulating the data. Fit patient, FOLFIRINOX. Unfit patient, we will give, gem, cisplatin or nab-paclitaxel. And when you compare the efficacy, FOLFIRINOX is much superior than the other. How many % patient achieve this complete course with FOLFIRINOX? 20 to 30%.
So I do agree in the neoadjuvant setting.
I have not finished. We are reducing the drugs in terms of efficacy with lesser toxicity in neoadjuvant setting. Same thing when we talk of adjuvant setting, where the Clavian Dindo type 3 or class 3 or more complications are only 10 to 15% today, and these are the patients probably would not come for adjuvant setting in 3 months time frame. That's the time frame we have to start. So 90% would still come, and where if they are not nutritionally, as well preserved, we can start with gemcitabine alone, which we are giving. We can give, if they are better, gemcitabine with cisplatin or FOLFIRINOX. So why are we not, comparing these? I think we are unfairly putting these patients, making them unresectable. This is our understanding what we are getting with the study.
Anupama, I have a doubt to you. You said bad biology, you select the patient by giving one chemotherapy regime. Suppose it is not responding. There are other chemotherapeutic regimen available in other second line therapy, etc. Is there a point in changing your chemotherapy regime? Because I have already given 3 cycles and the patient is having bad biology, poor response, then what will be the next option? Anyway, surgery is not going to help. You have to...
Recommendation is to go for the next line of treatment which the patient is not exposed, like if your patient was on FOLFIRINOX, because gemcitabine is not exposed, so gem combinations can be tried. But in actual practice, the response to those patients to second line therapy also will be poor. the usual resistance will be a pan-chemo resistance sort of thing. They are unlikely to benefit. So at the present scenario, the only option is to go for NGS and find out if there is any mutation is present, which can be targeted, and then give the treatment accordingly. And one more point, cisplatin gemcitabine as of now is not a recommended regimen for pancreas. Only for those patients with the PALP2 and or BRCA2 1 and 2 mutations, it's beneficial. All the other studies failed.
I have one doubt to Madhu.
Can I answer this? So your point is taken, because if you look at all the data coming about the neoadjuvant protocols, I would say today, sitting here, the 4 or 5 trials, if you look at it and critically analyze the data, I'm not sure which is the best combination. And I'm not sure which are the patients who would benefit and which are the patients who would progress. So I would say that I do agree that neoadjuvant should come in some way, but the data is very conflicting, and for a surgeon to analyze that data and to come out with some recommendation or some guidelines, it would be very difficult. So it's a bit murky.
Even for borderline resectable, where you have a very small window of opportunity to operate these patients, you miss that opportunity, they progress, you lose this patient. You resect these patients, you get them in a better shape, you give them adjuvant treatment, which is probably, I think,
Yeah.
Madhu, you mentioned tissue diagnosis is a must for giving chemotherapy. That is based on the consumer and other issues. Why surgeons are exposed to a morbid or a more difficult surgery without a biopsy? Suppose surgical complications can kill the patient and the biopsy comes as negative, you can be penalized.
That question should be to Anupam, I think. I also wanted to ask this.
Why persist on chemo, not on surgery? Because we had a situation where benign disease came out.
Yeah. No, if the tissue diagnosis fails after 1 or 2 attempts, that's an indication to go for surgical thing, at least laparoscopy and then.
No, why not chemo?
The question was, why are the medical oncologists insisting on tissue diagnosis prior to chemotherapy when the surgeons, which is a much riskier job, are
You
able
said
to do
if you have a very high CA19, you have bad biology. 1000 CA19, typical mass, lymph node mets, and still you want a biopsy for starting chemotherapy. And you are telling that bad biology is selected by looking at the CA19 value.
Not only CA19.9.
No, that is a marker utilized by most of the studies. If you have high 100.
Progression.
So if you can utilize CA19 as a marker of bad biology, why you are insisting on biopsy in difficult situation, not an easy situation?
It is not for diagnosis. It's for prognostic value. If it is elevated at the time of diagnosis without any biliary obstruction, that indicates that it's a poor biology. And if it is not coming down, at least 50%, more than or equal to 50% or less than 100, that's again an indicator that it's a poor biology. But it cannot be used as a...
No, you're willing to use CA19 as a marker. Then why do you want a biopsy? So the same question comes not only in pancreatic cancer, in rectal cancer, sometimes the biopsy comes negative, the lesion is locally advanced. Radiation oncologists are unwilling to give neoadjuvant radiation. Why?
That's what
If you come to the surgical side, we are willing to do even liver transplant, the biggest surgery on earth, without a biopsy for HCC.
That's what I was going to answer that. That's one of the...
As a surgeon, I think will come to help. So basically, surgery we do for many benign diseases. But chemotherapy, you cannot give for a benign disease. So therefore, without a biopsy, you cannot give, because the papers, the media will come and kill them. That doesn't happen, because we do surgery for benign disease. So it's okay. Surgery is not like it can be only for malignancy, is not there.
That's what one is. It is not used as a diagnostic tool.
We should just leave it.
There are many other reasons, including biliary obstruction, peritoneal irritation, many other reasons for increased CA19.9. That's one. And second thing, we do go for NGS and other studies. We have to see the pathology, genetics of the tumor to decide about the other lines of treatment if the patient progresses. Then it will be more difficult to get a biopsy at that time if the patient's GC also worsens. That's second thing. And third thing, like you mentioned, surgery can be done for a benign condition also. If it is not a benign, if it is going to a benign condition, unnecessarily the patient will be exposed to this thing. And if it is a uncommon tumor, adenocarcinoma and adenosquamous, maybe squamous can be treated in the same way. If it has any other component, it has to be treated in a different way. The treatment regimen will be
just one point I'll make. Sir, Ramesh sir, even this is our practice in our own institutes, our medical oncology, they won't give chemotherapy without, and if you look at the data, and the 2 arms that went in for the PREOPANC or the other trials, they insisted biopsy only for the neoadjuvant arm. biopsy was not mandatory for, there was one arm which was primary surgery. One arm was neoadjuvant followed by surgery. In that arm, biopsy was mandatory. So it's an international phenomenon. They don't give neoadjuvant chemotherapy without biopsy. So the two arms was, without surgery you can operate, but for the neoadjuvant, they insisted that the patient should have pardon, sir?
Yeah, I just
One
wanted
more
to
aspect is that for HCC, for example, there is no need for a biopsy.
Yeah. If you have a
Because
classical
because the
radiological
diagnosis
picture, you
is
can.
99% sensitive and specific, but that doesn't apply for pancreatic tumor. So I think.
Yeah, I wanted to say further in the defense of the biopsy situation is that suppose the patient has a recurrence sometimes with a rising CA99, often biopsy is impossible to achieve and presumptive chemotherapy is given. If you really want to argue legally, even there, without a repeat biopsy, we should not be given. I think there's enough reasonable approach therefore by a medical oncologist that you don't want to start chemotherapy in a patient who has no biopsy. But when the setting is very typical, later on they are willing to give chemotherapy.
Yeah,
It's
recurrence is different.
Same thing like tuberculosis, you want a biopsy. So,
In a recurrent setting, you can start chemo because it's a progression of a disease
yeah,
or something
so I
like
think
that. In a primary setting.
it
Prathapan's
just
question
establishes
is
their credentials a little bit. That's all I'm saying.
Prathapan's question is that biopsy is negative, CA99 is not elevated. He is asked specifically that CA99 is elevated. And the biopsy is
CA19
negative.
is not a very specific marker. It can be elevated in inflammatory conditions, non-malignant conditions. So that may be the reason why they don't give chemotherapy just based on CA19 with a radiologically detected mass over there. It can be lymphoma. It can be so many other things.
Can I just add one point? I asked the same question to a surgeon from US and a surgeon from Japan about doing an operation without a biopsy. The surgeon from US said that if you wait for an indeterminate lesion to show the signs after 6 weeks, you'll end up in a jail. You'll get a legal notice by the customer. And the surgeon from Japan said, you will go to jail if you operate in this era without a biopsy proof.
I
think
we
we're
are
better off in India.
It's somewhere in between because when we were PGs, we were taught that you can operate a pancreatic mass without a biopsy. But now the teaching that at least we do in our classes is that make one attempt at getting a tissue diagnosis. If you fail at that, go ahead with the surgery. Yeah, because
Others, sir, would you like to still operate a patient with borderline resectable, reconstructible potomacentric system? Coming to you upfront.
I'll tell you a real life scenario. Though literature recommends that these patients should get chemotherapy before surgery, what is happening is when I tell a patient to get chemotherapy, if there are 10 patients, at least 5 of them will not want to get chemotherapy. So, though literature recommends, in my practice, if it's a fit patient, I will most likely operate this patient surgically upfront. I know you will discuss with me, but real life scenario is this. I am aware of literature, I'm aware of that. If I have 10 patients of borderline resectable pancreatic cancer, when I tell them they need chemotherapy, 3 of them will go away to another surgeon who will operate. Of the 7 I put on chemotherapy, 2 of them will have complications, they will not complete. Of the other 5 who come to me, 2 of them will have advanced disease. Ultimately, I end up resecting 3 or 4 of them. So my present day thing is, if it's not bordering on to too much, I will most likely operate this patient before surgery. Another information I share is of all the venous resections we did for these patients, at least in 20 to 30% of them, the biopsy came as merely desmoplasia. There was no malignancy. So in real life scenario, most patients I will operate today.
Mahesh, can I ask one question, sir? Would this be the same attitude towards the venous side or the arterial side?
Only on the venous side, not on the arterial
So on
side.
the venous side,
only
the philosophy may hold good, but arterial side.
No, arterial no.
Your borderline operability can be the venous side as well as on the arterial
My question
side.
was specific.
Small. The possible only arterial might be a gastroduodenal artery. That's okay, but
Root of
SMA
the
never.
GDA.
SMA never.
On the venous side, you can have that philosophy, but the arterial side, I would say I would give neoadjuvant chemotherapy for almost. Yeah.
Other accessory right, if accessory right is involved, would you
I will.
Replaced. Replaced right hepatic.
And with my technique, most of the time, anyway, they're cut.
So, Baiju, what are those? So, some slides on normalization of CA99 with a good survival. And so, Baiju, if the CA99 were normal to start with, I mean, what are the other options available?
again, this is more theoretical and literature review. It's not the experience to say. This is, we can have a CA or CA 125 if it is elevated. Or otherwise, there is no other alternative. We have to depend upon radiology, CT, to some extent PET CT.
And the performance data.
Yeah. And this is one paper which has come up from the Mayo Clinic, which states that post-neoadjuvant resected specimens, FDG PET, pre-operative FDG PET correlated better with the pathological response than the CA19-9 response. So I've already asked this question to Adarsh sir. So what are the operative strategies and how radical will you be in your operation, Baiju?
Yeah, already we discussed in this one, where whenever there is a venous part, in borderline resectable tumors, venous part we will resect. Either it is a sleeve resection or end-to-end resection, or we can even use graft. Nowadays we are using prosthetic one, graft for resection. The lymph node dissection is same as in other resections, same. It's a regional lymph nodes we dissect. So far I have not done any arterial resection for adenocarcinoma. One case we have done for a neuroendocrine tumor.
Right. So you would always go with the pre-neoadjuvant therapy image. You have already mentioned about venous resections without arterial resections, and lymph node dissection is added. So these are some of the pictures which Baiju had given me. So Adarsh sir, your personal experience and personal take on neoadjuvant therapy for pancreas?
For resectable pancreatic cancer, no. For locally advanced, always. For borderline resectable pancreatic cancer, sometimes.
So on this note, let us join this opinion poll. Hope all of you are getting the questions. So it is there on the side. So 41. So there is no question regarding resectable CA of the pancreas. Most of us will operate them. And what about the next question?
Prefer is a wrong word. I also prefer, but it doesn't matter. What do you really do? Real life.
Yeah.
Like they say, textbook outcome. Shailesh will give to 90%. Am I right, Shailesh? You give to 90%. About 70. 70. What are those 13 you don't give? Who are those 13?
Small contact. Venous side.
Type 1, type 2 resection. Complete clearance is easy between the vein and the artery. Uncinate is not large. CA99 is not high. You can get it, I think it's an anatomical problem, not a definition problem.
That's very well said. Very good sentence. And can I ask you a question?
Please.
Shailesh, what is your experience with locally advanced conversion?
About 30%, 30 to 40. But I think that percent FOLFIRINOX predominantly, even more than Gemabraxine. And many patients, we would go to total neoadjuvant therapy. So we would complete up to 12 cycles of chemo. In some selected cases, after 8 cycles plus minus, we will give SBRT as well.
Okay.
Still continue. And then if everything is fine, let them earn that chance of getting a supramajor resection. More arterial resections with celiac axis.
Yes.
Less arterial resections with the SMA.
mean mainly for body pancreas?
Body, neck
But for
tumors.
head, no.
Head, less SMA resections, more common hepatic resections.
Oh, yeah.
Publication is coming out soon.
So my conclusions also agree fully with the opinion poll also. Resectable CA pancreas, the jury is still out. And for borderline resectable and locally advanced, NAT is more or less a standard of care. Thank you so much to all my panelists for making this discussion so lively and the audience participation also. Thank you so much.
Our next session is on the critical technical aspects in pancreaticoduodenectomy for cancer. I would like to invite the chairpersons, Dr. Prakash K., Dr. Deepak Verma, and Dr. S. Sudhindran. And our first speaker is Dr. Sailesh Aikot on preoperative optimization.
Good morning. At the outset, I would like to thank Dr. H. Ramesh sir and team for Lakeshore team for this wonderful meeting. The topic is preoperative optimization for ripples for cancer. In cancer, we all know that pancreatic cancer can lead to anorexia, nausea, vomiting, jaundice, and cancer cachexia. And all these problems can lead to weight loss, loss of fat, loss of lean body mass, and there will be excess extracellular fluid, and patients will become nutritionally depleted. Surgery is an acute illness, and such nutritionally depleted patients will not have enough reserve to fight the catabolic phase after surgery. So, in such patients, if there is a slight complication, patient can lead to more problems and even mortality. There is a cascade of inflammatory events that happens during surgery. The end result of this cascade is there is efflux of amino acids from skeletal muscles for gluconeogenesis, wound healing, and there is significant skeletal muscle loss. There is evidence that malnutrition and sarcopenia increase postoperative complications. So therefore, preoperative build-up by nutritional support and physical exercise can reduce postoperative morbidity and mortality. Here you can see this is a patient after surgery. There is intense catabolic reaction. So patient's reserve will go down from the baseline. So by this preoperative build-up, before starting surgery, patient's reserve is up. So the period, we want to reduce the period that is below the baseline. The dip has to be slowed, and patient spend less time in this dip. So even if there's a complications, it is likely that patient may recover. The process of improving the functional capability of the patient prior to surgery to help the patient withstand any postoperative inactivity and associated decline is actually called prehabilitation. It comes from IRAS protocol and typically lasts for 2 to 6 weeks. Interventions are many, mainly nutritional and exercise and medical optimization. Nutritional screening is a must in every patient undergoing pancreaticoduodenectomy. And in addition to patient weight loss and body mass index, measurement of sarcopenia and sarcopenic obesity should be considered in the preoperative evaluation. So this is the most important thing. When is preoperative nutritional support indicated? It is not indicated for all patients. There are definite indications like if there is a weight loss of more than 15% within the last 6 months, and if the BMI less than 18.5, and if the subjective global assessment grade is C or nutritional risk score more than 5, and if the serum albumin less than 3 gram percentage, or if the patient has sarcopenia, it is better to build the patient before surgery. All other patients, you can directly go for upfront surgery. But if any of these features are there, it is better to wait for at least 2 weeks to nutritionally improve the patient. This is how you calculate nutritional risk score. And if it is more than 5, you have to preoperatively optimize the patient. And also, subjective global assessment. This is also nutritional assessment, nutritional and history examination assessment. And if this is belong to C, the patient has to be nutritionally optimized. And also next thing is sarcopenia. Diagnosis of sarcopenia, you can see the muscle mass is replaced by fat tissue. It is based on documentation of 3 criteria. First criteria is low muscle mass. Second one is low muscle strength. Third is low physical performance. For criteria 1 is a must, that is low muscle mass. Plus criteria, either of the 2, criteria 2 or 3 has to be there. So how you calculate the muscle mass? It is usually by psoas muscle index. Anyway, you are doing a CT scan or MRI for Whipple's resection. That CTM itself, you can calculate the psoas muscle. In the left side, you can see the patient with a low psoas muscle index and sarcopenic. And right side is a normal patient with a psoas muscle index. And also, the grip strength, low muscle strength can be, the best way is to objectively measure this is by assessing the hand grip strength by a hand dynamometer. And also, ECOG scaling is used for to know is the patient is having a low physical performance. So there are a lot of articles published. There is emerging evidence that sarcopenia is a major contributor for morbidity and mortality, especially in major surgery. So how will you give preoperative nutritional support? There is no doubt that enteral nutrition is preferred. Only if it is not possible because of a gastric outlet obstruction or either problem, parenteral nutrition is added. Should be started 10 to 14 days prior to surgery. Intense protein support during preoperative period. Protein index of at least 2 grams per kilogram per day. From high quality protein sources like whey protein, egg protein, and also if vegetable protein and soybean protein. And it should be given throughout this day, that is multiple small feeds. At least 20 to 40 gram protein per sitting. There is not much role for immunonutrition now. Studies have shown that not much role. And protein loading can continue till 6 hours prior to surgery. Even just before the night of surgery, patient have a protein-rich meal. And the carbohydrate loading can be given up to 2 hours prior to surgery. That is, except in obstetric conditions. In the morning of the surgery, patient can give carbohydrate liquids, Carboload sachet. And exercises, 2 types. One is respiratory rehabilitation, where patient has to undergo deep breathing exercises like incentive spirometry. And severely compromised patient will require intense inspiratory muscle training. And also, second, exercise to improve general physical fitness. Aerobic exercises at least 30 minutes daily for 2 weeks. And also resistance training, 2 to 3 per week for 2 weeks. You have to concentrate on all aspects of the exercise like aerobic exercise, resistance training, flexibility, stretching. All this will improve the patient's general condition. And psychological support is a must for this. Patient will not, to improve the exercise threshold at all, patient need constant psychological support. And smoking and alcohol cessation is another important aspect. It has shown that there is 20 to 30% risk reduction when smoking was stopped 4 weeks preoperatively. Short-term smoking cessation showed no significant difference. And alcohol also, moderate to mild alcohol use stopping has no effect, but in a severe alcohol consumption should be stopped at least 4 weeks prior to surgery. Coming to preoperative biliary drainage. Biliary drainage increased risk of sepsis, so it is not indicated in patients with bilirubin less than 15 milligram percentage. And it is definitely indicated in patients with cholangitis and if the patient is planned for neoadjuvant treatment or if there is a delay in surgery. Endoscopic stenting is better than percutaneous approach. And antithrombotic prophylaxis, we know, And antimicrobial prophylaxis also should be given, first dose should be given 60 minutes before skin incision. And all recommendations recommends that you have to reevaluate antimicrobial prophylaxis or pancreatitis based on specific microbiology data of each institution. And coming to medical optimization, diabetes, there is a chance of new onset diabetes and already existing diabetes may worsen and should be strictly controlled in the postoperative perioperative period. And anemia, if there is patients have less than 7 gram hemoglobin, patient should be transfused. And if there is ongoing bleed or a cardiac compromised patient, threshold is 9. And effects of obstructive jaundice venocoagulopathy should be corrected by vitamin K and prevent renal failure. These are basic things before every surgery. And cardiac optimization is also very important in the preoperative optimization. Coming to conclusion, the pancreatic cancer can lead to severe nutritional turbulence and therefore many patients may not have enough reserve to overcome the catabolic phase after a major surgery like pancreatic duodenectomy. Such patients must be identified preoperatively by nutritional screening and they benefit from preoperative nutritional support and physical exercise. The importance of meticulous preoperative optimization in reducing postoperative morbidity and mortality cannot be overemphasized. Thank you.
Thank you, Sailesh. Thank you. It's very crisp. You said bilirubin more than 15 milligram, we should drain it?
No. The thing is that there is no evidence that if it is, there is evidence that if less than 15, you should not drain it if there is no cholangitis. But more than 15, whether to drain, we don't know. There is no level 1 evidence now to show that it is. No. In the slide, I didn't mention that it should be drained. Less than 15, no drainage. More than 15, actually, there is no evidence that it should be drained. But
because generally, as a
rule, it comes from that guideline. That is, actually, there was a study which showed that there is no benefit if less than 15. So that study was extrapolated, and guidelines came as more than 15, you may drain.
Adarsh is, I think his study, where's Adarsh gone? Has he left? I think his own study from India has shown that there is no need for drainage at all,
yes.
irrespective of the level of bilirubin.
Yes.
2-3 weeks, prolonged obstruction.
Yes.
Beyond 2 weeks, you get permanent metabolic derangements. So if it is 15 for a long duration, it stays around 15. Then I think you should take a different call. Do you agree?
Yeah. Again, for pre-operative, sorry.
I'll show the slide, but
Pre-operative optimization is longer, then it's better to drain it, even if it is less than 50.
Optimization.
So this is poor nutritional status. If you
I think
want
generally, if they're going for neoadjuvant, obviously we need to do that. Or there's something like failure, we need to then, of course. But otherwise, just for, I don't know, Pratap and Sailesh.
No, so there's no confusion here. This,
no, we do drainage because our waiting
period is
longer. Otherwise, it's not the actual issue. I have to ask Sailesh, your preoperative optimization is very stringent. I think many of our patients may not tolerate 2 weeks of intense exercise before pancreatitis. Many of them want surgery in the next day itself. So how will you convince if you see a patient in your OP with a pancreatic tumor, a periampullary carcinoma, you need them to be optimized. You are working in a private. What will happen to the patient? Will they stay back for 2 weeks in your hospital or will they go to another surgery?
Most of the patients stay back. Thing is that one is, if it is this patient, some patients may need admission for at least 1 week. So by that time, we will give all consultations, cardiac, all consultations will be done in admission. And initial, we have a good physiotherapy department. If there is, they cover all these things. They will also, most important thing is psychologically support patient. Patient has to be clearly told that it is not single day. First day, you will tell them to walk 5 minutes in the morning, 5 minutes in the evening. Next it will be increased 10 minutes in the morning, 10 minutes in the evening. Then 15, 15. By that time, by 3-4 days, they will be able to walk up to 15 minutes in the morning. 15, that is enough. 15 minutes in the 30 minutes exercise means 15 minutes walking in the morning, 15 minutes walking in the evening. And exercise, physical exercise, starting with own weight exercise that they can do is sit up and also small exercise. That's why it's building.
Regarding albumin in the pre-op setting, if you mentioned if you don't have renal disease or hepatic disease. Most of these patients will have hepatic dysfunction. Albumin less than 3 is an indication. Suppose you have obstructive jaundice patient, you don't do biliary drainage procedure and albumin is low. Will you transfuse albumin or no?
No, albumin transfusion is not required. But I am telling is it is a surrogate marker of nutritional status, and patient has no hepatic problem, no renal problem, still low albumin. Thus, patient has been nutritionally built up for at least 2 weeks.
Yeah, Shailesh, please.
Endoscopy.
Endoscopy, he said.
Endoscopy. It is endoscopy.
Endoscopy.
Endoscopy is preferred.
The risk of infection is higher, and then a more natural drainage also, no? So, I mean, it's cholangiocarcinoma, it's different, but I think for this one, endoscopy is almost always preferred.
So I
Yeah,
think
Shailesh, sorry, yeah.
To add to the bilirubin thing, the number of patients that you will get with a bilirubin which is more than 15, and there is no metabolic derangement and there is no symptom and the patient is absolutely symptom-free, is relatively a smaller number. So you will get patients, and we have all operated with 17 and 19 milligram bilirubin without pre-operative biliary drainage. But that number is a smaller number in our experience. We find that once it crosses 15, they have issues. Apart from the other issues which were rightly highlighted, that you need time for optimization, your albumin is a problem, the wait list is a problem, then they of course would need a drainage. So I think it's more of a practical recommendation for 15 and above. But he's right when he says that we have more evidence that for less than 15, if everything is fine, you don't need to drain.
Yes, sir. Yeah.
Just a point, actually, one. Most of these patients will be chronically constipated, and by the time you operate, the colon will be loaded. So just to add to the vitamin K, hydration, nutrition, some laxatives.
Laxatives.
So how will the, Madhu, I mean, maybe Anupam is gone, the neoadjuvant therapy itself, because how, with the prehabilitation, will that interfere with the prehabilitation?
No, some facts have to mention, because as Shailesh has said, we have pretty long waiting list. To be truthful, our waiting list is about 2 to 2.5 months. So we drain most of the patients. Irrespective of anything above 10 or 15, we tend to drain and maybe put them on a short form of chemotherapy in the neoadjuvant protocol. So if you look at my list in June and July, I have at least 6 or 7 or 8 people waiting. All of them have been drained and all of them are post-chemotherapy, not because of the inoperability part or not because of the wait list we have. And we advise them to go to some other center, get operated, they don't go. They still stay back with us. So that's a problem which is inherent to our center. So as I said, the drainage-related complications are there. Most of the patients end up some form of sepsis-related complication in the intraoperative. And again, the neoadjuvant, as I said, they're going for some surgical problem, they have worse outcome. It's difficult to pull it out with extensive intensive care. We are able to pull them out, but perioperative complications are lesser. So in our practice, we drain most of the patients because of the logistic issues we have in scheduling. We can't post a patient within 3 weeks or 4 weeks. We have a long waiting. I have to accept that. Any patient, we drain and then take up surgery. So we are used to drainage and operating.
Can I make a provocative statement, not connected with what Madhu said, the point which Sindhu was talking about? I hope there are no medical gastroenterologists here or any medical person is here today.
They have gone, it's okay, carry on.
Huh? No. So our general principle in oncology is not to touch the tumor, correct? When we operate, we are careful not to manipulate the tumor too much and we tend to stay away from it. So why not apply the same? I'm just putting this for discussion. Because this is an observation that having operated small periampullary carcinomas, maybe we can say that it's bad biology. And 1 year down the line, I have seen some people coming with widespread liver mets, just small periampullary tumors. So extrapolating this thought, I was thinking whether they had pre-op biliary drainage ERCP stenting, these patients. So if you go percutaneous PTBD, you're not touching the tumor at all. You're not manipulating the tumor at all. I don't know, I'm just putting this for discussion, whether the manipulating of the tumor during ERCP, difficult stenting, whether that will contribute to dissemination. I don't know.
Ramesh, I have the same experience with 7 cases. All of them stented from outside, ERCP stenting small periambulary. Because for periambulary or ampullary tumor, they cut through the tumor, I think, sometimes. But for pancreatic head cancer, when the duodenum is not infiltrated, the risk of cutting through the tumor is less.
But I think this cannot be extrapolated because suppose you take the scenario of Klatskin tumor, Japanese routinely do tumor stenting one, maybe multiple, and make them wait for 2 or 3 months even for the optimization for the bilirubin to come down, because there's always a transtumoral stent. No, most of it is transtumoral. For the
Prakash, that is PTBD, right, for clad skin.
Yeah.
But they don't go through the tumor, right?
I pointed this to, I pointed
They have to internalize, so they
this
will.
to Varghese Thomas, sir, and he said, then you give me the data, then I will look into that. But we will.
There
we
is
won't
no
get
data.
That data.
There is
because
no data.
But
it
theoretically,
may be anecdotal only. Yeah.
Theoretically, even if you're cutting through it, and we remove it, we are taking the whole thing away, no? So all that area which has been contaminated. So do you think it happens?
There is no.
There is a publication from SCPJ group, periampullary, small periampullaries, ERCP post-stenting, and compared with non-drained patients, they have a more potential for lymph node as well as liver mets. Definitely, there is a published paper from SCPJ. But the touching the tumor is, even with PTBD, you don't expect your 1200 ml bile to be lost. You are always internalize it. And maybe at the end of the second day, third day, we are going to cap it. So the stent is going across the lesion, whether it is a tough lesion or a soft lesion. So cutting or disturbing the tumor is not much difference, whether it is ERCP or, because you are putting a stent across and you are capping it.
Can I add a different scenario, because we are discussing about arterial divestment, cutting through the tumor, divestment, all these things. And
in our center, it's easy to get a PTBD done than an ERCP stenting. So we are nowadays we are doing that. We'll come back with the data.
I mean, varies from center to center. If somebody is happy for PTBD, that's fine. Go ahead.
Yeah, but we will have a comparison, sir. We'll come back with the data.
Does anyone do a percutaneous cholecystostomy?
No.
Surgeons have handed over everything to everyone for no reason. Can I make this statement? Sure, but then in a number of cases, you will be good enough by just, you are doing a periamp, right? You're doing a Whipple's, right? What's the harm in doing a percutaneous cholecystostomy? Just a few days.
The same issue, because we don't know where the cystic duct is opening. So if that's also blocked, there's no point at all.
If GB is dilated.
Yeah, but GB is dilated.
GB will be dilated because you'll have a mucosa. So because the blockage will have.
Within a few days, because there is no inflammation, there is nothing.
If we plan such a drainage, then it's okay.
Exactly. So we can avoid a number of ERCPs, a number of these. We have had some experiences where there have been problems with centers for doing ERCP or a PTBD. And we have just told them that just go ahead with this, and then within 4 days, 5 days, absolutely clean abdomen, everything fine.
Regarding the oncological outcomes post-stenting.
Simple intervention.
Regarding the oncological outcomes, stenting versus no stenting, I take the point said by Ramesh sir and Prathapan, but I think we have a lot of data to compare this. The DROP trial, which was a randomized trial, and so many other data with comparing stenting versus stenting. All of them said the oncological outcomes are not affected by the stenting.
The infectious complications.
Infectious complication. You look at the randomized trial or look at the non-randomized or meta-analysis looking at the stenting versus no stenting for surgery. But the oncological parameters have been similar. Only the complications related to the stenting or the infectious complications perioperatively have been the higher side. So other than the anecdotal reports, we have.
But the
Again, it's what do you want to choose? Dragon versus Dead Sea.
I think we
Infection
will have to
means stented,
make a
bleeding
close of the
means
session, because
non-stented.
this can be discussed ever. So thank you, Sailesh, for making this wonderful topic. And
Now I invite the next speaker, Dr. Kalerisan, and he'll talk on whether mesocap pancreas resection can be standardized.
Thank you. So in this talk, we'll just focus on the principle. So I'll highlight with a lot of pictures, no videos, maybe a small open clip rather than a minimal invasive. So what is a mesopancreas? So it is if you see the definition, it's a structure composed of fatty tissue, nerve plexus, lymph nodes, which are located in the pancreatic retroperitoneal region between the head and the superior mesenteric and celiac vessels. So this is what is defined. But for surgeons, we need proper boundaries extent to completely do a mesopancreas excision. So that's what we'll be focusing in this lecture. So this is a schematic representation of what you mean by mesopancreas, and this is the radiological definition or the extent of mesopancreas. So why it is important? Because the good study, anatomical study done from Japan, so where they have shown pancreatic cancers have extensive perineural infiltration, and this is how they spread along those pancreational vessels and go into the superior mesenteric artery. And that's why we need to excise the mesopancreas. No level 1 evidence to support this, but lot of retrospective analysis have shown mesopancreas excision improves R0 resection and local recurrence. So these are the two things which have been proven. With respect to the overall survival, it's still not proven, but you can reduce a local recurrence. So we commonly use the term mesopancreas. Is it the right terminology? Because when you, what do you mean by a mesentery? So it should have folds of peritoneum. All the blood vessels supplying that organ should go through that mesentery, and all the lymphatics should be in that folds of peritoneum, and it should attach the organ to the posterior wall of abdomen. But if you see the pancreas, not all of its blood supply is through that mesopancreas. You have the GDA which is coming, which is outside that. And that's why, so you have the lymphatics also beyond that. And for this reason, strictly speaking, the term mesopancreas is not the right, it's a kind of misnomer. And that's why if you see the Japanese guidelines, they prefer the term head plexus rather than mesopancreas. But this term, if you see the overall literature, it's commonly used and it will remain in usage. So this is another question, because sometimes, so what is a nerve plexus and what is the difference between nerve and a nerve plexus? A nerve is a neuron with a connective tissue around that. But nerve plexus, it does not have only nerves, but it has blood vessels and lymphatic vessels. So what we are actually talking is basically the pancreatic head plexus. And having understood that, so as I mentioned, as we surgeons want to have the extent, anatomical extent. So the mesopancreas has the three components. The pancreatic head plexus 1, which extends from celiac trunk to the uncinate. Head plexus 2, which extends from SMA to the uncinate. And then the proximal jejunal mesentery along the first jejunal artery. So these are the three components of mesopancreas. So if you are telling a total mesopancreas excision, all these three components should be part of the specimen. The question is why this is important. The territory along the jejunal mesentery along the first jejunal artery, because if you see here, this is something which I've shown yesterday also. So now we know that our tumors are in this region, ampulla. And ampulla is drained by or supplied by these branches of IPDA. And often IPDA originates along with the first jejunal artery. So this is the common route of spread of the tumor cells. So when the tumor cells spread along the vessels, lymphatics, so they also travel along the first jejunal artery because of the common origin. And that is one of the reasons why this territory also is included part of mesopancreas excision. Now once we know that what are the components, so what should be the dissection range in when you do a pancreatectomy? So there are three dissection lines with respect to the mesentery. The first is you go along the jejunum, close to the jejunum, and then reach the uncinate and travel along the branches of the IPDA and then go to the SMA. So this dissection line is not a mesopancreas excision. So this is not, so we won't be discussing that further. The dissection lines, you can see here there are two figures. This is with respect to the veins and this is with respect to the artery. So when you talk about the vein, whether we are going to divide this IPDVs away from the first jejunal trunk, or you will be going along the first jejunal trunk, or you are going to excise the first jejunal trunk. So these are the three dissection lines with respect to the veins, and these are with respect to the arteries. That is, are you taking only the peripheral branches of IPDA, or you are taking the common trunk of IPDA and the first jejunal, or you are taking the second jejunal in addition to the first jejunal also. So these are with respect to the arteries, and these are with respect to the veins. And dissection line 1 is not recommended for malignancies. So that is only in a benign cases. So we have either dissection line 2 or 3 when we talk about malignancies. So this is with respect to the mesentery and jejunal vessels. And the next component of the mesopancreas, so you have reached now the SMA. In the SMA, in what plane you will stay? The level 1 is, the LV1, is you are actually not taking any of this pancreatic head plexus. So you stay close to the vein, and then you, so when you actually follow the dissection line 1 along the mesentery, most often you stay away from the SMA, which means that even the pancreatic head plexus 2 is not removed. Now this is again not for malignancy. So dissection line 1 and LV1 are for the benign conditions when you are doing pancreatectomy. So the standard is LV2, in which you take the pancreatic head plexus but preserve the SMA plexus. And in LV3, you take the hemicircumferential SMA plexus. That is 180 degree on the right side, you take the SMA plexus. I mean, it can be either 180 or 360, but we prefer to do 180 to minimize the complications. So there are two components in mesopancreas. One is on the mesentery and one is along the SMA. So generally, I think this distinction, probably Ramesh may not like it, but just to give a, because you do have a small subset where it's a pure ampullary tumor without pancreatic involvement. So where you can stay in the dissection line 2. And in pancreatic tumors, whether the dissection line 2 or 3 depends upon the imaging assessment. You can assess how is the involvement. If there is a involvement into the head plexus, then always better to stay in the 3. But otherwise, you can follow the dissection line 2. And along the SMA, it is always LV2 or LV3, and generally in pancreatic cancer LV3, and in LV2 for small ampullary without pancreatic involvement. So this is kind of standardizing your mesopancreas excision. So that is the first half of my lecture, and the second component, so now coming back to the same figures, so you state for small ampullary tumor without pancreatic involvement, follow the dissection line 2 in the mesentery, and along the SMA stay in the LV2 plane. And for the pancreatic cancers, line 3 and LV3. So how to do mesopancreas excision? The challenge with the mesopancreas excision is because of the twisting of the mesentery. So we know the uncinate process is here, and our mesentery is on this side. The mesenteric vessels go this side, and we are the uncinate dissection will be on. So because of this twisting, the mesopancreas excision is complicated. Now, retaining the twisted mesentery, you can actually do along the left side. You start from the left side. So this is basically infracolic. You can follow the jejunal vessels and do the same plane. I'll just take maybe 2-3 minutes. It's okay. So we just follow the jejunal vessels in the infracolic compartment. You're not, with the twisted mesentery, you can still do the mesopancreas excision, which is called the left approach. But because we are not familiar with that anatomy, it can be technically challenging. Otherwise, it is still feasible. But because conventionally we are used to approaching it from the right side, we need to find a safe method of doing mesopancreatic excision. So that's where the concept of intestinal derotation, when you do it completely or when you do it partially, you can call it as a flattening. Because now this is the view you get when you don't derotate the mesentery. So you have the veins covering the artery, and when you approach it, you can injure the vessels because of lack of good landmarks. And so the structure which actually retains this rotation is something called this uncinate process ligament. It extends from the uncinate process into the posterior aspect of the mesentery. So this is called the uncinate process ligament, which you can observe when you are actually doing this dissection. You can see the tissue which extends from the posterior aspect of the uncinate process into the mesentery. Now this actually retains the twist. Now once you divide this uncinate process ligament, and then you will be able to mobilize the DJ flexure and deliver the proximal jejunum to the supracholic compartment. And that actually derotates the twist and makes your anatomical observation clear. So this was a picture which was shown yesterday. So this is after complete derotation. Now you can see all the jejunal vessels are towards the right. Typically, if you see in the rotated, so this will be going like this, and artery will be going like this. So when you approach, so either you will be taking only the peripheral branches, and we will be reaching SMA close to where the tumor is located. Our aim is to reach the SMA away from the tumor. And that's why you do this, and once you do the derotation or the flattening, then you can identify the first jejunal artery territory, and you can go in this plane along the SMA, well away from the tumor. So I think this procedure can be done by minimally invasive, but the main reason I'm not showing is because first you should do that in open approach, be familiar with anatomy, and then move to the minimally invasive. So when you are doing this, we need to remember about these arcades. We all familiar with this arcade because of making this ruling. But the initial part between the first and second jejunal artery, you always have one arcade which is very close to the SMA. So when you are coming between the first and second jejunal artery, you will have one arcade close to the bowel, and the second arcade will be very close to the mesentery. This is again one point you should remember when you are doing this. So this is a very short video I delivered because we have another session on minimally invasive where we'll discuss about how to do it minimally invasive. But as I mentioned, we should be familiar with the open. Now you can see here the proximal jejunum is delivered into the supracholic compartment, and this is not a complete derotation. You will still have the mesenteric vessels going along like this, but at least the first jejunal artery territory is now under your view, and you can always use the first jejunal trunk as a landmark. And here you will have the first arcade, so which is easy to identify. So the key is getting the proximal jejunum into the supracholic and staying between the first and second jejunal artery. And usually this first jejunal trunk is a good landmark. Now we are going close to the base of the mesentery. You can see this is the first jejunal trunk. This is the first jejunal branch draining into the first jejunal trunk. Because we all know that territory drained by, supplied by the first jejunal artery and the first jejunal trunk are different. So the first jejunal trunk is formed by 3-4 jejunal veins. Now this is the first jejunal vein draining into the first jejunal trunk, so that is taken. So you can see here now we are basically, this rotation you are correcting it. So once you divide, you can see now the mesentery move towards this side, and the rotation you are gradually correcting it. Now this is what I mentioned. This is the second arcade which is close to the base of the mesentery. So only when you take this, this is the first jejunal trunk, and where the jejunal vein is draining into the first jejunal trunk. I think once you do few cases in open, do it slowly, understand the anatomy, then it becomes easier. And now you can see this is the jejunal artery, the first jejunal, the main first jejunal artery. It will be going down. So once you divide the first jejunal artery, the IPDA straightens up. And you can see the IPDA now comes into the view. So this is the safe way of getting into the superior mesenteric artery, away from the tumor bearing area, and also allows you to remove the proximal jejunal mesentery also. And then you can complete the uncinate dissection. This patient had a small venous involvement, but I'll just skip that, show the last part. So you can see here, sorry. So this is what you will have: the SMA, the celiac, and the triangle area is cleared along with the jejunal mesentery. So this is how you standardize. So it is feasible, and it could potentially reduce a local recurrence, because that's what we surgeons could achieve. We can reduce a local recurrence, and obviously the occult metastasis we have to depend on the chemotherapy. Thank you.
Thank you, Dr. Kale, for wonderfully demonstrating that. So for the third type of dissection, is it not safe to start from the infracolic SMA approach so that you can be taking the jejunal vessels in the infracolic level and then take the uncinate from the right side?
No, we can actually very well do the approach. The reason why I mentioned is because actually we need to appreciate the anatomy from both sides. We should be familiar with both the anatomy, because there are some scenarios where we follow that approach because when there's pancreatitis, so the right side plane will be fused. So those are the scenarios where we actually approach from the left side. But when we approach from the left side, many times, because of the unfamiliarity with the anatomy, so you tend to make mistakes of identifying the structures. Often when you do from the left, commonly you have to take the first jejunal trunk, because that will be overlying the jejunal vessels. So unless you take the trunk, you may not be identifying the jejunal arteries easily from the left. Or you try to preserve it, often we tend to injure that. So that is the reason why we follow this approach of derotation and approach from the right. If you are actually going from the first, along the first jejunal artery, you reach the SMA well below the uncinate. And if there is some suspicious of involvement, you can actually use the second jejunal artery as your landing plane for the SMA. So you can very well come below in this approach also, depending upon whether you want to go along the first jejunal artery or the second jejunal artery, and then reach the SMA well below the region of tumor, and you can do the circumferential clearance, and depending upon whatever you want, whether do you want to LV2, LV3, can very well be achieved.
Thank you. Dr. Sailesh.
Two comments.
Yes.
I would not make a differentiation between periampullary tumor and pancreatic cancer and uncinate process. There is only one plane and there is only one resection.
I agree.
I don't think we need to do that. This is semantics. This is theory, but this is not practice, in my opinion at least.
I agree. I mean, the reason is because we do see some tumors, they are really early. I mean,
I don't know how you can say that, because the earliest of tumors can have the worst of liver metastasis, and we should not run the risk of, we should be good anatomists and we should be good artists and surgeons, but we should not run the risk of becoming only technicians where we, confuse about the oncology part of it. But that's philosophy we can discuss over coffee.
Yes.
The second, I don't need
No.
to convince, I'm making a comment, it's up to him. He's an independent surgeon. The second thing is...
No, the reason why I'm actually, because when I routinely follow the LV2.
So I'm coming to that.
Yes.
Just my second comment is that yes, the way it has been described by Inoue in 2015 in Annals of Surgery, LV1 to the right, LV2 to the left, LV3 subadventitial or periadventitial. You can also do LV2 by going from the right if vein is not involved. That's the point. So the figure is a good explanatory figure from Inoue, which you also showed it as a line diagram. That's a good clear figure. But you can also go like this and go right till the end of the mesopancreas. That's your right medial approach for the SMA if you are in the supracolic. It's also your infracolic approach for the SMA if you want from there. And you are fair. Sorry? Really? I didn't know that. I thought I presented in your IAP the SMA first approach in 2011. You all got up to catch a young Shailesh over here in this hall itself.
I don't.
Just take a moment, which I learned from your talk, IHBP as well as today. For the residents, just I'm repeating it. Splenic artery, there's a splenic vein. Superior vesical artery, there's a superior vesical vein. First jejunal artery, there is no first jejunal vein. Jejunal vein, he used the term trunk. That means 2-3 coils together to form a bigger vessel. And doesn't follow the typical anatomical pattern. So that's the difference between arteries as well as jejunal veins.
It's like the gastrocolic trunk as well, no? There's no artery for that.
Actually, that's a very important point, because that's one of the reasons why that anatomy becomes more complex. The vein which I ligated, that is actually corresponding to the first jejunal artery. So that's called the first jejunal branch draining into the first jejunal trunk. So that is what we like.
Shailesh, Kale, in the beginning we saw all beginning surgeons all doing ligation, routine ligation of the first jejunal trunk. Was it improved or was it worsened by doing a smaller vein resection? Because we individually ligate that veins rather than going to the first jejunal vein, thinking that that may be a major venous drainage for the entire jejunum. So initially, when we will ligate the first jejunum. The tendency to ligate the first jejunal vein, but as we progress in our technique, we tend to save the first jejunal vein. Oncologically, it may be correct or not, but when there is no involvement, I think it's always better to preserve that first jejunal trunk, because you are taking the jejunum for anastomosis. If there is some venous engorgement or venous congestion, they all can have problem with anastomosis.
Yeah, that's standard, the level 2 and the dissection line 2, we preserve the first jejunal trunk. And if you have to resect it, you remove a longer length of jejunum. So that way you can prevent complications related to jejunal congestion, because that is one thing which we follow if you are going to ligate the first jejunal trunk.
Thank you, Dr. Kale, and thank you.
We next have Dr. H. Ramesh on the artery first.
Good morning, and Mr. Chairman, ladies and gentlemen. Most of my lines have been already covered by Kalaharsan and Shailesh. But I hope there are a few residents still coming on Sunday morning. And I just wanted to mention some important points. And this is a slightly more three-dimensional approach to how you can reach the superior mesenteric vessels. And we have looked at all these approaches. I just wish to mention that with the advent of minimally invasive surgery, going posteriorly has become a breeze. You don't have to transect the neck of the pancreas. You can actually get the artery before you get the vein very, very elegantly. So that's changed the whole, approach to the superior mesenteric vessels. I also want to mention the left posterior approach, and Kalay was mentioning how it can be sometimes confusing to reach the superior mesenteric artery there. If I had a proximal jejunal gist, or if I had a third part of duodenum tumor, I would always use a left posterior approach. But I wanted to emphasize the fact that a combination of these techniques is often required, especially if you have a slightly bulky tumor, especially if your policy is to hang the tumor on the superior mesenteric vein, in which case what you would do is you would need to, rock back and forth. So the question that I've titled this talk is that, is it such a big deal? And in fact, the first randomized trial came in 2017, which really said that there was no major difference, and that was in the annals in 2019. A huge number of papers have established its feasibility, safety, the fact that it can actually be done with considerable elegance. Shailesh himself has a paper on this subject. The Maple PD trial, I believe the results are still not yet out. I communicated with the principal investigator, and they have not yet collated the data. It should have been out by now, but it's not. Maybe it's not because it's not really a big deal. The artery first approach could help in hanging the specimen on the SMV and resect it later. It minimizes clamp time, lets you organize the system for whatever you want. You can take a break, whatever. In patients with borderline resectable pancreatic cancer, suppose the patient says, I want you to operate me because I think, if possible, I would still think it's a great idea to do an inframesocolic approach and then just see if the artery is free before you actually go and mess around the pancreas. And if it is not favorable, you can pull out and say, this is not for surgery categorically. And if you can do this by MIS, it's all the better. Of course, we can do adequate lymphadenectomy, which you can do otherwise also. Arterial anomalies can be eminently looked at, which also can be looked at. And therefore, that's in a yellow. There is some evidence that it increases operating time, but it's not a big deal. There is a slight risk of chylous leak and diarrhea because inadvertently sometimes you encircle the superior mesenteric artery at more than one place and remove all the tissue, the nervous tissue. My own policy for the last 15 years has been you can do SMA first or last, but SMA always. Either you do a peri-adventitial dissection or you do a sub-adventitial dissection depending on the extent of the tumor. And I have, say, three approaches. If you have a tumor far away from the superior mesenteric vein, you can go, and I've just used this slide. It is actually this patient had a superior mesenteric vein resection and end-to-end anastomosis. If you are clear that the tumor does not approach the superior mesenteric vein, you can go from the right. You can dissect the lymph nodes, and you can approach the artery from behind the superior mesenteric vein. If, on the other hand, of course, it is a good idea to expose the superior mesenteric artery origin and clear the lymph nodes there, because then you have a clear idea of where your dissection should be. If, on the other hand, there is some abutment, and there's actually some infiltration here in this case, I think, I would not recommend this sort of a dissection. But what I would recommend is that you would then dissect on the left side of the superior mesenteric vein, and then expose the superior mesenteric artery, clear it completely all the way up. For, of course, if you do it open, you have to transect the neck at some point. You can't do it without transecting the neck. In laparoscopy or robotic surgery, you can do it without transection. Indeed, you always transect the pancreas afterwards. So that is what I would do. And in the real bad ones, I think the only technique that I think can be done is to do an infracolic, mesocolic approach, identify the SMA and SMV, and work your way up. And eventually what happens is you end up under the neck of the pancreas. You have left the arch of the mesocolon behind, or you're working under the arch of the mesocolon, and you have actually gone to the, I don't want to get bogged down in this video. So I'm going to, the question that I always ask is, everyone talks about artery first, but is artery the final frontier? If you do a venous resection, you've got an artery behind it. If you look at this picture, venous resection has been done, the celiac axis is seen here, the superior mesenteric artery is seen here. What about this tissue here? And how can you become more radical? If this tissue is involved, it's as good as involved. This is actually the mesentery of the proximal jejunum. That's why, as Kalai said, I'm somewhat obsessed with the fact that the rotation of the bowel ensures that you have two sections of the mesopancreas, overflowing on two sides of the midline, as it were. And unless we derotate, and that's, to my mind, one of the technical flaws of our current, approach to minimally access surgery, that we have yet to find a way of retracting the third and fourth part of the duodenum and placing traction so you can actually get this tissue on the right side. And I just want to show our version of the brief video. Again, you can see the artery has been exposed completely there. But this criminal fold, which I call, allows you to complete the straightening out of the mesentery of the Unsternate process and the mesentery of the proximal jejunum usually carries the chylous vessels, and therefore you are better off sometimes ligating it. Just as Kalai has shown you, the best thing then is to convert this operation to right hemicolectomy. So you are going to drive from the jejunum. You can actually plan your mesenteric division in such a way that even in chronic pancreatitis, if you had to do a lateral drainage for an exceptional distance, you can get a very long roux loop, which can, jejunal loop, which can reach comfortably to the other side. So your aim is to reach the superior mesenteric artery. You can see the artery and the vein there. So divest all the tissues and ligate the vessels, and finally you end up with the vessel ligation. So that is the end of the procedure, and then the IPDA. So when that is done, the operation is kind of finished. The only concern I have is that everyone would say ligate the IPDA early, otherwise the specimen would get congested. I'm not sure if it's such a big deal. So that's it. Thank you very much.
Any questions? So basically, did you say you would transect the pancreas most of the time before you actually get to the SMA?
No, the neck of the pancreas would have to be transected in open surgery for sure. But even that can be done later. But what you would certainly have to do is, once you have mobilized most of the Unsternate process, you would then need to definitely do a partial re-rotation of the bowel, and in which case the whole anatomy becomes very straightened out. There's no mysteries. The jejunal vessels are no longer curving and going behind. They are coming straight ahead, and it doesn't take a great, very intelligent surgeon to map where he or she wants to resect. Otherwise, basically, these vessels are going back. I've seen surgeons ligate these vessels twice, once close to the superior mesenteric vein, which is not ideal. If you have a jejunal trunk which is more than 7 millimeters, you should not ligate it, because that means 4 of the proximal jejunal veins are joining it. So normally 2 or 3 are joining it. If up to 2 or 3 is okay, you don't get congestion of the jejunum. But if you have 4 joining, then you will get congestion. And if you have some excessive crystalloid therapy intraoperatively because your patient dropped their blood pressure, then you are in serious trouble. Your bowel will be really edematous and also a little dusky. So, and then what happens is, then this vein is actually curving back behind the SMA, and then it gets ligated a second time. Sometimes there's bleeding from those veins. And all of that can be avoided if this move is done. And this has been a standard practice for over a decade in unit.
So in robotics, I mean, normally this intestinal derotation, is that a must? Because can you do it from the right side fully?
Yes.
I mean, is that possible?
It is possible, but it's just that it would be so much easier if you did it. So how could you do it? You would probably have to place 2 sutures in third part and fourth part, and then take it out of the abdomen and put some traction on it, and then of course.
No, I mean, does it impinge on the oncological outcome because you don't end up taking that much of jejunum in that case? Because so much more easier and saves a lot of time if you do it from the right side.
Yes, it is oncologically satisfactory because you can take as much jejunum as you like.
Still from the right side.
It's not. It's an entirely different decision. That doesn't depend on which side you approach. In fact, I believe that when you take the jejunum from the left side, that's when you end up transecting it too close and then using a harmonic scalpel to just scythe your way through the mesentery very close to the jejunum, and that's probably not an
I don't know
advisable.
how Kalai does it when you do it robotically. Do you do everything on the right side or do you do?
The mic is there.
Okay, we got a video, is it? Yeah.
I thought because there is a session on minimal
All right,
issue,
okay,
so
thank you.
I thought we'll cover that.
Okay, thank you. I mean, for both of you showing us anatomy that I never knew existed. Thank you so much.
We'll have a very short tea break and then start the next session. Excuse me. It's time to start our next panel discussion. It is on vascular resection in pancreatic cancer. And the moderator is Dr. Shailesh Srikande. And the panelists are Dr. Kalerasan Raja, Dr. Sajish Sadevan, Dr. Ramesh Rajan, and Dr. B. Venugopal.
Thank you so much for this invitation. Shall we start the session? If the coffee can come to the table so that there is no disturbance. Friends and colleagues, request you to come and be here. You can carry your coffee, but we can save some time. Great. So the brief given to me by Dr. Ramesh, first of all, once again, congratulations to him. He has been a real leader and an idol for so many of us for so many years. And he never ceases to surprise me with his energy and with his desire. I really wonder whether he's not very old, but when I get as senior as he is, would I have the same energy and the enthusiasm to carry on relentlessly as he does? Time will tell. But yes, thank you for this invitation. Congratulations. And as I just told you, if an invite comes from you, the first instinct is to, if required, even adjust everything around it, but make it to Cochin. So thank you. The brief given is to speak in a conference where we are discussing only pancreas for 2 days, vascular resection in pancreas cancer, strategy and execution. We have 4 experts who are excellent in their own way. Dr. Raja Kalerasan is well known. He's from JIPMA. Shajish is from Calicut. And Ramesh Rajan is from Trivandrum. And Dr. Venugopal is from Cochin itself. They are going to be doing the talking. I'm going to highlight some issues. And we will try to finish everything in 45 minutes. So that we have 15 minutes available for question answers. So the request would be that please on your piece of paper, please note down all your questions so that we can have a 15-minute interaction as well. I'm going to try and focus a little bit about anatomy and imaging the way I would. I know you've already had this yesterday and in greater details, but when we look at a case in the pancreas clinic, the thought process is staging of the cancer, vascular relations of the cancer, any vascular or biliary abnormalities, patient general condition, anesthesia, fitness, optimization, and surgery. This is standard. But it's more important that we study the radiology ourselves and we are aware of the anatomy at the back of our mind as we study radiology. Anatomy in the books is one, anatomy on the scans is another, and anatomy on the operation table is another. We try to merge all of these together in our system so that we can do a good job. And then once you decide that there is a vein resection to be done, how do you want to plan it pre-operatively and intraoperatively, a little bit post-operatively as well? First is the planning in the brain and then comes the actual execution on the operation table. And I'll touch upon arterial divestment and resection also since that's the brief which the boss wanted me to do. Kale, you have already given us many lectures which I have personally enjoyed, not only today morning but even in Pondicherry. This is again a picture where I just want you to highlight for the sake of the audience in terms of the important veins and venous structures or the portal anatomy, which is relevant when it comes to planning a vein resection.
Yeah, so I think we all, in the conventional Whipples, we know about the importance of a gastrocolic trunk, because that is one of the area where there's a lot of variations which can happen, and it's a potential site of a bleeder. And the reason is, when there is a venous involvement, usually we see the gastrocolic trunk dilated. So that is one thing which we need to keep in mind, and while trying to ligate it, most often when there's a venous involvement, you tend to have bleeding from there because it is dilated. The next important venous anatomy is with respect to the first jejunal trunk, because there are two reasons. One is, if the venous involvement is coming close to the first jejunal trunk, then when you actually preserve the first jejunal trunk, it can sometimes even cause the twisting of the vein while doing the anastomosis. So there are some cases where you might even resect the first jejunal trunk to make sure you have a proper orientation for the anastomosis. The second is knowing the diameter of the vein, so that whether it is a significant, it's draining a significant portion of the jejunum, as was mentioned by H. Ramesh sir also. The next important things I will be interested when we talk about the venous resection is, what is the drainage pattern of the left gastric and the IMV? If the venous involvement is close to the portal vein, the splenic portal vein junction, splenic and SMV junction, if both IMV and the left gastric vein draining into the splenic vein. So that is again, I'll be concerned in that scenario. And obviously look at the middle colic vein drainage, because sometimes the middle colic vein will be draining into the gastrocolic trunk. And so that's again a scenario where if you have to do a venous resection, so the middle colic vein drainage also will get affected in those patients. So these are the things which will decide about, in addition to portal vein reconstruction, do I need to reconstruct any other veins? So all these factors play an important role.
I think the highlight is that look for the signs of portal hypertension, which is local because of obstruction. The size of the tumor, you just heard the previous lecture when it comes to the SMA first approach or the supracolic dissection versus the infracolic dissection. All these approaches may be a combination that you will require, especially in cases where there is vein and or arterial abutment. So you may not be able to do the things which you normally do in the supracolic compartment. You may have to do it in the infracolic compartment near the ligament of Treitz. Your anatomical knowledge may be good, the radiology may not guide you, but intraoperatively you may see a first jejunal, which yes, you can even sacrifice. But when in the slightest of doubts, not in obvious doubt, nobody divides a big vein. But in the slightest of doubts, I would play it safe and put a small bulldog, make sure that we are on the right path and then divide. Somebody would call me an extra cautious surgeon. I'm happier off to be called as an extra cautious surgeon than land up in trouble afterwards and then show my surgical skills to do troubleshooting. So approach it carefully and gradually. Every case is a new case. Okay, a little bit about arterial anatomy. Anybody else would want to take up some suggestions, inputs, please?
Yeah, arterial anatomy, apart from the accessory or the replaced right hepatic artery, I would be very much concerned when you have a CHA from the SMA, which would be coursing right through the head of the pancreas.
So he's talking about a common ciliomesenteric trunk, fairly common. It's not absolutely abnormal, just to tell everyone, yes.
And in which case your oncologic outcome may be compromised if you have a tumor involving the head. Even a near abutment of that would make dissection quite difficult.
Yes.
In which case you identify it pre-op on imaging, you may have to opt for NACT.
Yes. So I think what he's highlighting is arterial variations and anatomies are normal. Virtually every case, if you really look for it carefully with your radiologist, you will find a variation. Even if you have a common hepatic artery which is giving rise to the right and left, the course of the right and left can also be very clearly defined on a triphasic CT scan for you to be mentally prepared when you actually go into the dissection or while doing the surgery. This is standard, but the abnormal comes when you have a replaced right, not just an aberrant right, and you will also have a situation where there is abnormal ciliomesenteric trunk, and you will also have situations with large tumors where maybe only the SMA is abutted because the mesopancreas is going around the superior mesenteric vein, behind the superior mesenteric vein, to the right of the artery, or even posterior and to the left of the artery. You can get varying degrees of uncinate process and mesopancreas which is extending to the left. So these factors will also have to be kept in mind when you study your arterial anatomy. I'm going to just play simple things which have been already perhaps done in greater detail yesterday, but this is what I would do when I am consulting a patient in Tata on a day-to-day basis. So what I've done, please. Yes, IPDA anomalies will always be there, and this is where I think our SMA first approach is going to be making a big difference. And that's another point to be highlighted, that be aware of this in your mind. After you are aware of this in your mind, the next thing I do is to see the scan myself. Do not study radiology reports before you get biased. I always see the scans myself and then study the radiology reports. So here is the first video. This is not an exam, this is just to share with you what I learn along the practice. Dilated veins, stent seen, that's the main portal vein. I come from top to down, thin cut, triphasic CT scan, and here I already see a replaced right hepatic artery. And then you will start seeing as you come down that this is the SMV, the SMA relation, the tumor relation. Some contact maybe some contact, but otherwise when I come further inferiorly, you are going to see the first jejunal, not the vein as he called the trunk. Am I right, Kalai? This is the trunk you are referring to. So this is what I want to see, and this is what I would largely term. Any thoughts about this scan? How does this scan look to you? I know it's brief, but anything abnormal that you feel in this scan, or largely you are okay with this?
It looks,
yeah,
except
so
for the replace right.
Exactly. So we are just aware of a variation, but there is no other problem in this case. Let's look at the other scan. On the right side, please. On the right side, you will also see the other scan where you see the right hepatic, the common bile duct, the common hepatic, the splenic origin, the flying bird, the splenic vein. So the triphasic scan is extremely important, where you periodically stop, pause, understand every single cut so that you are prepared. Now here I see that there is a compromise or a compression or an involvement of the SMV. Immediately my antenna is out, that I'm dealing with a bulky situation, an inflammatory situation, or a situation where I may have to do something more than a conventional simple Whipple resection. Any thoughts on this particular scan which I showed you? Any one of you again?
Basically, I'll be concerned about the site of involvement.
Correct.
Where it is close to the first jejunal trunk. Because
exactly.
The SMV involvement, especially close to first jejunal trunk, is technically more challenging.
Yes, as you go more and more inferiorly, there is a problem of the caliber, there is a problem of multiple anastomosis, and that's why, if you know, one of the criteria for unresectability is that there is lack of available vein. So artery may not be involved, but this also becomes locally advanced if you have a vein which you just can't reconstruct, especially from the inferior side, unless you have very good collaterals. Fine. The other bit is, this is resectable, the left side one. This is borderline resectable as per the venous phase. Do not stop there. Go for the arterial one as well. And again, I will show you a normal scan of an arterial imaging. So there are a number of times that one would, if you have doubts, repeat a scan at your center if you are comfortable with your radiologist, or if you feel that a good quality scan is not done outside. If you don't have a good CD to load on your system from the radiology center, you need one, because you can't just have some plates and plan a vein resection. You know, something which I learned from my father, Dr. Philip Augustine mentioned about him yesterday. When you fail to plan, you plan to fail. So best is to plan well in your mind and on the scans. So this is a normal anatomy, and this is a patient who would directly come on the operation table, and we are 99.9% sure there is going to be no vascular resection in this case. Now let's look at the other picture. And in this picture, you will see the same patient, by the way, the previous patient with the CT scan of the borderline resectable. Same patient, it's the arterial phase. The same structures initially seen as you come down, the flying bird seen in a slightly different cut, but again there, and then you are further coming down. So I'm always taking a pause in between, highlighting to you the relationship of the tumor with the vein and abutment and all involvement of the artery. And then we further keep on coming down till we come down to the inferior aspect, and we are absolutely clear as to what we are dealing with. Now, on this background, what other information, Kalai or any one of you want? One is the location, the relationship to the first jejunal, he said. Any other information you want, especially for the borderline resectable scan on the right side? As I said, this is resectable and this is borderline resectable. Anything else you want to know from the radiologist after you have seen this?
How much is the arterial involvement? That is what we have carefully look for.
Exactly.
How much is it more than 180 degree, or is there already a stenosis?
Yeah.
Other than the aberrant vessels we are looking
So see how the thought process is flowing. You won't even believe that I have not even shared these slides with them. But when you plan, if an expert is there, we are thinking along the same lines. So see the next slide that I have put up. This was one of our first series of only 12 patients of some disease which was often considered before 2007 as locally advanced. And then we started discovering where 7 patients of adenocarcinoma and 5 of non-adenocarcinomas underwent some sort of vascular resection. The second author is a radiologist, and the highlight is only one. We realized you can't say there is vein involvement, artery involvement. Look at 3 things. Look at length of contact and location, as Kalai mentioned. Then you have had the other expert telling us about how much is the contact. So the circumferential contact or the degree of contact. You can divide it 90 degrees, 180 degrees, more than 180, 360, etc. You can also get venous deformity, something which has been highlighted by Nakao long ago. Nothing original, but very clearly shown by him. And for that understanding, we must also know that more the circumferential contact, and the minute there is pinching or venous deformity or something, you know that you are dealing with a more complex situation. Anything else you want to add?
Thrombosis also. Is there any thrombosis already that is
fine? So I think these are the factors that you want to see when you study a scan with a possible vein resection. Another example, you don't have to necessarily follow this, but when you study your scans, do keep in mind such things highlighted by Nakao and another publication. That complete encasement is going to perhaps give rise to collaterals, and then you need to also study the collaterals as to how they are going and where they are going, so that when you come on the operation table, you have a situation where you clearly understand how you're going to handle this. So you can have a normal situation like 1, or there is just a little bit of indentation 2. When Adarsh sir was asking about would you do a borderline resectable, some of these cases between 2 and 3 would be deemed as borderline resectable. But if the CA19-9 is normal, surgeon is experienced, it's a small tumor, you can do upfront resection. There is no evidence that just by classification this is BRPC, but oncologically this is resectable disease. So that's where the answer may be of neoadjuvant comes in. Moving on further, it gets worse to grade 5, where you see that collaterals come. Remember, you can do a great surgical job in grade 5, but also do remember that the prognosis in these patients is declining gradually. So in whom to do how much despite your expertise is something which is to be left to the experts and individual surgeons and their expertise. Another point, do you agree with this statement? Any thoughts to these from any one of our experts? So that's where the dilemma comes, that how do you know intraoperatively or preoperatively as to what is the chance that the vein is actually involved or there is desmoplasia. Admittedly, there is neoadjuvant therapy for 70, 80, 90% of these patients before when you plan a vascular resection nowadays. And so admittedly, you will get a fair number of R0 resections. But an important point as a surgeon that I wish to emphasize here is that if there is a doubt, do not discuss this theory on the operation table. This is your one-time and one-time chance. So if you do a few over resections which are safe, and if you have 30-40% no disease, it's fine. You have not committed a crime. But I think it is bad that after neoadjuvant, if you do a divestment of the vein and that comes as R1 positive, then perhaps you have done something lesser for the patient than what you could have when on the operation table. These are pure surgical decisions, and these are individual surgeon based decisions on table. We will sometimes be right, we will sometimes take wrong decisions, or sometimes we will intentionally end up with an R1 that's also justified based on the ABC classification of what kind of patient you're offering. So this is information. More the involvement, be more certain that tumor is involved. Less the involvement, sometimes the tumor may not be involving, but take a decision on table, and we will share some thoughts with you. Now comes a case. So this is a case, and again, any one of our experts, please take it up. Hypodense mass in the head of the, there are no videos here. These are just so that we keep in time and yet have enough time for discussion. Mass in the head of the pancreas, contour irregularity at the junction. As you can see, splenoportal, SMA is fine, renal vein is fine. Tumor is otherwise localized, dilated bile duct, dilated main pancreatic duct. How would you approach this?
So the, we need to now plan with respect to what about the CA99 level in this case?
It's all fine. It's all okay. It's not 500, nothing. This is the radiology. What do my 4 experts want to do in this case?
Neoadjuvant?
Okay.
Neoadjuvant chemotherapy.
Yeah, fine. Neoadjuvant. Okay. All 4 of you are on the side. So you see, there is surgical maturity. There is no expertise issue here. There is some involvement, but they have preferred neoadjuvant. Fine. Then, next. This is post neoadjuvant. Same patient.
So in pancreatic cancer, post neoadjuvant, what we generally see is we don't see a dramatic response as in esophagus or rectum.
Yeah.
For us, the stable disease on imaging.
Yeah.
So look, it's considered as a response.
Fine. So now what next? This is your patient. What do you want to do?
So now we go ahead with the resection.
Okay. Any doubts about requiring a vascular resection?
So in this case, we will be requiring portal vein resection.
Fine. So I think the surgeon has looked at his pre-operative or pre-chemotherapy scans. At that time, there was definite irregularity. I know I'm not sharing videos for constraints of time, but he's prepared for a vascular resection in his mind. So when Ramesh sir says that planning and execution, planning begins when you start consulting the patient. It doesn't begin the day before surgery or on the operation table. Just to emphasize that. How will you plan this case, the scans? I have put up some points, and all of you, one after the other, please take up the points on which you want to make a comment or two. Let's discuss these points for the next 3 to 5 minutes, all of you.
Yeah, so whenever there is a venous resection is required, the first thing we need to keep in mind is the portion of the tumor which is stuck to the vein. So we need to dissect the rest of the stack, which means you are generally follow the, or I would tell the artery first approach in all these patients, because the uncinate has to be completely dissected off the SMA, so that the portion which is stuck to the vein is dissected last. The reason is because the moment you clamp the vein, then the countdown starts. So you should be ready with resection. So it should not happen that we...
Point well taken.
Yes.
Hanging the vein division and resection anastomosis is the last step. Everything else is done. Great. Something else? Yes, sir.
I will also see on the imaging the extent of venous resection needed, so that I can plan for if a graft is required or not.
Yes.
If a graft is required, my preference is left renal vein. Then I will see the anatomy, see that the left renal vein is going behind the aorta or in front of the aorta. If it is in front of the aorta, it's easier to take the graft.
Yeah. So the other question is, based on your scan, do you keep vein grafts ready
both patient grafts
No,
and
on table only I assess, but I will plan for it actually.
Sure.
So
You plan in
if
your
somebody,
mind,
if
very
some-
important point, that in case he is going to require a segmental resection, he already knows the other anatomy and the
if,
veins that he would like to
somebody-
harvest.
If somebody is planning for a left jugular vein, neck
Yeah.
should be prepared as well.
Exactly. So again, it's a part of planning pre-operatively, but also have the other grafts. I don't know, Gore-Tex, whatever you want to use, have it in the OT, couple of these always ready. You never know when you will be found out. You never know when your CT scan once in a while will not guide you as well as you think it has, and on table you have to take a bigger resection or undertake a bigger resection. So don't be caught out, be prepared for it. And again, as he said, prepare for the anatomy and the part as well.
Some other small tips is whenever we plan for resection, generally, I mean, we usually don't do that, but in these cases, don't try to go towards a splenic flexure. Keep those collaterals intact. So that is something which we always keep in mind, because you always have a collateral circulation in the splenic flexure which goes in through the stomach and the left gastric vein. So even when there is some problem, some prolonged, so you won't see a significant congestion
Yes,
happening.
I'm going to show a small clip of that. This has happened to me in a workshop 3 years ago in Tata only. I don't know whether you were there that day.
And another point is that most often we can anastomose directly, and if the gap is about 2 to 3 centimeters or more, only you would need a graft.
Right.
A prosthetic graft. Most often
Do
by
you have a
mobilization.
practical cutoff in your mind? 2 to 3, 3 to 4? Because there are some surgeons who say, I can do it with 5. And
Again,
I can't do it with 5. It can be done, but I can't do it with 5.
Again, it depends on the location.
Yeah.
If it is at the splenoportal junction, then resection leads redundant vein, which can be easily approximated.
Very important point he
Whereas
has
if it
highlighted
is
about
below
division.
the splenic vein confluence, approximation becomes difficult. You might end up using a graft.
So SMV resection anastomosis is different from splenoportal. The resistance offered is by the splenic vein. So you need to be prepared to even divide the vein, you will be able to get the length easy. But when you divide the splenic vein, if you have kept the gastrohepatic omentum more or less intact, including the coronary vein or the left gastric vein intact, which is draining superiorly into the portal vein, you will be able to safeguard the stomach, the spleen, everything else, even after dividing. So you won't be compelled to rejoin the splenic vein. Sometimes you will be able to rejoin, but sometimes it comes under tension and you may not. So we also have a fair bit of experience of not rejoining the splenic vein, but gaining on the length so that we are able to cover the defect and do it with a type 3, so to say, end-to-end anastomosis.
One point, it need not be always a resection.
Yes.
You could get away with some venorrhaphies and also a patch.
Excellent.
A patch is always a good thing when there is only a lateral adhesion.
Exactly, and we will discuss that also, and I'll show you some of these things. So see the number of options which are going through the minds of people for this case which I've spoken. One expert has spoken about the length cover. One expert has spoken about the location with the first jejunal. Another expert has spoken about the fact that you should be looking at the left renal option, the jugular option. I've tried to suggest that also in your OT complex you must have other grafts, size 6, size 8, size 10. If you're a transplant team or if you have a vascular center there, it's a different matter. But I work in a GI cancer unit where we have to be prepared for all this, specifically for GI and HPB, then we do it. So it all depends as to various aspects that need to be factored in. He's now spoken about a patch, which is a type 2, especially for lateral wall situation. A word about mesocaval or mesoportal bypass. I've not heard any one of you make a comment. Any experience, any thoughts? Have there been any cases where you have felt, should we do this, and then you have felt, let's not do it, or pre-operative or intraoperative?
I had not done that, but it is definitely, it may help if you want to do a proper arterial divestment.
Mm-hmm.
Because you could take away the vein away from that area. You could take the whole tumor towards the artery only, and the vein will stay to the right side.
Right. There is also another situation that there are some cases where what Dr. Kalai was talking about, that the tumor is hanging on the vein, and that's the last thing you do. That's what we would do in the vast majority of times. But you would also have certain long segment involvements with a portal cavernoma, etc. And you need a lot of time, not only to do a complete resection, but you can't even access the uncinate process
because of the sheer bulk of the tumor and the approximation of the, or the, the compression of the vein that has happened. So in these situations, if you want to have less bleeding, less discomfort on your heart and on the patient, what you can do is to put a bypass from the mesentery, temporary, to the mesocaval or even to the portal vein. It is of course not in a straight line, it is in a curved line. I've had an experience of 2 or 3 cases where you put it above, so now you have re-established, so to say, the flow back from the bowel to the liver. The surgery does become stress-free. Now you take your time, anatomy, difficulty, divestment, artery, planes, change the sequence of your resection, etc. This is of course extreme, uncommon, but you require an experienced team also. You can't just be doing this alone. You need a first assistant, a second assistant, and an anesthetist, everything which is queued for doing something like this. Any specific message for the younger people as regards instrumentation, use of operating loops, any philosophical but practical philosophical comments for the students?
Yeah, you need to, familiar with usage of vascular instruments, Castro VA, and operating loop, I think more or less should be considered as mandatory if you are going to do this.
Fine.
Because
even for vein or for artery? Even for vein?
It's preferable, sir.
Okay. No, I'm just being provocative. I'm just asking you. You have to tell whatever you do. So all of you use an operating loop for a vein also. A standard portal vein also you would do with a loop.
Yes.
Okay, fine. Any other thoughts, comments at this point before we go further? Yes, they are all avoiding. I don't know why. Maybe
Clamping
they have not
time,
done all these procedures.
Should be ideally below 20-25 minutes. The clamping time should be ideally 20-25 minutes or less.
Yeah.
And then another important thing is one should be as short as possible. And orientation sutures should be always used on the
We'll come
vein.
to the technicalities. Yes, sure. 20-25 minutes.
We can, probably you can go even up to 45 minutes. You have the control of SMA. You can clamp the SMA also. Then it can actually extend another 15-20 minutes without significant congestion.
Yeah. Fine. Also beware that the instrumentation that you use, if you are in an expert unit which is regularly doing vascular work, transplant work, it's fine. But if you are not, and if you are occasionally doing a vascular resection, make sure that your vascular clamps and your bulldogs are really high quality. They should be more expensive than the things in your living room and in your bedroom, because that's what you will finally enjoy the most. I'm not joking, seriously. Exactly, and then you need a good quality bulldog, but also beware that Indians, a large number of them have got bad blood vessels. So also think twice, comorbidities, age of the patient, and whether you want to put a clamp on the SMA or not. But you should be prepared for it. Okay, heparin, you give systemic heparin. Okay, how many of you are doing this?
It's probably not essential, maybe used.
Yeah, we are not doing it, to be very honest. We are not giving systemic.
Before we put a clamp on the portal.
Yeah, sure. No, I'm going to give them 15 minutes for pure discussion as well. Yeah, sure. How many of you give heparin? Introp. For a vein resection also, you just give a IV heparin? Vein resection, okay, fine. No, arterial resection, I understand what you're talking about. But here we are talking of arterial clamping for a period of time when you're doing a vein resection. That's what I'm discussing. For that, do you do heparin, systemic heparin? A vein resection. But if the vein resection is little longer duration clamping, you have to clamp the SMA if you want to. For that also you give IV heparin?
Then you have to give actually.
Sure, I get the point. So you give even for a pure vein resection. Okay. So
That's
I don't
basically-
give,
yes,
just to tell you.
I think the logic is because you are clamping, so minimize the thrombosis in
Sure.
the single dose.
Dosage of heparin?
80 units per kg.
3,000 units.
Okay.
That's what roughly 80 units per kg is.
Lot of variation. Is that so? Or are we talking the same language?
No, the dose roughly comes in that range.
Low molecular weight heparin? No. Okay. I'm just clarifying everything. Okay. Fine. Okay. No difference. No difference.
No,
It's
always
okay.
you need biliary drainage if you're planning vascular resection.
No, biliary drainage meaning I suppose that in this case, all these issues are addressed and now you're doing a vein resection, which is what I'm discussing. Is that what you're referring to? Because the livers in these patients are already damaged either with folfirinox or whatever. They have already been drained by a short metal stent for 2 months, 2.5 months. You have got your 4, 6, 8 cycles of folfirinox and then come on table. So I'm taking the baseline that, there is no bad cholestasis, jaundice, but the liver is already bad. The liver is compromised already. It's damaged. That we have to accept. And all the more, that's why the clamping time should be kept the least. That's one statement.
I think it has to be reinforced that when you're planning a vascular resection, venous resection, you need biliary drainage.
Yeah.
That is one of the indications for a biliary.
That's standard. And the other thing is sometimes you may get a vein involvement, say a lower CBD cholangio, a vein involvement with a common hepatic artery involvement at the same location. Any different strategies? You are having a cholestatic liver, you have a liver which is affected. You don't want blood supply to the liver of both the vein and the artery to be compromised. How would you sequence your surgery?
So, in that scenario,
You made me ask this question, but it was the perfect time. It fell in my lap. So
no, these are the cases where we use a mesoportal bypass.
Okay.
So that you have the perfusion going on. In case if it is not done, so generally the arterial anastomosis takes time.
Yeah.
So the venous is done first, and then the arterial anastomosis.
So what we do is we try to get the artery out of the way early because the specimen resection also becomes easier with the vein. So what we would do is if we are not doing it ourselves, we'll get the vascular surgeon in early. Distal dissection, proximal dissection, decide on the need for a graft versus a primary anastomosis and wash out. Let the surgeon reperfuse the liver immediately within 10 minutes, 15 minutes, whatever. And then we continue our surgery and do that. So we are not doing a mesocaval shunt, but that's another indication where again, if it's a difficult one, a long segment one involvement, you can't mobilize everything, then you might be able to consider doing a mesocaval shunt as well. But
mesoportal.
Mesoportal, sorry. Fine, let's go ahead. I don't need to emphasize this, that if you are planning vein resections, you should be comfortable with all these aspects of surgery. We discussed a lot since morning. There is nothing to discuss. Supracholic, infracholic, swinging the artery to the right, being in the mesopancreas, defining the anatomy. All these are standard steps. The more you do standard Whipples well, the easier you will finally do when it comes to your first vein resection and then your 10th vein resection and then your 100th. The last picture here is the work of Yi Miao. He was here in 2011. I don't know. I'm sure many of you were there. But the subadventitial dissection is a plane which is deeper than the LV3 plane, which we have discussed since morning. Be aware of these things which should be there in the technical armamentarium of an expert surgeon so that you can deal with it. Dividing the uncinate first is important when you want the tumor to be hanging only on the vein. But that depends on the location of tumor, inflammation, size of the uncinate, ability to retract, etc. So that case is where I show you what we have done. The artery is looped, bile duct is divided, SMV is under control, splenic vein is under control, neck is divided. This is the area you can see even the whitish tissue here. So this is where the chance that this can be desmoplasia, cancer always there. But remember, what you see anteriorly is not enough, both on the CT and intraoperatively. The rest of the uncinate is hanging and taken off the SMA. But here, there is the triangle cleared, but there is disease behind also. So the plan is that if you look at the rest of the vein here, 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 it's different from what you see here. Can you strip it off and be right 30%, 40% of the times? You may be right, but 30-40% of the times. Other times you are ending up with an R1. So be prepared for these situations where you would do a simple standard anastomosis, an easier one because the vein and the two things come up together. So this is an easy tension-free anastomosis, 4 types of vein anastomosis. Yes? Yeah. Correct. So the SMV is below and the portal vein is above. The in-between one is where you perhaps require a graft. That's where the left. So make a rough roadmap as to what suits your comfort level and that you are able to do and that you can do all these. Uncommon for us to do a type 1. Beware of trying to narrow down the vein thinking that I'll put a side clamp. I had not planned for it and then it becomes a narrowed one. It's not worth it. If you get caught out and if you have not done this, best is to buy a little bit time, get an expert surgeon from anywhere on the table if you can, or be prepared for putting a patch where you will be able to correct this constriction which may happen if you put a side clamp. So actually we do very few type 1s. We do some type 2s and we do most type 3s and a few type 4s in our practice of pancreas cancer. A small example, apologies, this is on the mobile telephone, but it is a incidental finding of a neuroendocrine tumor. My colleague recently, Vikram Chaudhary, was doing this. You see a left-handed surgeon, and that's where there was a small involvement of the abutment of the specimen with that of the vein at a very small segment. And this was a young lady recently we have done, where it was just a question of getting a clamp. The loop is there. We have not prepared for anything else. But the closure is not along the length. The closure is obviously like this. And then you are able to take a running suture of 5-0 or 6-0 proline. If the vein is a good wide one, I use a 17 millimeter needle. But you can also use a 13 millimeter needle of a 5-0 proline. Some heparin saline drops over there locally as long as it's straight. And then you are able to do a type 1 anastomosis. No patch, no nothing. This is incidentally discovered on table. We knew it was close to the vein, but this was a neuroendocrine SPEN kind of a tumor in a young lady. But then finally we realized that it is no big deal and everything is fine. So this is a type 1. Now this is a picture where you see that's the patch I'm referring to. Safi Docmac made it very popular since 2007. And then you can easily take the peritoneal graft. So if you are caught out, you don't want to do a vein resection, etc. Do you use a patch or and peritoneal patch?
Peritoneum.
A word about how would you harvest the peritoneal patch anatomically? People to know which side, how, and how do you take it?
So you can actually use the falciform ligament also. Sir.
Okay.
So that is in fact much more easier.
Okay.
So otherwise you can take from the subdiaphragmatic.
Okay.
Obviously we have to.
I just take it from the end of the wound actually, from the side of the wound. You just take the peritoneum and the transversus is right there in front of you. So you just have to, the isolation mop is put aside and then we spend a little time in the abdominal wall and then we are able to get a bigger patch. Peritoneum with the posterior rectus sheath, that's it. That is kind of giving you a little bit of a scaffolding, but the peritoneal side is the one which is on the inner side of the portal vein when you do the anastomosis.
Yeah, that's actually important because the one problem with taking falciform is very difficult to handle.
Yes.
Because thin and
then you handle it and then you don't have to cover it, you don't have anything to cover your GDA also. I know your GDAs don't bleed, but I cover it with I'm pulling your leg. So now this is a case which I have done and here we will share a video with you. You can see the vascular clamps, the splenic vein is also taken care of. We have put this out on Twitter also. My colleague Manish Bandare assisting me and then only a side wall as was mentioned by our expert here. See, this is the posterior part. This is not the full segment resection, which also I'm going to show you at the end. We still have a good 19 minutes and we will have enough time for question answers also. Now this, trying to close it primarily can be tempting, but never do that. And we just felt that we would not be worthwhile. So that's the peritoneal patch which comes and you just do it like a standard anastomosis. You just have to go around it and make sure that you can do it. And there is enough time. If you have planned it before and finally put a clamp, all this is done in 12 to 15 minutes of clamping time. So good vision, fine surgical instruments, 5060. do not puncture these tissues again and again. So before you puncture into the vein or in the peritoneal patch, make sure that you want to puncture it exactly where you want it. Use the curve of the needle as you would do for any fine dissection surgery or as with any good surgery. The same principles apply here. It's all about remembering Halsted and doing the right things. And then you have that patch in place, and it looks just like a vein, kind of integrates. We've not had problems with patches, and they are locally just there available. Before we discuss type 3 vein resection, I want to go ahead. This we will keep it just as a video when we are having our discussion. We have a case of a subadventitial dissection, but let's look at this case first. So a couple of videos which we will finish within these 17 minutes remaining. Please, your thoughts and your suggestions to this tumor. Chemotherapy has been given, body neck tumor, celiac axis going down.
Body tumor encasing the celiac axis.
Yes, yes.
So if you're planning a distal pancreatomy with celiac axis resection, I'll be interested in seeing the anatomy of the GDA.
Yes.
And intraop as well, you do should look at the GDA.
Yes.
And of course, there is literature on ICG as well.
Yes, yes.
To have good flow into the liver. And that would, obviously this patient would have had NACT.
Yes, total neoadjuvant,
Total,
12 cycles given.
And then
originally inoperable, splenic artery gone, substantial segment of celiac gone, and if you see even the proximal hepatic artery is gone.
So you'd go for a celiac axis resection as well, distal pancreatomy celiac axis resection.
And if the GDA is doubtful, do you plan for this pre-operatively? And this patient has had 12 cycles of chemotherapy on the liver, so you can't allow too much of, fortunately vein is not involved, or maybe type 1 resection may be required at the splenoportal junction. So now in terms of sequencing, how will you plan this? If we decide that let's operate, the 5 of us together, how will we plan this operation? Yeah, the GDA is little doubtful. You have to be prepared for plan B, right? If your ICG is good, GDA is good, stomach is fine, liver is fine, easy surgery, we are all happy.
So we go for divestment.
Divestment, okay. Yeah. What about replacing the hepatic artery? Because chemo is complete, tumor marker is fine, patient's ECOG is 0. Is there a chance to offer this resection, or say this is PDAC, leave them alone, they all die anyway?
I'm not sure about the length of the hepatic artery to get segment to.
This is the discussion which should come up between the 4 of you for them to know how your mind works.
We can use as a venous vein graph if there is a
okay.
On the hepatic artery.
Any other thoughts?
You'll have to do a direct implant to the aorta by a graft.
Correct. How many of you are used to working on the aorta by a graft? I am not. I get a vascular surgeon to do this.
Your vascular help will be required.
Okay, so you have to plan a vascular surgeon. Somebody is saying a saphenous vein, very good option. We are all hoping that GDA is working fine, and that's okay. Any thoughts about need for a gastrectomy? May. So we will. Why do you say so?
No, not always.
Why? The GDA will supply, the right gastric will supply.
Not total, maybe
GDA is
subtotal.
there.
GDA is there. GDA gives off the right gastroepiploid. No, even when the GDA is okay, it's not completely compromised. Then it is different story. Here we are saying the GDA has to take the responsibility of supplying the liver and also the stomach. And intraoperatively, you have to deal with the stomach which is looking okay, but after 6 hours of surgery, it looks a little leathery, but it's okay. It's not blue-black. That is easy. No rocket science. Compromise bowel resect. Sorry? ICG.
Stomach is a problem if you have a sleeve resection on stomach.
Yeah.
That submucosal supply is gone, then the proximal stomach you can get.
I like your theory, but 37% of patients with apparently well-preserved blood supply get massive gastric problems. So do you need venous problems and even arterial supply? Because You might be having comorbidities, you might be having diabetes, you might be having a liver where it requires blood supply from the GDA. So the assessment can go wrong. That's what is shown by data, that nearly 37% of patients can get massive complications of gastric ischemia, venous and otherwise, and more often in the fundus, because the blood supply distally is better by the right gastroepiploic and right gastric, but the blood supply is not helping you enough for the fundus. You've done a celiac and splenic and everything is out. So any thoughts about a gastrectomy to be added to these patients, and would you counsel them accordingly?
No, we should keep that option, and it has to be explained.
Yeah.
The only thing is, it need not be a complete gastrectomy. You can actually preserve the portion of the stomach. So
another important point, you need not go up to the GE junction. You can keep a cuff so that the blood supply is more from the esophageal side, and you can hope again that you would get an easier anastomosis lower down. Sometimes you may have to do a subtotal gastrectomy, and many times we won't, but we would keep these patients under observation, and if required, after 2 weeks or so, we might even do an upper GI endoscopy to make sure there are no ulcers developing. This is something which I have learned after one bitter and a difficult experience where we've lost a patient who has gone home, and then 2.5 months later has come up with a perforation and a gastric ulcer for a PDAC. With a celiac axis resection, with a reconstruction. And then I ended up studying more and more to realize that this is a serious problem. 1 in 3 cases can have gastric ischemia.
Sir, in case you are planning a celiac axis excision,
yes,
and you feel that the GDA is not very good preoperatively, can you embolize the common hepatic artery and...
Don't ask me, my job is moderation.
Can you embolize the common hepatic artery before the GDA so that the collateralization is better? And you are waiting in that 2-3 months chemotherapy.
That is actually a described technique. In fact, they mentioned like when you embolize, the liver in fact gets supply through the phrenic, and the supply through the phrenic does increase. The only technical challenge is we should make sure that embolization is done proximal to the GDA. Sometimes the process of embolization, if this embolic material slips, then it actually goes distal to the GDA and makes it more complicated. That is the only limitation. Otherwise, it's a good option. It's been described also.
It is described, it's an option, but it's also an inconsistent result giver. It doesn't always give you the desired result which you and I seek. So we can't be fully dependent. What I'm trying to emphasize the point is that should you decide to do resection of some of these cases, you should be prepared for a complete arterial reconstruction to the liver, and you should be prepared for a possibility of even a total gastrectomy. Otherwise, you can get caught out looking only at the local aspect of the tumor. The videos are there, but I don't have much time, but we will show you. They will be around, and Ramesh sir has told me we can keep it playing somewhere. But this is the celiac stump in this case. Another area to note is that the left gastric artery is not simultaneously always coming off the common hepatic and splenic. Actually, it comes a little bit more proximal or above. So what we have managed to do in this very case is that we have divested. Now this is what we learn with the SMA, that this is the divested segment. This is the non-divested segment, let's say LV3, and then subadventitial here. And then we safeguarded it, and we have divided the celiac here. So literally you fight for millimeter to millimeter after you have done your TNT. So to say, splenic artery of course is taken, and then from the specimen we chose to harvest the distal splenic artery, and we reconstructed it. The GDA was good, the blood supply was reasonably good, but I also wanted to preserve the left gastric just because of the worry of the stomach vascularity as well. So technically many things can be done which can be a variation of what is conventionally taught to us, and you will still achieve an R0 resection. For example, this lady who is doing fine for over a year now in this kind of a resection. So principles of ramps comes in, principles of SMA first comes in, type 1 portal vein resection on the left side comes in. One word of caution, type 3 portal vein resection on the left side is not the same as type 3 portal vein resection for right-sided tumors. Beware of that, because the uncinate is intact with the patient. So a type 3 vein resection will be difficult if you are doing a neck and a body tumor. A type 3 vein resection is the commonest when you do a head resection. So You may require a graft when you are doing left side tumors, and if you have to do type 3, it may be type 4 actually with 2 anastomosis. And very often you may have to put a patch, type 2, when you have to do more than this, because then this will narrow down. We recently had a situation where we thought we have done type 1. The lady had a little difficult course in the first few days. She settled down. Fortunately, didn't anything happen, but we were worried whether we are going to cause thrombosis due to the narrowing at where we had done a type 1 instead of having done a nice type 2 anastomosis. So these are judgments.
Yeah, other important is combining portal vein resection with DP CAR also is challenging.
Exactly.
So because we might actually even injure the IPDA.
Yes, and that has to be preserved at
then,
all.
Then the whole...
Very important point, that's draining the entire stomach. The coronary is going to go when you operate here. So your right gastroepiploic vein draining into the portal vein is going to be very important. Also the sequence of clamping is important. So once you have isolated, taped and looped everything, take a breather, discuss with your team on table the sequence of who is going to do what so that nothing goes wrong. Then it's a very peaceful activity, like a very structured, dogmatic approach, but it helps for the whole team to think along the same line. So here we have an interposition graft of the splenic artery. The liver is reperfused. Look at the quality of the liver, amount of chemotherapy given. And then we have closed with our hand like a fish mouth technique for the pancreatic neck. GDA is preserved. No problems for such patients. So it's a modified procedure. Before I go to the videos and some questions, we already discussed this, a good update for those who want to study in great details. I think this is an excellent update from Neoptolemus, who's one of the leaders as far as chemotherapy and trials in pancreas cancer is concerned. So this would be a good paper for those who want to study. And this is the present and the future in pancreatology for pancreatic cancer. That the small blue of 23 is going to become a bigger blue. So just because you are in precision oncology and better chemo and better radio, do not relax. In fact, we have more work to do and more difficult work to do in the next 10 to 20 years, the way I look at it. Thank you. I'll stop here, but I think we want questions. And I'll anyway play a video of a type 3, and we still have a few minutes. Am I keeping within time, sir? Where is the boss? Boss has gone away. Fine, okay. We'll play some videos which are 8 minutes, etc. It's not much. So we'll just show you a case of a divestment, but please be ready with your questions. So this was a 56-year-old lady, ECOG 1, jaundice, stented, EUSFNA, adeno, mass involving portal confluence, SMV. And you see the dilated duct, so easy future pancreas anastomosis, replaced right, and then you go down and then you see the involvement of the tumor going behind the vein, less than 180-degree contact with the artery. And here you see the collateral as well, the prominent gastroepiploic. The tumor is seen here again, and this is post-neoadjuvant. Tumor still there, but no worsening as such, maybe a little bit less. This is the plan. Be prepared for an arterial. See the radiotherapy impact. Camera is on the left from the first assistant shoulder. Surgeon is operating on the right. SMA is looped. You can loop it supracholic, infracholic based on anatomy, inflammation, convenience, comfort, obesity, so many factors which contribute to this. So now we have divided the neck early in this case. And now we have gone to behind the vein. This is what I mean, Kalai, that we can do LV2 or sometimes even subadventitial by the LV1 approach, so to say. That then comes, be ready for a disaster. So you need to be able to clamp the artery above and below. And this is, the radiotherapy does help. Uncommon cases, not routinely done by us. But yes, in every case here or there, when you require a degree of divestment, you can do it. You need to understand that paper of Chris Wolfgang and Yi Miao about the halo sign and the string sign to decide where you are. Now here, my colleague spoke about safeguarding the artery and oncology clearance. This is what it comes to, that you loop all the blood vessels, everything is bared, and you are still able to safeguard the artery and get it out. And the chemo radio works. So surgeons have to do a good job because yes, there are 5 lymph nodes positive. So long-term prognosis is a question mark. But as far as the classification is concerned, this is T1C, N2 and M0, and then they continue the remaining chemo. So a case like this, would I do an arterial resection? I would be prepared as a poor second option, but if only arterial resection is there, I don't want to do an arterial resection. I rather back off for an SMA. That's my opinion. What would you do?
Arterial resection has been found to have poor oncological results overall.
Yes, exactly.
And probably the same can be achieved with divestment with less morbidity.
Yes, yes.
And another point is, do you need to transect the pancreas more on the left side if you're planning divestment?
Sometimes yes. Again, it depends on the kind of bulkiness of the uncinate, the inflammation and the approach. Sometimes I'm able to approach the uncinate from the transmesocolic plane. The vein is here and I'm able to go straight down. The vena cava and the left renal vein is already exposed and I'm able to go. Sometimes it's unyielding. The mass is head going more to the left. Then of course I need to go to the left more. I need to mobilize the pancreas to the left more. So I think it changes from case to case, location to location. Yeah. Any other thoughts?
We'll all plan for arterial divestment, but if we find that during surgery, if there is some evidence of infiltration into the media,
yeah,
or you can't achieve,
yeah,
you could get a frozen section, but to achieve a clearance sometimes. So always vascular help should be there whenever you're planning for a divestment only.
Very important point. You can easily open the artery at this situation and you will have to counsel these patients differently because you will be in hindsight doing an unintended arterial resection, which was not your goal. Your goal was divestment, but you can land in trouble. And you can also have situations where we have tried for 2 hours, 2.5 hours, and then felt that we are overdoing it and we might run into trouble and it's not worthwhile doing an arterial resection and back out. This is also an honest assessment where patients like these are told before that the chance of unresectability after a trial of 2.5 hours of dissection is yet about 30-40% that we may not be able to do it. So what I have shown you is what is technically possible in a well-selected case. This is not a daily occurrence what you saw in terms of a subadventitial dissection. Fine, this is the last video now which we can put up. We showed you type 1, we showed you type 2 as a patch, a peritoneal patch preparation, and now the standard type 3. It's a more standard type 3. I think today's engagement has made me convinced I need to prepare a type 3 or type 4 with a vein involvement, but this is a SMV involvement, but with a larger uncinate process tumor where at the beginning we had the discussion that the tumor should be hanging on the vein, but we could not make it hang on the vein. And there are 2 or 3 times in a workshop that I've been slightly caught out, and this was 2 years ago in Tata at our annual OncoSurge meeting. So I'll play this video of a vein resection type 3. The usual steps happen in the beginning. The Cocker maneuver, camera is over my shoulder on the right side. Left renal vein is getting exposed. You can see the cava, and then you want to expose the SMA and 14A lymph nodes. So once you have done, we will wind up soon in 5 minutes. The usual steps which we don't have to highlight to you just now, getting the stomach away, getting into the lesser sac. You can get the gastroepiploics, making sure that that's the gastrocolic trunk. As Kalai said, it will be variable based on the uncinate. Here I prefer more of ties in such a situation because I know my clamps are also going to come afterwards. Otherwise, I'm normally a clip person. Now the SMA first approach to the left of the vein. SMA was not involved in this case. This was a planned vein resection. So you can go between the vein and the artery. So you are effectively doing your uncinate process dissection. Inferiorly vein is available. And this looks like a tiny one. But actually the disease is more behind. So that's posterior approach. So though we have defined potentially the length, we are still assessing things. Then you do the standard rest of the steps, which is easy. get 8A, 8P, define common hepatic, gastroduodenal, get the gallbladder down, divide the non-dilated common bile duct, do the lymphadenectomy, etc. You get more traction once you get the bile duct out. We won't discuss whether we have divided the bile duct above or below the cystic duct. That's for convenience, out of the way now, for now. And then we close the lower end of the bile duct. In other words, we move towards making the tumor hang exactly on the area of concern. So GDA fine, also taken, it's clamped, it's checked, all that is fine, no celiac steel, all that is done. And then we are now coming to the neck of the pancreas. The pancreases are hard. That's the good part of some of these difficult resection. You can use a cautery, you can use a knife. Take the usual stay sutures, make sure there is no pancreatica magna issue. You know this anatomy very well. Kalai has also made those concepts even more clear in my brain. I should thank him for that. And then get into the supracholic compartment. So here, sometimes I divide supracholic, sometimes infracholic. This case, I have divided infracholic, the limb. Now you will see that behind there will be this desmoplasia. You are wanting to gain every millimeter to make it into a safe type 3 rather than a more difficult type 4. Now this is where I realized I am unable to go behind the involvement. So I could not separate the uncinate process well from any way unless I divided the splenic vein, which I didn't want to divide. Otherwise I could have separated the uncinate from there. So that was the area, and then the uncinate was right behind and fairly bulky. So now today we had this plan that we will have to divide the vein and then do the uncinate process afterwards. Get clamps organized for orientation from 3 o'clock to 9 o'clock. One more aspect he spoke about was orientation of veins. So apply your clamps in such a way that you can do anastomosis. But I was caught out. I thought my clamp is not applied well. It is still bleeding. Can someone tell me why after clamps on both sides it is still bleeding? So it was a bulky thing, and I was not anticipating it, and then it was full. Even after the clamp and the scissor, I thought it is full and then it will collapse, and it was coming on the face. This was not enjoyable, but that's fine, that's okay. Sorry, apologies. This is not the one. And 1 second, we'll go here. Yeah, we are here again. I reapplied. I made sure. Now you require an experienced assistant. Manish is covering up for my crimes with his left index finger. And then we decided, yes, but I need to get this out of the way first. Otherwise, I'm not getting, see the bulk of the disease behind. I discovered that vein finally. I'm to the right of the SMA now. That's the divided resected vein which immediately retracts. That's the entire specimen, and I'm yet to do the complete uncinate. Little sweaty situation, but if you know that your collaterals are okay, as Kalai said, the left colon, the retroperitoneum, other blood vessels, stay calm, make sure you get your IPDA and other vessels out of the way so that the SMA clearance is complete. Otherwise, the whole exercise is a total waste of time. This took a good 15-20 minutes. The blood on the gloves is not delightful, but that's reality. And I'm glad this is not edited, this is real. And then a 5-0, but all the mobilization was done before. So the colon mobilization, making sure your alignment is okay, the same bulldog clamps. I do not take stay sutures. Just have the right instruments, and a 5-0 proline will help you, double-ended, straightforward, type 3. But yes, the anxiety was that there has been a clamping time not of 20 minutes and 13 minutes, but 40 minutes. So I had decided that if the bowel is going to be congested, we literally take a 10-15 minute break and then start the anastomosis. You don't want a congested bowel to join to everything. We did that, released it, allowed a good growth factor, so to say, and then leave a little airlock, and then clamp time was 40 minutes, yes. And look at the bowel at the end of it. If we have completely prepared everything, the clearance was fine, and then we looked at the bowel was not bad. but be prepared that this bowel can get also congested and be in trouble. I think I stop here. If there are any more comments, questions, otherwise we stop. Thank you once again to the expert panel for your inputs, which I hope has made everyone benefit. I have personally benefited from this. Thank you.
Can I ask one question?
Please, one after the other.
If the splenic vein is divided, would you reimplant it?
If sometimes it's easily possible, I would. But sometimes if it's not easily possible, I won't.
What about
you can put a graft.
What about a splenorenal shunt?
If required, but I have not had much experience of doing it honestly in these kinds of tumors. We are largely okay. The one thing I would definitely do in all these cases is to not mobilize the gastrohepatic momentum. Sometimes in a conventional Whipple, in order to make the stomach go to the left, we divide much more. Those smaller blood vessels are also a good help for carrying the blood back from the stomach to segment 2-3 of the liver.
I think generally the rule which we follow is if any one of the three veins, left gastric, splenic, IMV, if any of the one vein is preserved, no need for...
We are okay, generally, exactly. That's what I said. Splenic flexure, lack of mobilization, hopefully IMV sometimes if you have not known it. If you have known it, try to safeguard it. And the left gastric, one of these usually will be okay.
Yeah, I was just going to say that even if the LGV is patent, if the IMV is also gone, then you get isolated gastric varices. So 7 or 8 patients who had splenic vein ligation, it's almost impossible to reconnect it unless you have put a graft, because otherwise the vein has become so taut. Venu will recall your own resections.
Splenorenal shunt is an option.
That is an option, yes. Splenorenal shunt is an option, but
it will easily reach.
Yes, but would you want, on a philosophical basis, to go and join this vein which is close to tumor?
If the IMV is not preserved, better to do it, I think.
No, the question of also tumor areas, you're going to an entirely different area of the abdomen and then potentially joining a splenic vein which may have cells to the splenic vein. I don't know. I would be a little concerned about that.
I would not do it. But this is of course preferential based on, I mean, I get your point that it can be done, but we are not doing it more. There's one more area. Sometimes you don't have to actually disconnect the vein. The tumor location is such that you can remove a part of the vein, so you make a big hole there, and you have the clamps on the splenic vein, portal vein and SMV, and then you reconstruct it either with a patch or with a tangential cut and then move it down or up. And you can safeguard the splenic vein as long as it's not under tension in some cases.
There are lesions which is near the body or the neck of the pancreas, where you attempt something like a distal pancreatectomy, and you have to do something like a portal vein resection anastomosis as well. So my concern is regarding the left gastric vein. Suppose if you have, anyway the left gastric vein is gone when you do the triangle operation, or already the portal vein resection anastomosis is there. So you observe a bit of gastric congestion.
The right gastroepiploic is the secret.
The right gastroepiploic is also gone because there is a portal vein resection anastomosis there.
No, you need to place it in such a way that the right gastric vein is preserved. Otherwise, you need to drain it into a colonic vein with your microvascular surgeon. Otherwise, your stomach is in trouble, no question. So I've had a situation where you need to localize where is going to be your resection. Usually for a neck tumor, in the vast majority of cases, the involvement of the splenoportal junction is such that you are able to preserve the right gastrocolic trunk or the right gastroepiploic vein. You are able to. Now, if your disease is involving the neck and going inferiorly to the point that this vein is getting compromised, then you need to resect this vein, join this vein, and easy to reimplant the right gastroepiploic vein, which is already by now a little dilated vein because of the evolving obstruction which has happened in your case, I suppose. I have a nice picture of that also, where we have done that a large vein has been preserved, a portal vein resection is done, a triangle clearance and a left pancreatectomy.
Is the LGV reimplantation, is it an option?
Yes. A left gastric vein is defined. The Heidelberg group has published it in JSCS, The Surgeon at Work, how you can reimplant it. but you can also re-implant the right gastroepiploic vein in case it is compromised. But majority of the times we don't feel the need to re-implant the left gastric vein because your right gastroepiploic is taking care of the stomach. Do you agree with me or any different thoughts? Any different thoughts, sir?
I had 2 occasions where this has happened, severe gastric congestion. One case I reimplanted the LGB and one case subtotal gastrectomy.
Yeah, fine. So again, options to be available, decided whatever you do, buy time and do it then only. Huh? The worst thing is hope that it's okay and then close and then telephone calls in the middle of the night and then the second day and the third day, you are a wreck, your patient is a wreck and you are suboptimally done the job. So spend those 5, 6, 7, 8, 10 hours on table. That's the best thing. Yes, very uncommon, but yes, because these are not neck tumors. These are neck tumors which are already crossing over to the right, and the CT scan is already telling us that even dividing the neck is going to be a problem. Those are subtotal, it's not division anterior to the vein, it's more to the right of the vein near the GDA, etc. And those patients, you may have to offer a total gastrectomy. Game up. We can discuss afterwards. Thank you so much.
Of course, we would have been here all day because this is a subject which is very fascinating for everybody. But we have to move on. We have even bigger treats in the next hour.
Our next panel discussion is on the evolution of minimal axis in pancreatic cancer. Over to Kalesi.
Yeah, we will. So I request the esteemed panelist. I can control here, no? I have mouse is there. Control like this. Okay. No, some controlling video with this. Okay, I'll do it. Yeah, so we have Dr. Ovi Sudhe, Dr. Beju Sanadipan, Dr. Shabir Ali, Dr. Biju. I don't think anyone requires any introduction. So let's go on to the issues which we'll be discussing. So this probably will discuss some of the practical questions which comes to the mind when we talk about MIS in pancreatic before we actually go into some of the techniques. So first let me start with Dr. Beju, who has a lot of experience with MIS PD. So how you shifted from open to MIS? Like this is something which you can give as a tip to any young surgeon who wants to start MIS PD from his open experience.
Yeah, actually I was doing open BIPLs for almost 5-6 years. Since the time I started practicing GE surgery. Then not many people were doing laparoscopy BIPLs, but 3 or 5 people all over the country were doing MIS BIPLs. So predominantly it was done by Dr. Palani Velu. But by 5 years' time, I must have done nearly 80 to 100 open BIPLs. So the anatomy was so clear. Then in one of the conferences, Dr. Brace Kai came from, I think from France, is it? So he was an anatomist as well as a surgeon. So he was clearly demonstrating how a BIPL can be done in one of the conferences. And I managed to get the video. At that time, YouTube was not popular. You are not able to get the YouTube videos. So I managed to get the CD from the organizer, the unedited video. Then I saw it 100 times, and then started the next case. That was a periampullary tumor, and succeeded in completing it.
Yeah. You want to add anything, sir?
No, actually, when you move to the minimally invasive Whipple resection, you should have a very good, I think, laparoscopic, realization of the anatomy. Probably you should be doing more of the other kind of surgeries like probably distal gastrectomy, the right hemicolectomy, distal pancreatectomy. Try to dissect that at a cauterization. Should be well versed with the suturing techniques and all before moving on to the pancreatectomy. And you should have some training also, I would say, because it's shown that it needs a lot of training, a lot of experience to do a safe laparoscopic Whipple in many studies. So all these things are there before moving. And also you should have an aim, what you are doing, how many cases of pancreatectomy you will be doing in fact in a month. Or are you going to do a big change? Because it's shown that the pancreatectomy is not going to have a big change, minimally invasive or open. So what are you trying to do by doing this? So you should have a clear idea of all those things. Then you need, once in a while doing a Whipple laparoscopically is not going to do much importance.
So I think some of the important points have been highlighted. Also, if anyone wants to start off, first he has to ask himself, is my open technique standardized? So how you know that you are doing a good job in doing a Whipple? So you need to compare your outcomes. Are they matching with the benchmark outcomes? So this is one, I think, something useful for the residents to go through it, where they have defined for each of the outcomes, like what should be the, starting from the duration, but more importantly, the fistula rates, bleeding rates, what are the acceptable? So this is the acceptable range, so called as cutoff. So you need to see, is my cutoff or my outcomes are good in open before you start thinking of moving to MIS. I think that's the first thing, in addition to whatever. And also, yes, in abroad there are some centers where people go to a unit where they do only Whipples. So when they move from open to minimal invasive, they'll start off with Whipples. But in an Indian scenario where most often it's a GI training, so you have the, as Dr. Ovisu was rightly mentioning, get used to the other laparoscopic procedures before you move on to Whipples. About this learning curve, this is, you can read, there are many articles which tell this is a learning curve, 40 procedures, 50 procedures. It's good to see, learn, have an idea, but we need to remember it's unique to each surgeon. So that someone can have a learning curve of 40, some with 30, but they are only reference. Don't go by that. You decide like when you feel yourself comfortable in moving ahead with the MIS. The one other option is you can do the resection initially laparoscopically, have a planned conversion, and that conversion, don't try to, because you have done as a lap resection, don't try to do the reconstruction with a small incision, because then you will be compromising on the reconstruction and the complication increase. So do a lap resection, give a good incision to do a safe reconstruction. And probably these are some of the ways which you can, some of the practical approaches to start off MIS from the open. So once we know that MIS, we have two options, laparoscopic versus robotic. So when you have both options available to you, maybe I'll ask Dr. Ovisudi, like in your experience, what are the pros and cons with each approaches?
Yeah, robotic surgery, robotic Whipple, I think we have done in 2015 itself. And we were doing a lot of robotic surgery on Whipple, but nowadays we are not very sure whether we should proceed with robotic because of a lot of reasons, which I think we will discuss in the coming slides. But robotic, I agree that actually have a lot of ergonomics, good vision, and probably there are a lot of, and the patient surgeon's comfort. I know the surgeon's comfort is very important because by the end of the day, 7 hours surgery, if the surgeon is comfortable, I believe that the outcome also would be better. That's one point. But there are a lot of cons in robotic surgery, like the energy instruments are less in robotic. You need a very good assistant who knows what you are doing. And the thing is that robotics usually go for a single quadrant or maybe two quadrant surgery in a people. Maybe probably for the DJ mobilization, the upper jejunal mobilization will be supracholic always. So there are some constraints also in robotic pancreaticoduodenectomy. Yeah, and the cost, robotic pancreaticoduodenectomy, the cost is very high. And definitely robotic pancreaticoduodenectomy, easy to learn and teach. A robotic pancreaticoduodenectomy. Whereas in laparoscopic pancreaticoduodenectomy, you have a panoramic view of the whole of the abdomen, and you can move into any quadrant wherever you want. And your assistant need not be that technically, because you yourself can tell him what to do and all. And the table position, you can change the table position in laparoscopy. Where robotic, you can't do that. So that also would help in pancreaticoduodenectomy.
Is it because of the robot which you are using is XI?
Yeah, now new tables are available, but hasn't come to India. That's definitely the new table. New robotic tables are coming up. Might give that opportunity of changing the position of the patient later on. And the reconstruction in pancreaticoduodenectomy, that is the most important thing. Laparoscopic pancreaticoduodenectomy, the reconstruction would be a bit more difficult than robotic. Usually laparoscopic pancreaticoduodenectomy, they do single layer pancreaticojejunostomy, which has shown that it's much inferior to the two-layer pancreaticoduodenectomy anastomosis.
Yeah, I think anyone wants to add any point? Okay.
In my opinion, I feel the only surgery which has the maximum benefit in a robotic surgery is Whipple surgery, I believe, because I can't think of any other surgery that has so much of reconstruction involved. And the key advantage in robotics is reconstruction. And the main limiting factor, as we all know, in laparoscopic surgery is reconstruction. And doing a laparoscopic Whipple by an expert is definitely, I mean, we all see it and appreciate it, but I'm sure it's not replicable for at least more than 80% of people. But when it comes to robotic Whipple, the reconstruction techniques are slightly modified to suit the purpose of minimally invasive surgery. And there are centers in the East which have done more than 1,500 to 2,000 robotic Whipples. And they have all fairly standardized each technique of reconstruction. And I don't think we need to innovate anything, but what we are lacking here is the numbers. We need to have at least 20 to 25 numbers per year to replicate this and to learn this. And what we have seen and what we have experienced is everybody goes through this learning curve, and during the learning curve, it's the patient who suffers because the complication rates are high. It's just purely technical and because of our lack of expertise. And more what I always feel is most of us choose benign cases to start with for a minimally invasive surgery, which I don't think it's the right way, because when you intuitively think, the reconstruction is more difficult. And somebody with a benign surgery who should walk out of the hospital without any complications, we try to do a robotic or a laparoscopic, and they end up having more complications. And probably they are the ones who should least suffer and get out of the hospital. So we need to do what we are familiar with. That's my comment on it.
I fully agree with Biju Chandran. I think having done all these surgeries laparoscopically, I still believe that I have not done enough triangle dissection for pancreatic tumors as we are doing in open surgery. But I have seen videos, I am not a robotic surgeon, but I have seen videos of robotic surgery having this triangle dissection done meticulously, like a open surgery. But this thing, robot will help in such way, is it not?
Because I think in 2018 when at Amrita we started doing robotic Whipple. Yeah, we did the first case, but robotic Whipple we did consistently few cases during that. That's when I think Dr. Kalesa also started in JIPMA doing robotic Whipple. But what I feel is the anatomical appreciation of all these small vessels and the mesopancreas. He has divided into 3 parts of mesopancreas, especially identification of the mesojejunum, which is the 3rd part of the mesopancreas. And all that has become more better in robotics because of the magnification, stable field, and even flattening, because you do, in a robotic Whipple, you do everything supracollically. You don't go infracolic at all. Initially, when we started, I remember we used to do infracolic first laparoscopically. We divide the jejunum, do till the ligament of Treats, then leave everything, dock the robo, go supracollically. So that was, during then we didn't have a standardized technique, but now it's all very, very standardized. Everything has been clear. So I think following that is the norm.
Yeah. So I think.
Just
yes.
a point.
Okay.
I'm surprised.
Yeah, sure.
I'm Manoj. Surprised everybody is talking about dissections in robotic surgery. But what I understand as a beginner of robotic surgery, the most difficult aspect of doing a robotic surgery in a center where it starts is you must have a surgeon who is very capable of assisting you laparoscopically while your robotic procedure is going on. Because to do the suction, especially when the arms are locked, you need a person who sucks, who can put in instruments. That's a very difficult job. So you tend to convert.
True. I agree. Because in fact, actually, our department most of the times is done by residents. So I used to tell them, like, if you can assist in robotic, so you can actually easily assist in laparoscopy, because assisting in robotic is technically challenging.
And more challenging may not be such resections. More challenging will be bariatric surgery, because a person who starts on robotic, if he is not good in laparoscopy, if you have any problem in robotic in bariatric, you're gone.
Okay. So, yeah, most of the points have been covered. Some important things to remember, especially some of the disadvantage when you're starting robotic. Your team needs to be tuned. Even the staff who are there, because one potential problem which can happen in robotic is you have 2 arms, so like 3 and 4. So you are telling your staff to remove arm 3. Okay, so probably it's having one instrument, maybe for example Maryland, and you have a grasper in the another arm. So there is a chance in some of the critical steps you must be holding the portal vein with a grasper, and you want to change the Maryland. Okay, but the instrument change is done by the staff there. So there are occasions where they have taken the wrong instrument out, and if unfortunately when you are holding the portal vein and they take the wrong instrument out, then you can imagine some of the potential problem which can happen. So this all happened. It has happened in our institute. Fortunately, we are not holding any critical structures at that time, but you need to tell your staff that when you instruct them to remove a particular instrument, they have to remove that instrument, not the other one. And even the needle loss is slightly higher in robotic compared to laparoscopy, because most often your assistants remove the needle, and in a lab you can always move the camera, you can track the needle till it comes out of the trocar, but most often in robotic you don't do that. And these are some of the complications which can happen in the initial phases. You need to remember when someone is transitioning. And another common question which comes to mind, like from open to MIS, if I want to go from open to robotic directly, do I need laparoscopic experience? You need to be oriented to the anatomy, because when I've seen open directly move to robotic, the skills are not really critical. The laparoscopic skills are not critical, but the laparoscopic anatomy is critical. So you need to be familiar with that anatomy. Obviously, the skills are not that critical. Maybe if anything you want to add, otherwise. So this is the next, maybe I'll ask Dr. Shabir. So now laparoscopic and robotic Whipples are there for at least the last 2 decades, and you still don't have a strong evidence to show that it is superior compared to some other surgeries where you have good evidence to show the superiority. So what do you think as reasons?
practice over the last few years only, maybe last 1 or 2 decades. So 1 decade. So basically we have literature, we can see with this time we can only get data for the safety of the procedure. Oncological outcomes, good studies are yet to come. So regarding the safety, in the beginning itself, there are many single center experiences. People have come out with case series of minimally invasive Whipple's procedures with comparable outcomes with their open Whipples. And coming to the good quality evidence, we had from our country itself, I think Palnivelu sir himself has published randomized control trial on nearly 30 patients, but all cases been done by 1 or 2 surgeons who had a huge experience in lap surgery as well as laparoscopic Whipple's surgery before the trial. And then they have come out with a very significant improvement in the hospital stay. I think it is 7 versus 13 days, and comparable morbidity and mortality statistics with the open surgery. And again, the Padulab trial, also European, they also have proved one center. When it was done in a single center, it has shown a comparable outcomes. But being said that, when you have gone to a wider perspective, when multi-center studies have come up, especially that one which we discussed yesterday, Leopard trial, it was nearly 20 surgeons, I think, but they had a standard structured training program. They have good experience in open Whipples. They had, I think they kept 40 as the cutoff for before starting the trial, cutoff for laparoscopic Whipples. And then in the phase 1 itself, they got surgical complications leading to mortality in the phase 2 itself. But still they continued with phase 3 to look at the morbidity, thinking that it may be an accidental event. But in the third phase, they got more mortalities. But all the mortalities were unfortunately directly related to surgical complications, either intraoperative or postoperative events. And that study was prematurely terminated. And that has given a bit criticism when this minimally invasive technique, unlike any other minimally invasive surgery, when it was applied to a bigger number of surgeons, it behaved a little different. But being said that, there is a good study from China who has nearly 300 cases, I think. 300 cases, 20 surgeons, but they all had more than 100 laparoscopic Whipple's surgery done before the trial being started. So that is a big problem, like Biju has mentioned before. In our country, how many can have 100 that number to tide over the learning curve? Coming to the robotic, I think there is a good randomized trial which is showing a comparable outcome from the Heidelberg unit, I think. Yeah, they have shown a very good comparable statistics. Only complication which was slightly more in the robotic group, statistically significant, was the grade BC, clinically relevant DGE. All other parameters were comparable.
Yeah, so I think Dr. Shabir has nicely summarized the evidence. I think the first 3, most of you must be aware. This was published this year from Heidelberg. Really not very impressive, to be frank. Although the conclusion they have mentioned comparable, if you see the fistula rates are high. The reason it becomes significant because of the small sample size, but you can see here 37% in robotic compared to 21, and all the complications were almost on the higher side, although only DG became statistically significant. Again, this is highlighting because of the small number of patients included. Probably again the learning curve effect is coming into play. What we have seen, whenever it is a single center trial, those when they cross the learning curve, generally the outcomes are better. But once it becomes multi-center, more surgeons with not so much of experience, then the results are not that great. The 2 large studies which I mentioned is from the China, but again, although they mentioned that there is a statistically significant difference in hospital stay, but if you see practically it is only 1 day. And the same, another Chinese trial published this year, not in fact this month, I could not even get a full article. So this is in robotic versus open, and here the difference was 2 days. and they've reported that the outcomes are comparable. So if you have to actually summarize, during learning curve, minimal CPD is harmful. So that has been documented. And after learning curve, now if you see the two Chinese trials, they have large number of studies, large number of patients. The surgeons have almost all of them across 50. But even there, the benefit is marginal. So you don't have a significant superiority. So far, all the RCTs have focused on the short-term outcomes. None of them have focused on the long-term outcomes. The primary reason is because compared to other surgeries where the morbidity is primarily related to access, here the morbidity is related to the procedure and the complication. So if someone is going to have a pancreatic fistula, whether you are done an open or laparoscopy, the hospital stay is going to be prolonged. So if you really want to derive the benefit of minimally invasive, then we should actually select the patients who will be at low risk of pancreatic fistula and other pancreas related complications. Then you will derive the real benefit of the minimally invasive procedure. Whereas if we are doing in patients at risk of pancreatic fistula, you won't be seeing that much significant difference. So with the current evidence, if someone is telling like I won't do lap, I do open, no one can question that. It is still the standard procedure. The benefit with minimally invasive even now is only marginal. So I think that is clear. Probably that will remain even in future also. Yes.
Yeah. And to get that learning curve, you said you had to select the correct patients.
Yes.
Still you had to reach 20 patients robotic a year. And that too said that more than 250 patients you had to cross to get the proficiency to have some advantage in that 1 day, 2 day hospital stay. That was the advantage. So, and in that period, you can have a number of complications. And so you have to prepare on that. So you have to be, clearly you should know what you are doing with the people resection. You have to reassess your patients. You have to statistically analyze your patients and audit your patients, see whether you are doing good to the patients or not before proceeding.
So having said that, I mean, we know that the benefits are marginal, but you see the number of surgeons attempting or the number of minimal invasive procedures are increasing. So there are some advantages with respect to, it's good for teaching, definitely you can really teach the anatomy, and in patients who are stented, the surgical site infection is much, I would say like the severity is much less. These are some of the practical advantages what we have seen with, in addition to obviously the wound related complications. So we know that the benefits are marginal, but if you see in practice, the number of procedures are increasing. So that's why we need to focus on how to kind of do this procedure safely in minimal invasive. So probably the next half of our the panel discussion will focus on the one of the key is standardizing. So how to do that we can discuss in the next 30 minutes. So maybe I'll ask Dr. Biju, like in MIS, so we know that overall the broad steps are same, but the way you do, there are some steps which are different in MIS compared to open. So maybe I'll ask you about what are the steps which you do differently in MIS compared to open.
Yeah, as I mentioned before, lot of steps will have to be modified, especially to suit your minimally invasive surgery, whether it's laparoscopic or robotic. My experience is more with robotic, though it's not much. So in that, for example, like gallbladder, which normally you might take off initially itself in your open surgery, which is usually left in robotic surgery for the retraction. The bile duct division, which we might do early on in an open surgery, is usually done the last when it comes to robotic surgery. Approach to your SMA from the left is quite difficult and tedious in robotic surgery, which you might do it from right side because that's the angle of your operation. SMA first approach might be slightly more easier because you're having a cranial inferior view. So, your angle of the camera and the way of operating is just good enough for you to look at the SMA and do a peri-SMA good dissection. So, a lot of things and steps. When it comes to reconstruction also, similarly, a lot of things have to be modified and so as to suit the minimally invasive surgery and also the instruments we have.
Yeah. So I think most of the points have been well covered. So before we move ahead, any other comments from any of the panelists? Also from the participants, anyone, any queries at this stage?
The changes we practice routinely is that we do SMA first for all cases, not for borderline operability. All cases, even small periamp also we do SMA first. But that is the easiest method in laparoscopic surgery. And also uncinate first, because your camera is coming from down, and you will be seeing the uncinate first. So resection and straight and taking the jejunum to the right side, and then do the pancreas resection. That will be better ergonomically and.
I think more or less that's becoming standard in minimally invasive of the artery first as a routine.
Yeah. Yes. One more point which I would say is actually, when you start with the robo, you do it laparoscopically, laparoscopic resection and robotic reconstruction. So that might because the advantage on reconstruction. So laparoscopic dissection, that will give you a more clear anatomy. Later on, you can go for a full complete robotic.
That is one described, but only thing is the cost of your, especially in an Indian scenario. But that is actually the advantage is because resection, you have a lot of energy devices available for you in lap. So you use advantage of lap there, and during reconstruction, you use advantage of robot.
Particular procedure, and more importantly, when we know that these all trials haven't shown any benefit, they're not shown a superiority trial. They are trying to say that it's an equal trial, right? So, do we think that we have an obligation to tell our patients that I'm in a learning phase? Dr. Baiju might have passed that phase now, but for us, the new generation who haven't yet done or trying to get into the bandwagon, don't you think it's medical legally important? Because we don't have a very structured mentorship in India, and everybody goes out and we all feel that we are great surgeons. Isn't the cost, the burn being taken by the patient, not by the surgeon? As Dr. Biju pointed out, that learning curve is very, very significantly shown. Morbidity. If I have a father who has to go for a Whipple operation, I won't give it to anyone who is in a learning phase. But we don't tell our patients that I'm in a learning phase.
For every surgery is like that. For every surgeon is like that. For a person who is doing his first gastrectomies or maybe the early gastrectomies, probably the same thing. How many cases he has said that I am in my learning here? He has to say that. But the better way to tell the patient would be there's high chance of conversion. I'm doing a robotic surgery, but there would be a chance of conversion. Always the safety is the first thing to do. I don't know whether we are telling them truly the learning curve. I'm in the learning curve.
When we are doing an open gastrectomy, we don't have an option, Here you are doing a robotic or laparoscopy where we have an option of converting, and same applies for a donor hepatectomy for that matter. There is definitely, and whether the centers will speak or not, there's definitely more complications related to donor robotic hepatectomy, but we're still doing it. And so whether that conversation with the patient or the donor has been very frank and open and black and white, or it is just concealed under our...
I think...
like what Sir said, even I feel the same. It's with any other surgery, it's the same thing. But definitely the only way we can minimize that is to tell them that we will definitely, if there is a concern of patient safety, we will be converting it to open. It is same as when we do a SPK or simul pancreatology. We don't do so many numbers in a year. We do one or two. We don't become an super expert with that, right? The same thing applies to that as well.
when you do a pancreas 1 or 2 a year,
Yeah, so
make,
that's also
make sure that your training has been enough for
that's
many
true.
years.
Yeah.
So you are trained, you're doing less number of cases because of circumstances, not because your training is inadequate.
So here now in this scenario, the only way to circumvent this to have numbers. So numbers, when you talk about numbers, in Kerala, I don't see any institute that can have so many numbers in. So the only possibility is to have it in the government setup. Now with the RCC coming up with the new robo in Trivandrum, so I'm sure they're going to have enough number of Whipple cases lined up, and they have a robo. So they might end up hitting good number of cases. And if they can start a good training program, mentorship, then that would be a way where everybody could get trained in robotic.
Yeah.
Like what you said before, it is non-inferiority. I don't think robotic has shown any superiority, but it's just a cosmetic scar benefit. But it is definitely, if it is non-inferior, it's just like your new automatic car or an iPhone 14. It may not be that superior to your iPhone 10, but still the people are moving towards that direction. Robotic is evolving. Number of cases are increasing. Whatever we said and done.
Are you telling your patient that this is just for your cosmetic benefit?
No, I think so it's a difficult thing. I think we'll discuss it further. The reason is I think it's all depend on the individual surgeon. That's why we have shown what is the evidence, how you need to, like it is harmful learning. So we have to find ways to minimize that. So each has their own method, like doing the initially laparoscopic resection. So you cross the learning curve so that you can safely accomplish. So it's a difficult, I think probably it applies to many surgeries. So let's move on to...
Before going to that, again about this learning curve, they said there's 20 cases. It's not 20 cases per surgeon. It's 20 cases per team in the hospital. So I would say that if a person can go to this some Chinese center or somewhere where there's a large volume of cases doing robotic and have an experience there, need not be his own robotic surgeries, need not be his own laparoscopic surgeries. He's in that team. He can replicate here better. So the learning curve is a team's learning curve. It's not the individual learning.
Yeah, so now move on to the technical aspects. So first is obviously the important is port position. Although it can be variable, so I'll explain what we follow, and probably we can have, because as we are running short of time, let's move forward. So generally we divide into two phases, the initial resection and then the reconstruction. During the resection, the surgeon stands on the left side with this two as a working trocar. The camera comes from here, and the assistant trocars. So important tips is this will be more towards the subcostal and the medial, so that you have, like, you don't have actually have a triangulation with the camera here, but having this trocar here will give that kind of a triangulation effect. And these two trocars will be a bit lower because the reason is when we are doing the reconstruction, so the camera comes here, and the surgeon from here moves to in between the legs using this two as a working trocar. So the camera comes here, and this becomes the assistant trocar. So this is what we follow. I agree that there will be variations. So anyone who wants to start, you need to observe the 2-3 ways of doing with respect to the trocar position, and then you decide which is the ideal for you. Maybe a quick comment. Any difference?
Yeah, I do the trocar entirely different way. Actually, I concentrate more on the right upper quadrant. My camera will be coming from the right hypochondrium at the level of, or just below the level of umbilicus. And left to that, there will be another port for the left hand movement. And my right hand will be from the umbilicus. So above that, the symphysis sternum, below the symphysis sternum, that will be the retraction port for the gallbladder, and in between that there will be a 5 mm port. So that will be used for the hepaticogenostem anastomosis, taking the camera towards the umbilicus. Till then it will be between the legs, and I don't move to the left of the patient. So my surgery is completed from beginning to end in between legs. So my port positions will be more on the right upper quadrant than the entire abdomen.
So that's what I clearly mentioned. So each one have variations.
the reason we develop, because as I told, we start with gastrectomy, hemicolectomy. So some of the steps appears easier from left, but the point is, look at 2-3 ways, you try which is ideal for you and then follow that. But you need to standardize. Then you follow the same way in the rest of the cases. When it comes to robotic, more or less, not much difference with respect to the trocar position. Generally, we place all at the level of umbilicus. One practical tip is, if it is an obese patient, once you distant, you see the distance between Ziffy and umbilicus increases. So in that scenario, you see the way the abdomen is distended. And the summit, the abdomen gets distant like this. At the summit, you place the trocar. Don't place the sloping part of the abdomen, because then it appears as if you are climbing up and reaching the pancreas. So that is one practical tip you need to remember, especially in the obese patients. Otherwise, all at the level of umbilicus, camera to the left, and then when we do the uncinate, then the camera comes here, and you do this, all this becomes working trocars. And
I think SI, the port position is
yes, yes, this is for the XI. Yes. And if you want to use energy device, now you have to remember that harmonic in robotic, as any other, so it is non-articulating. So in that scenario, if you want to use harmonic, especially for the uncinate dissection, then you want the harmonic to come from umbilicus, because it will be in line along the SMA. So the technical tip for that is, you can use a trocar in trocar technique, in which within the assistant trocar, you can place a robotic trocar and then use that as a robotic arm. So that way, your harmonic will be in line. So this is how it is done. You place a robotic trocar within the assistant trocar, and then you can dock it. And one of the robotic will become like an assistant. So some practical tips for in the trocar position with robotic. And so when you start off, it's in minimal invasive, the exposure is critical. So you do what all, and you don't want the assistant to be retracting. So most of the retraction should be a constant, and use techniques which will have a stable retraction. So sometimes the falciform will be bulky, and it will interfere with your vision during dissection. So you take it off if it is bulky, and then you can even retract this, put a catgut loop around that. And then obviously you use trocar for liver retraction. I've mainly focused on lab, because I thought that will be something which will be, many will be starting with lab, because access to robot may not be always available, although we'll be covering some aspect of robot also. So various techniques are there. You can use whatever technique you want for liver retraction. And this, in addition, in this case, we didn't use as for traction, but you can use that. And another thing is, many times the gallbladder will be distended. So you can decompress that, and then because that itself will be occupying a lot of space, and use gallbladder for retraction. So that gives you good exposure for before you start. So I'll run through it. I think panelists are free to comment, and also any questions we can ask, because we are running short of time. So that's why I'm just going ahead. So these are the preparatory steps. So the first, obviously the critical, is the gastrocolic trunk. I think the most important thing is be familiar with the anatomy. In fact, probably I'll just start off with that. So most often it is formed by right colic vein. Often you have two right colic veins. So one you call a superior right colic vein, and the other one. So in this case, both are joining before it joins with the gastrocolic, but many times you will have two right colic veins draining here. And then obviously there's an anterosuperior pancreatiodinal vein. So you will have small, some infrapyloric veins.
but the main vein will be the right gastroepiploic vein. So the key when we are doing this gastrocolic dissection is often you need to mobilize the transverse colon hepatic flexure. You need to take it down. That will help you in the uncinate dissection. But before you take the hepatic flexure down, you need to control the right colic vein. So first identify the right colic vein, control that, then you do the hepatic mobilization, because many times what happens is you will be applying a lot of traction in the hepatic flexure and this vein avulses and you will have a bleeding. So that's the first important point to remember. And also while entering the correct plane during the gastrocolic trunk division, that is, you know that as normally when you open the gastrocolic omentum, you enter into the lesser sac. You will have a nice plane between the mesocolon and the pancreas. But as the transverse mesocolon moves towards the antropyloric region, the colic fascia and the gastric, they fuse. It becomes like a gastrocolic fascia. So when you come somewhere here, close to the antropyloric, so you'll have you can see here the colon comes close to the stomach. So at this point, you need to stay in the right plane so that the gastroepiploic vein gets lifted up and the colic veins are lying below. So you need to be staying in the right plane. So this area is called the gastrocolic fusion fascia. So stay in the right plane so that the colic veins are below and the gastroepiploic vein is above. And that way, you will avoid going into the wrong plane. Otherwise, you might go into the mesocolon. You will open the transverse mesocolon and the small bowel starts coming into the field of dissection and causing trouble. So these are the mistakes which usually happen at this stage, which we need to avoid. So when you're in the right plane, you will go over the duodenum, then you will be over the gerotas, and then go into the hepatic flexure. So, and then when you come, so you can see here, we are first taking the right colic vein, because that's the first thing before we go further. So once the right colic vein is taken off, then you will take the gastrocolic trunk. But in this case, so you need to be aware that variations are very common. Now you can see here in this, normally middle colic vein drains into the superior mesenteric vein separately, but here the middle colic vein is draining into the gastrocolic trunk. So they're all even that is part of this. So in that scenario, you need to be careful. Before you start ligating the gastrocolic trunk, expose the superior mesenteric vein above the gastrocolic trunk and also below. Because in case you have bleeding, you know at least where the bleeding is happening and you can safely control it. I'll also show, I think, Bejas actually shared one video of how to control that, but one of the ways is, as you can see here, we are nicely exposing the superior mesenteric vein here, and we also expose the vein below before we control the. So you can see, now we are also exposing the superior mesenteric vein below before we actually come into the gastrocolic trunk area. And so at this step, so this is actually, I've kept the relatively kind of unedited video. So in case if any queries at any stage, we can discuss. You can see here the middle colic vein is draining into the gastrocolic trunk. So this is another useful instrument. So this is called as overhold instrument, overhold forceps. You can see it looks like right angle, but it has a longer jaw, and it allows you to loop all the vessels safely. So this points to remember while doing the gastrocolic trunk, because this is done in the initial phase and you are bleeding in the initial stage itself, then most often this is one of the reasons for the conversion if you are not able to control.
So I'll share the clip.
This is
So,
one of the
yeah.
initial days of my surgery. I think it is almost 13, 14 years old video. So while controlling, standardization was not there then. While controlling the, that is the bleeding which I tried to control, because it's not the area where I was touching. So I tried to control it with the bipolar forces, but it's blood. So we didn't know it is what vessel it was bleeding, but finally found that it is gastrocolic trunk. So again, controlling with trying to control it with the bipolar, but it's not getting controlled. Now the left hand tries to control.
When you do a right hemicolectomy, most of these vessels you can see. So
Absolutely.
before going to the Whipple laparoscopically, you should have a good experience in right hemicolectomy and even a gastrectomy.
Yeah, I can expose the superimation vein there and then take the vessels one by one. Now it is caught with a bulldog. A 4-0 proline is used. And bulldog is taken. Scan road.
Yeah. So I think as many would have agreed that it's not easy to control this type of bleeder. I think many would have converted. So the most important point is try to, as much as possible, we should try to prevent it. But it can happen sometimes, bleeding can happen, so you should be ready to control. So one of the key is define your anatomy before you try to loop any vessel. So the next is, normally the standard teaching is the plane over the superior mesenteric vein, the neck is relatively clear, free of any vessels, but you can have occasionally the centro-inferior pancreatic vein. So what is that vein? We all know there is arcade running along the superior and inferior border of the pancreas, and so this arcade is drained by the vein which is called the centro-inferior pancreatic vein. Normally it drains into the splenic vein, but occasionally it can drain into the superior mesenteric vein. Not a very big vein, but it can again another source of bleeding, which you should remember and you should be expecting. So you can see here we are now coming towards the SMV, moving towards the neck, and you can see here that's a vein there. So always now we look for the vein because many times if it's not there, it's good, but at least you should be expecting that there can be a vein. So this is a usual site. It normally drains from the splenic vein, but it can occasionally drain there. So you can see sometimes it can even drains into the inferior mesenteric vein. But mainly when it's drained to the superior mesenteric vein or the middle colic, it comes in the field of dissection. Lymphadenectomy, I think I'll quickly cover. We all know that the technique is, as much as possible, try to do a en-bloc dissection the way we normally do it in open. So we start off from hepatic artery. That's where there's a very good landmark. You start the anterior surface of the hepatic artery. And the point to remember here is, always remember about the left gastric vein. The left gastric vein usually runs posterior. You can see here, this is the left gastric vein. It runs actually posterior to the hepatic artery and often drains into either into the splenic vein or the portal vein. And that is one of the important source for bleeding during this step. So you need to define your left gastric vein so that you avoid bleeding from there. And you start from the hepatic artery, then move towards, so as you move upwards, you will encounter the you will often encounter the right gastric artery. Let's see. So we are now off the hepatic artery. So we are crossing the GDA there. So as you cross the GDA, usually you will have the right gastric artery coming into this. You can again stay close to the artery, so because that's where the plane will be good. Always one of the principles doing lymphadenectomy is stay close to the structure which you want to preserve rather than going towards the lymph nodes, because then you have a very high chance of fracturing the nodes. Now you can see clearly the left gastric vein. Here you have to remember there will be a lot of nerve plexus around the hepatic artery which will be crossing the GDA. So that sometimes make it difficult to even expose the portal vein there. So you need to remember the nerve plexus will be running over the artery and then crossing into the GDA. So you need to open those. And you can see here now this is the right gastric, which is a very small tributary here, which you can control. And so the sequence is you start in the hepatic, then move towards the hepatic artery proper. You do the left side of the HDL dissection and leave the lymph nodes on the left side. And after doing the right side dissection, you take all the nodes posterior to the portal vein into the right side. So that's how we usually do it in open, and we follow the same technique in laparoscopy also. One difference between lap and robotic is often in lap we have looped the vessels for lymph node dissection, but in robotic, because of the articulation, many times you will be able to achieve lymph node dissection even without looping the vessels. So you can see this is the left gastric vein which is draining into the portal vein there. So defining that minimizes the chance of bleeding. So you can see now the left side of the lymph node dissection is complete. You expose the portal vein on the left side, the hepatic artery there, and then you leave the lymph nodes on the this left aspect. The next is the division of gastroduodenal artery, which is obviously the point to remember is making sure that that is not the pathway of blood supply to the liver, the celiac artery stenosis. One variation which I'll show, which you need to remember. We all know the gastroduodenal artery, the first branch is the posterior superior pancreatic artery, usually arises at least a centimeter or 1.5 after the origin. But you can see here, this is one case. There are actually two vessels. So you can see here, so this is the hepatic artery, and you have the hepatic artery proper. Yeah, you can see there are two branches here coming from the hepatic artery. So this is one branch and there is another branch. So one is a GDA. So in this case, the PSPD, the posterior superior pancreatic artery, was coming directly from the hepatic artery instead of the GDA. But before ligating both the vessels, you need to be sure that you are not ligating the hepatic, because sometimes the early origin of the hepatic artery also will be coursing the same way. And you need to be extremely careful. Make sure that you have identified the other hepatic arteries before you ligate these two branches. So we are making sure this is the left, this is the middle, this is the right.
before we individually ligate these vessels. So you can see here these two vessels are ligated, but after making sure that, so again your imaging will help. You can see where is the hepatic arteries dividing, and so also be aware of the variations. I think since we are running short, probably we'll cover the approaches to SMA in minimally invasive. Maybe I'll just take 5 minutes extra, John. Okay. So I mentioned that we have various approaches. The commonly there are many terminologies, but in simple it is anterior, posterior, right, and left. So what we normally use is a combination of right and the posterior approach. This is what we commonly use in minimally invasive Whipples. But anterior approach, what do you mean by anterior approach? You go over the anterior aspect of the SMA. It can be done both infra or the supracolic. The scenario where we use the anterior approach is when there is the first jejunal trunk is involved. So now in this case, you can see the tumor is adherent to the first jejunal trunk. And we have discussed that first jejunal trunk goes underneath the SMA. So often it travels underneath the SMA and joins on the right side of the SMB. Now if you try to loop the first jejunal trunk in this aspect, that is so we are on the right side of the SME. Now if you try to loop the first jejunal trunk here, one is you may not be able to loop it completely. Often you will be entering the vein because it's curving and joining there. Even if you manage to loop and you are applying the clip, suddenly clip slips, this will go underneath the artery and you will find it very difficult to control the first jejunal trunk. So always the safe way of ligating the first jejunal trunk when you have to ligate is you go to the left of the SME. So when you want to go to the left of the SME, so that is where you use the anterior approach, in which you start dissection over the anterior aspect of the superior mesenteric artery. You see that now we have retracted the superior mesenteric artery to the left, the superior mesenteric vein to the right. So this is in contrast to what we normally do in Whipples. Normally we retract the vein to the left. Here you can see nicely you can expose the first jejunal trunk, and this is a safe place to ligate the trunk. So here even if something slips, you have a much better control. You will be able to control it. So this is one scenario where we use the anterior approach in minimally invasive surgery. The next is left approach, where we are in the infracolic compartment. So where we use the left approach. So I think I'll cover this part, and so we know that the IPDA is usually, although we see it on the right, it originates in the posterior aspect. It can be posterior right or posterior left. So when this is the site of origin, you can easily control from the right. But sometimes it will be originating much more on the left aspect. So something like, as you can, so you can see here the IPDA and the first jejunal artery is originating more on the left side. So these are the scenario where you can use the left approach and approach the SMA from the left and ligate the inferior pancreatiodontal arteries. So the only challenge here is you need to retract the mesocolon. So use this type of internal organ retractors to retract the mesocolon so that you don't use any of your arms for retraction. As far as possible, minimally surgery, we don't use arms for retraction, use any of this type of innovative methods to have a stable retraction. And then you start here. So you'll have the Treats ligament, which you need to divide. So this is the inferior mesenteric vein. So the inferior mesenteric vein, you dissect it off from the DJ flexure. So you can see here now the inferior mesenteric vein is retracted. The same we follow in open also. And then you will start encountering the superior mesenteric artery. In fact, actually it is easier to expose the superior mesenteric artery using left approach. But if you want to do the mesenteric dissection from the left, that becomes challenging. But only exposing the superior mesenteric artery, in fact, it is much more easier from the left side compared to the right side. And you can see, so the tissue which is around that is the plexus, what we are holding. So that is the SMA plexus. And you can see here, this is the common trunk. And the one which is going this side is the IPDA. And this is the other one is the first jejunal artery. So usually the IPDA, because it goes towards the pancreas, and the jejunal artery will be moving towards the mesentery. So this is the way of controlling the, exposing the SMA and controlling the common trunk of the IPD and the first jejunal artery from the left side. So the next is the posterior approach, which means you approach the SMA origin above the left renal vein. And the right approach is what we discussed during the talk on the mesopancreas after doing the derotation. So probably I'll come to this after, because that's one interesting video. Maybe we'll cover end with that video. The posterior, so we combine both posterior and the right approach, because you don't actually complete everything with your right approach. We start off with posterior and then the right. Now, we have seen in open, you have good landmarks, you have very broad vision to do all this mesopancreas dissection. But in minimal invasive, you need to have landmarks, and you need to imagine or predict how your landmarks are based on the preoperative imaging. So the critical structures which we look in the preoperative imaging is 4 things. Where is the gastrocolic trunk? Where is the first jejunal trunk? Where is the IPDA and the first jejunal artery? So the reason why we look all these things, I'll explain. So now you can see here, so this is the SMV, SMA. Now this is the IPDA. So in this patient, the IPDA and first jejunal are separate branches. So we have seen both IPDA and the first jejunal artery. Now we see the gastrocolic trunk. The next is, after seeing the gastrocolic trunk, you need to see how much below the gastrocolic trunk is the first jejunal trunk. Now this is the first jejunal. The reason is, of all these 4 structures, the only structure which we can expose in the initial phase is a gastrocolic trunk. So that clip will serve as a landmark. So from the gastrocolic trunk, we know, okay, after 2-3 cuts, I am seeing the first jejunal, which means a centimeter below the gastrocolic trunk, I can expect my first jejunal trunk. Now, if I enter the SMA at the level of first jejunal trunk, in this patient, I will be encountering both first jejunal artery and the IPDA. Because as we see on the image, we saw the IPDA and the first jejunal artery above the first jejunal trunk. So using these landmarks, we can predict what all vessels we'll be encountering, at what plane we should enter the SMA. So this is very important in minimal invasive, because in minimal invasive you don't have that panoramic view as you have in open surgery. So this is the last video. So showing that technique of mesopancreas excision, the same way we do it in open, how we do it by. So the first is, we start off with the posterior approach. The additional advantage of this posterior approach is, because you expose the SMA at the beginning, even if some bleeding happens from the IPDA, you can actually clamp the SMA at the origin. You can put the bulldog there. So that's the additional advantage of exposing the origin of the SMA. So this is a SMA and this is a celiac trunk. Because as we mentioned, we routinely do the triangle clearance. Now the additional advantage of posterior approach is if you have the replaced right hepatic artery, you can initially itself define that. So this is a replaced right coming from the SMA, so you can define it in the initial stage itself. So this is the SMA celiac. So this is done in the beginning. So you start with the posterior approach, expose it, and then we move to the right. So as we discussed, you will do the derotation so that the mesentery comes to the right. The same what we do in the left. So this is the inferior mesenteric vein. So you identify it, stay above that, mobilize the DJ flexure. Now we are taking the proximal jejunum, but you can't see the way the proximal jejunum as in open surgery. So what we do is we straight away go to our landmark. So first we want to expose the first jejunal trunk. Now this clip is there already. This clip is on the so we have seen this is a clip on the gastrocolic trunk, and we know that the first, based on the preoperative imaging, is just a centimeter below that, and we first expose the first jejunal trunk. So we can see here the first jejunal trunk. Now what prevents our exposure to the SMA is this IPDVs. So this posterior inferior pancreatic vein, you need to divide, because we want to separate the first jejunal trunk from the uncinate process so that you have the access to the SMA from the right. Often these veins are small, so you apply clip on one side, the other side you can just bust it off. So in open we started from the mesentery and went here, but here we do the reverse, at least the initial, because you can't do the same way in like in open. But now this is the first jejunal branch draining into the first jejunal trunk. So this is taken off. Then once you take that, you do the dissection, the division of the small bowel mesentery. Because that also gives an idea where I should divide the small bowel. And now you can retract. There are some techniques where you can take a suture and retract it also. But because we need a dynamic retraction, so now we know from here we need to go along the, I have to reach the first jejunal trunk, because if I reach the first jejunal trunk, I will be below the first jejunal artery, because that is our landmark. And before we reach there, we will be encountering this arcades. This is the distal jejunal arcade. And then you will encounter the way we saw in open. So you will have the proximal jejunal arcade. You can see is how close it is to the SMA. So it will be very close to the root of the mesentery. We can appreciate this anatomy when we do any of this open surgery. We can actually lift the jejunum and see how the arcades are, because that will help when we are doing this procedure. Now the jejunal artery gets straightened. So this is the first jejunal artery which is ligated, which will be ligated, and then
and then you go into the second, then you have the IPDA, because in this patient both IPD and the first jejunal were coming separately. So that's how, like, looking at the pre-op imaging will avoid lot of confusion intraoperatively. Now this is called, in the mesenteric division is called level 2, and here also it's a level 2 on LV2 on the SMA, because we are not taking the SMA plexus. Now I'll show that LV3, I'll go directly over the SMA part. So this part, this is called the SMA plexus, what is being held by the grasper. So you'll have that tissue over the SMA, and when you take that, so then it becomes the LV3 dissection. So you will see only the adventitia. So this tissue is the SMA plexus, and you will be right on the adventitia. So you can see here, so this is a routine triangle clearance which we achieve in most of the cases. So this is like the divestment so this patient had a relatively advanced, so you can see here complete divestment of both celiac, SMA. So this is peri-adventitial, so it's not sub-adventitial. We never, I never done a sub-adventitial divestment because that is something technically challenging. You have a high risk of vascular injury. Also this explains that anatomy which is relevant in celiac axis dissection. You can see here both splenic and hepatic artery are there, but you don't see the left gastric artery. The left gastric artery will be much more proximal. So many times you will be able to preserve the left gastric artery even when you have to do a celiac axis dissection. So that is about the triangle clearance and all the part. So I think before we end, I'll ask Dr. Beju to explain his, I think he has some interesting.
Actually, this is, yesterday and today, many people were emphasizing the importance of studying the images. So actually this patient came with the image from outside. We couldn't go through, only the films were there. So in the films, we couldn't make out the anomaly there. So I was on the, you can see the portal vein there. So I was on the right side of the portal vein, and suddenly some bleeding happened. I tried to clip it, and thinking that it is a cystic duct, sorry, cystic artery, I tried to resect it, but later found that it was replaced right hepatic artery. Now the application of bulldog on both sides. That is the artery which was severed. So some tissue is remaining just to open up the rent. And trim the area with the scissors. Now 5-proline is taken. You can fast forward. You can see the intima there. there was torrential bleeding, there was jetting like anything. So then only realized that it is hepatic artery which was coming behind the portal vein. And it was repaired. Now you can see the post-operatively the patient had a temporary elevation of the OTPT. You can see the right hepatic artery is intact in the images taken post-operatively. Thank you.
Any questions, because I know that we have taken more time, but any, okay. I think we are running short of time, so we'll, if anything, we can discuss later. Sorry.
Thank you.
I thank the panelists also.
Thank you, Kalai and chairpersons, for this very extensive discussion. Now we have a next panel discussion on metastatic neuroendocrine tumor. I'm sorry. There's a small video from Manjuraj on laparoscopic pancreaticogenostomy and hepatocogenostomy.
Good afternoon, everyone. Thank you, Ramesh sir, my teacher and mentor, for this stage and opportunity. We know that the PJ is the Achilles heel, and the ductive mucosa is the standard of care. When you do it minimally invasive, it becomes more difficult. So no one can match the experience of people like Dr. C. Palnivelu, like more than 1,650 minimally invasive surgeries since 1998. So you can see how effortlessly he is doing the hepatocogenostomy as well as PJ. So when we newly venture into high-end minimally invasive surgeries, it's very difficult to replicate these experienced hands. Yesterday we have seen Dr. CJV as well as Dr. Bayu sir. They are effortlessly doing all these pancreatic anastomosis. So when we venture into these high-end surgeries, we at least try to replicate what we are doing in the open surgeries, like placing all the sutures properly before taking the anastomosis. So we all know these standard techniques, either Blungard or Heidelberg techniques. So when we try to replicate into lab surgeries, a lot of suturing has taken, become very difficult. The knots become entangled, the sutures become entangled. So it becomes very difficult in your early PDs. So this become very, very confusing. So while we evolve, we adapt new techniques for, at least you can replicate your open technique, or you can at least do justice to your patient as well as yourself. So this is my port position for MIPD. And this is a post of when I do a small midline incision for removing the specimen as well as for putting the FJ. So this is a liver retraction, just like Dr. Kalai has shown, GB for retraction. One of the YouTube videos I've seen that one protein sutures is taken along the crus, the falciform and abdominal wall for retracting the left liver, which is found to be very useful. You don't have to put an athanson or extra port for this, so you can avoid interaction with the so many crowding of the ports. So this is an adaptation from the literature regarding pediatric choledocholicist. They were to prepare, when we remove the specimen from the midline, we take out the bowel, the jejunum for anastomosis. I prepare the bowel with if it is a very small PD, an opening is made outside the extracorporeal. The edges are approximated to the 6 PDS. If an FJ also, I open the bowel outside when there is depending on the size of the FJ. Again, approximating sutures are taken. So this serosal suture is taken, a pursing is taken around the anastomosis to avoid any leak from the opened end. Otherwise, it can contaminate your field and abdomen while pushing inside. So this is taken around the serosal suture is taken around your future anastomotic site. Taken inside with the inside and push across the mesocolon. So this is the HJ. HJ usually the last IHPB Dr. Haribhakti was showing 3 approaches from right, from the center between the legs and from the left. So we usually prefer to do from the right side. It's a normal size duct. Triangularization is the key in any open or lap surgery. So we take a hanging suture from the anterior wall. It is taken outside with a cobbler needle. This is a normal size duct, almost just 5 millimeter hepatic duct, CHD. The bowel is positioned. The serosal suture is opened. Usually this opening is made in the anterior side. Usually in the open surgery we are usually doing in the opposite side. Now it's in the appendix about getting that the lumen gets opened up during the anastomosis. Another suture is taken, that is inside out and from out in, and again hanged for in the opposite direction, so that it can almost replicate an open situation. If it's a large duct, we can do a continuous sutures. In between, some interpretive sutures can also benefit. So when we are approximating the seromuscular and the mucosa, there will be no confusion in taking, especially in the small ducts. So when we are doing from the right side, there will be less interaction with the other surgical team, assistants, cameramen, and also there is enough space is there, and you don't have to stretch your arms extensively to do this suturing. Only that taking the notes will become a little difficult when almost your instruments are almost parallel. This is the other case where you have the normal duct. This anterior aspect of the duct was split a little bit to increase the size of the anastomosis. So this is a full interrupted anastomosis. Again, if you have the one hanging suture on the anterior wall, one on the corner, this becomes the anastomosis becomes like reproducible and very easy. The posterior wall is complete, and the anterior wall again the same technique. The last two sutures may be taken without tying and can be tied after driving the needles. This is the last suture which completes the HJ. So coming to the PD, PJ, again the same technique. This is a very soft pancreas which even not even accepting the hemostatic sutures on the side. This is the first suture again taken for hanging. So all 5 sutures in the anterior wall, 2 corners, 3 anterior wall taken. So usually we take the duct sutures which will deep around 4 to 5 millimeter inside. So the duct is the only structure which reliably hold the pancreas, even compared to even the pancreatic capsule, because pancreatic capsule maybe become soft and most of it becomes cut through. So all these sutures are taken, and hanging corner sutures are hanging. The hanging corner sutures taken. After that, 2 posterior sutures taken separately. Then it is tied. Sorry that this video is taken from the monitor than directly from this one, because of faulty recording system with us last time. So the posterior sutures were taken, individually taken and tied. If it is a dilated duct, we can easily take the posterior capsular duct, then followed by intracorporeal opening and sutures. The posterior layer is complete. One more. These are corner sutures. So even if you have long threads, it will not come into your field, and it will not. So that completes the PJ, and 2 corner sutures are taken at 3 o'clock and 9 o'clock with the proline, the capsule to the serosa. Because you are taken deep sutures in the duct, you can even flip the pancreas and break the posterior sutures if you want to take. So mostly I complete with, if it's a very soft pancreas, I complete with the 2 capsule to serosa sutures in the 3 and 9 o'clock position. So I feel that more than the choice of the variant used, successful management of the pancreatic anastomosis depending on the surgeon's concentration and meticulous execution, as the textbook says. So I think this is probably, when you are newly venturing into the PD, probably you can reproduce. It's a reproducible technique compared to that shown by the most of the experts. Position of? Yeah. PJ, most of the 3 o'clock and 9 o'clock sutures, they has to be taken, the needle has to come from, the drive has to come from the vertically. So almost a vertical, Between the legs, between the legs, between the legs. I think normal, yeah, we'll finish.
So I invite Dr. Jasil for the panel discussion on metastatic neuroendocrine tumors.
Thank you and very good afternoon everyone. So I would like to invite my panelists to the dais. Arun sir, Govind sir, Manoj Ayapat and Sendil sir. So we are into the last hours of pre-lunch session. So I know everyone is hypoglycemic. So but still we'll quickly go through 2-3 case scenario based discussions. Number one. And number two, I would like to involve all the participants, all the experts which are sitting in the audience as also part of in order to give their opinions. So, as we all know, even though the pancreatic NETs can be functional, non-functional, lot of factors is there to determine the management. But basically, I wanted to concentrate on this image. In 2019, the WHO has classified this into either a well-differentiated or a poorly differentiated. You take that well-differentiated, you divide that into grade 1, grade 2, grade 3, depends upon the Ka67 index. And the poorly differentiated will be considered as a neuroendocrine carcinoma, where the grade is 3, and the Ka67 is more than 20. So I will quickly go through the first case. It's in 2014. So he's a 31-year-old male. Already the patient had underwent a pituitary macroadenoma excision some 5 years back. So now he was evaluated for dysuria and back pain. So anyone from the audience can say what do you see in these two pictures? So what do you interpret from these pictures?
Pidambaran.
There seems to be an enhancing tumor in the tail of the pancreas.
Yeah. And what is on the left side?
Yeah, left side, left kidney, left ureteric stone is there.
Yeah, there are actually more than 2-3 stones are there with a massive, something like an hydroerythronephrosis. So what do you suspect? Arun sir, what is your comment?
See, there is a history of pituitary, there is a hypercalcemia suspected and an entity. So must be an MEN1.
Okay, so how will you proceed? How will you evaluate?
Yeah, pituitary already dealt, we don't have to worry, but the high serum calcium and high PTH, we are worried. So next is parathormone, general surgery, endocrine surgery, whoever is dealing it, let them deal it. Maybe 4 to 6 weeks later, we can plan.
Yeah, the patient had a left lower parathyroid, which has been done, enucleation has been done. So how will you evaluate for the NET? Or that?
NET, see, now we have a 555 CT, abdomen as well as a chest. That is showing only the tail of pancreas lesion. Straight away, you can plan for.
Do you want chromogranin?
Definitely, serum chromogranin A will be done.
Yeah. So it's elevated. And will you consider a dotted PET? Sendil sir, will you consider dotted PET in all the cases of NETs, or is it selective?
Yeah, basic requirement is multiphasic CT or MRI. But in many cases, if the facility is available, we can consider because it covers only the abdomen.
So I'm asking about this particular case. There is one lesion which is around some 3 into 2 centimeter. Chromogram is 247.
It's difficult to predict which will metastasis. Even a grade 1 tumor with a small tumor can have metastasis, or bigger mass with grade 3 tumors may not have metastasis.
So is it safe to say that a patient with NET, I should have a baseline dotted PET?
Yeah, if the facility is available, if the patient is affordable, I think it's better to.
Okay, so which one you will prefer, whether it is dotted scan or it is FDG PET?
I think in grade 1 or 2, we'll go
So
for
we don't have any preoperative biopsy, so we don't know what to do.
As a baseline, we can go for DOTA PET. If it is not showing uptake or less uptake, then we can consider.
Okay. So, but you are not, for all the patient, you are not supposed to do both the DOTA as well as FDG PET.
In all the cases.
So what is this net PET score, which is something which has newly come out?
Net PET score is basically, we have to perform 2 studies, especially in grade 3 and if possible in grade 2 also, because there can be tumor heterogeneity. And we have to see the uptake in both scans. If the in well-differentiated tumors will have SSTR positivity, but FDG will be negative. There they will have good prognosis, and they are good candidates for PRRT. And as the tumor goes into higher grade, the FDG positivity will come up, but SSTR expression will go down. So that's how the grading is being done.
Okay. Arun sir, how will you proceed? Will you operate? Will you wait?
I think we should operate.
So how will you proceed? What is your...
Distal pancreaticosplenectomy. It could be any access, open, laparoscopy or robo-assisted.
Will you consider a preoperative biopsy before operating?
Biopsy in this case, I think we should try to see both sides of this biopsy coin. Definitely US graded FNA or FNB, by aspiration cytology or biopsy is good enough. But we should be doing more biopsies when we have equivocal features on imaging. Sometimes a NET may be slightly hypo-enhancing compared to the typical routine ones. And if we are really worried about any concern about tumor grade, then definitely we should be doing biopsy. The other side, see, there is, especially for NET, there is a lot of heterogeneity, even among different areas within the primary or among the primary versus the metastatic deposits. So that is always there. Biopsy, you will get a sample from only one particular corner of the lesion.
So it may not be representational, whatever we are getting.
Suppose you have a good enough sample, good enough biopsy, how many percentage of these patients will have a concordance with the final histopathology once you take out the tumor in total? So there is a lot of variation.
So basically the CT is the diagnosis. If CT is showing an arterially hyper-enhancing lesion, you take it as NET.
Absolutely. Unless there is two differential diagnoses like accessory splenangulus within the pancreas or an isolated metastasis of a clear cell carcinoma, RCC.
Okay.
These two are ruled out, then it is a NET.
Okay, so we didn't do any preoperative biopsy, so you will go ahead with a distal pancreatosplenectomy. What about the margins?
See, margins, textbooks, literature, guidelines says just a negative margin is good enough. But especially with minimal access surgery, if you are doing a lap or robo-assisted, at least aim for a 1 centimeter margin, so that if by chance, sometimes it's very difficult to differentiate the NET tumor tissue versus the normal pancreas, especially if it is intraparenchymal, not a protruding lesion. Our histopathology reports are going to take WhatsApp rounds. They will send it, the relatives will send it to almost all oncologists in the world, whoever is in their company. So a positive margin resection in the histopathology is not good for yourself or your team. So says a simple 1 millimeter or just a negative margin is good enough, but at least 1 centimeter. Go back to I want to talk more. But having said that, certain cases, very small lesions, less than 2 centimeter insulinoma, a protruding lesion, you may do an enucleation and parenchymal preservation. Such lesions, definitely I will, stand a bit back regarding the margin status. And I know you will quote so many things regarding even a positive margin resections. Positive margin resections in NET as well as GIST. There may not be any survival advantage. You will quote that, but NET, you have many other major things like age, grade, perineural invasion, vascular invasion, metastasis at the time of diagnosis, and tumor biology. You can say we don't know what it is. They are more strong predictive for prognosis, I agree. But we should try for a negative margin, and if possible, 1 centimeter margin, especially for large lesions.
Can I ask a stupid question? Just
explain. You are always intelligent.
Just the rationale for operating without a biopsy on this particular patient. This is a Men's syndrome patient. Suppose that is a grade 1 neuroendocrine on the tail of the pancreas, asymptomatic, non-functional, maybe. Why do you want to take it out? He or she is going to get the rest of the pancreas will develop a neuroendocrine tumors later on. But right now, why would you want to do a pancreatectomy?
But the chance is only 10%. Multifocality of NET in men is 10%. 90%, 9 out of...
If it is grade 1, why would you want to operate on the tail?
Is there any size? The lesion is around 3 into 3 centimeter.
There's a different concept on it. Like if you go to the studies, even the small one can metastasize. So observing alone may not be... Well, yeah, there is a concept of observing, especially in liver, but in because of parenchymal preservation, but in pancreas, resectable, resect even if it is small. There's every chance that it metastasizes.
So I think everyone agrees we should operate this patient.
One more thing. do you have the difference of opinion if the lesion is in the head of the pancreas rather than the tail of pancreas?
Regarding preoperative biopsy?
No.
Operation, surgery.
Regarding surgery.
In a one patient.
No, this is the same patient, location is the tail of the pancreas, rather than that, the location is the head of the pancreas.
Okay.
So, whether your approach changes, so you will go for a Whipple's or not?
Definitely Whipple's, more than 2 centimeters, definitely Whipple's.
No, in that case, we'll go for a biopsy. Whether your approach changes or not?
It won't much.
So I'm changing the scenario. What if the size is 1.7 centimeter? Head of pancreas.
You want me to say biopsy for all lesions, then I can agree. But certain cases we will do and certain cases we will not do.
So anyhow, we'll continue with.
We have one more surgery.
So we'll continue with the discussion. So as Sarah's pointed out, we have to aim for at least 1 centimeter. But even
One more thing, location in the pancreas also is important. So if you see the location and if it actually enlarges and cause obstruction, other problems, it's better to resect.
So you would try to resect a head lesion more than a tail lesion?
No, not like that. Resect more, tail more, yeah.
Yes. But it makes sense, absolutely. Yeah.
Okay. So even though 1 centimeter is adequate, but I can say even the microscopic margin, there is no survival advantage. Only the recurrence free survival may have improved. This is a very big study where the margin status was not associated with the long-term survival. But what is this adequate lymphadenectomy? Will you do a radical, an oncological lymphadenectomy in all the cases of NET, or it is selective?
See, something about basics like size of the primary definitely correlates with chance of lymph node involvement. Larger the primary, more chance of a lymph node metastasis. There, Pidambaran's issue, the head lesions definitely has a more chance of lymph node mets at the time of presentation than a similar sized body and tail region. But less than 2 centimeter primary, agreeing with Dr. Manoj, that is around 12 to 27% will have lymph nodes, less than 2 centimeter primary. And unlike in colon, stomach, esophagus, there are no universally accepted or established threshold to ensure your staging, to call yourself as a good surgeon, to ensure adequacy of lymphadenectomy. There is no guidelines actually. And just think about your central pancreatectomy or the median pancreatectomy, and very small lesions when you try to preserve the spleen preserving distal pancreatectomy, and definitely, as I said, the enucleations. It's very difficult to get the count in terms of lymph nodes slide. But having said that, when we operate on a body and tail lesion, focus on common hepatic, celiac, splenic and splenic hilar. They are actually within our field of dissection, so it's comparatively easier to pick up all these lymph nodes en bloc with the specimen if possible. Definitely in head lesions, we should not forget about the posterior pancreatoduodenal up and low, the 2 sets, along with portocaval lymph nodes. But you need a figure always, I know Jasir. So 11 to 15 lymph nodes, if possible, are better. Definitely it's better. But lesser, it is described in the guidelines like in lesser resections, removal of the suspicious lymph nodes on preoperative imaging. But I would say any suspicious lymph nodes on preoperative imaging, definitely we will proceed with a classical en-bloc lymphadenectomy along with the primary tumor.
What is your median lymph node yield in distal pancreatosplenectomies?
7 or 8. That is our routine. Unless the pathologist, just like a Japanese pathologist, who is very much focused and they do lymph node dissolving, fat dissolving solutions and so much of focus. Otherwise, we won't get such lymph nodes.
So anyhow, we did distal pancreatosplenectomy in 2014. So HPR, you can see it's a well-differentiated NET, actually 2 lesions. The other cystic lesion also turned out to be an NET, which is grade 2, and the K67 is 6%. And I think our pathologists are good. There are 12 lymph nodes. So 3 out of 12 lymph nodes were positive. So is there any role of adjuvant therapy going on in these particular cases?
No, as of now, absolutely no role of adjuvant in this patient.
Why?
So,
is it because of no residual tumor is there, or?
No, see, the adjuvant therapy, if you use the definition itself, it's a therapy of different procedure that can kill or that can cause cytotoxicity to the exiting cells actually. So there are no drugs which are causing adequate cytotoxicity in NET so far. So there's no role so far.
Okay. So how will you follow up this patient, Manoj sir? What is the frequency, duration?
If you see this patient is lymph node positive, that is metastatic disease. So this patient got every chance. The recurrence is the rule, it's not exception. So ideally, these patients should be followed lifelong. But when you go, there are many papers like that. But on a practical note, you have to do a CT scan, cross-sectional imaging, CT or MRI, after 3 to 6 months of follow-up, then 6 monthly for 2 years.
Is it feasible for an Indian patient population, or do we have to change this protocol to Indian population? This is, I think, Western guidelines.
Yeah, these are the guidelines for this particular tumor, where the size is more than 2 centimeter, node positive tumor. See, you can use chromogranin, which is not being very advisable to follow up with chromogranin, but in this case, preoperative chromogranin was high. So if you want to compromise on, then you can actually follow up with chromogranin, and maybe you can, this tumor and yearly CT would be okay. In ideal situation, you should follow up these patients for 10 years. Regarding DOTA, if you shall do it every 2 to 3 years, or if the index of suspicion is more for a recurrence, then you can repeat at that point of time. But if you see post-operatively a normal chromogranin with the CT scan doesn't pick up any new lesions, you can observe these patients.
Yes.
Yeah, I would like to add one more point on chromogranin and make sure that these patients are off PPA
Off
for at
PPA.
least 2 weeks, because this PPA will have the tendency to have raised chromogranin.
So that was what my next question was. Does chromogranin is really a reliable marker? Because I can show you hundreds of situations where chromogranin is elevated.
Definitely, it is not, especially in this patient who it's a non-functioning pancreatic tumor, the sensitive specificity is less than 50%. That's why I previously said, as the preoperative chromogranin was high, you can follow up with that. Otherwise, it is not at all a reliable marker.
So, but we are still getting patients where chromogranin is high, but dotted pet nothing is a. But some patients will be having dotted pet, a huge disease, but chromogranin is normal. How can you explain? How will you tackle those patients?
That is see, a patient whose DOTA is positive with chromogranin negative, it is immaterial. That's you can actually, if the DOTA is negative, you can do a cross-sectional imaging. It is a very rare scenario in which cross-sectional imaging is not picking up a tumor and your DOTA is positive. That is very rare. Likewise, if you're not detecting a tumor recurrence in CT, then chromogranin, I don't think you should give much importance to that.
Oh, do you agree? Go in, sir.
Again, as I said, I agree to part, but part again is that, as we all know, as a grade of the tumor increases, the sensitivity of chromogranin also will come down actually. So grade 1, the chromogranin will be much more higher than a grade 3 tumor. And yeah, as I said, in this patient, as the initial chromogranin was high, still we can, to a certain extent, judge on this tumor. And I think Sandil sir will also agree, we have many cases where cross-sectional images has not picked up anything, and DOTA will show multiple, especially in the low-grade tumor, grade 1 tumor, that are pretty common. So this is very heterogeneous actually, difficult to go by any guideline because it's relatively a younger tumor in ET, I would say. Probably in the next decade we'll be able to answer much better on this.
Yeah, we will move on. So this same patient in 2016, so they did a yearly CT. So this is a finding. So do you want to comment anything? Arun sir, do you consider biopsy from all these lesions? Is it necessary?
See, I think this patient initially was actually indolent. Now it is showing its true behavior. That means there are multiple lesions in the liver, hypodense lesions within the liver, suggestive of metastasis. Again, back to the same old principle of biopsy. See, definitely biopsy is important in this case. Let's go to that video. Before starting it, this is another case. There are multiple lesions within the liver. Just see the enhancement pattern within the liver, and there is going to be a large lymph node in the common hepatic artery area, just post to the stomach. Just see the enhancement pattern, that node, large one. It's a large node, and just see a small duodenal primary, and just see the enhancement pattern. A very small, the upper one. And the very small duodenal primary, definitely it's not a pancreas still. The 3 different areas from the imaging we know, they show different patterns. So there is every role of a liver biopsy in this case, because the grade can vary from among different areas of the primary and different areas of metastasis,
Yeah,
maybe lymph nodes or liver.
This is like primary is not resected. So our primary is resected. It's only.
Still, definitely.
So will you consider biopsy again? Yes or no?
This patient, definitely yes.
Definitely. You will consider from all the 4 lesions, 1 lesion?
I mean, 1 lesion, maybe a dominant lesion. 1 dominant lesion. They will say maybe biopsy from all, I don't know.
Go in, sir.
No, absolutely no. As you said, only 1 lesion is required because that doesn't going to change the treatment plan here anyway.
Absolutely. And definitely this biopsy is mainly to target some patient population where we can avoid actually futile exercises,
Yes.
like overkilling of such
So that means in order to assess the grade of the liver
and
lesions.
prognostication.
Yeah. Okay. So the biopsy was anyhow, it's well differentiated in ET. Again, it's a grade 2. Case 67 was 8. So, and he was some local hospital. They started him on octreotide. Do you think this is a correct approach in this patient? Govind sir? What would you have done?
No, was only cross-sectional imaging available or?
Dot pet showing no dissemination. Chromogram is 182.
Okay. Fine. So, yeah, again, a two-way thought actually. So here only the liver lesions were there. So I think the patient was a young patient, right?
Young patient, yes, but asymptomatic.
Okay. So the thing is that in, as I said, the role of octreotide, whatever we is usually only the stable disease what we get. So whatever theory and whatever response rate we talk, at the end of that it's only a stable disease and one point it's going to grow. So again, always the decision aspect to taken is an oligometastatic surgery possible in neuroendocrine tumor because the role of a medical oncologist per se is very less in a, so it's always, can you do anything to do, if it's a oligometastatic site, can we do anything for that is the next question actually. So we would always prefer to treat the oligometastatic in a definitive therapy rather than going for octreotide straight away, if at all possible.
Do we have any other opinion? What do you think, Arun sir? Surgery?
See, it's difficult.
Why?
Now it is showing 4 metastases.
Yeah, dotted pit, no other lesions.
Not surgery actually. I would say something like ablation.
For all the lesions, even for the peripheral lesions.
Do ablation for 2 lesions. Wait for some time. Let us see the behavior and then decide. Because this is not a very friendly for resection. Just see it. 4 lesions.
So,
yes.
I agree. It's not a good this thing for resection. I mean, even if you do right port line embolization and then do right
these 3 lesions we can do non-anatomical resections, wedge resections.
What about the right one deep one?
That any role of ablations, RFAs, microwave. Manoj sir, I think Manoj sir will talk about that.
But it's near the. Why not PRRT?
We all are thinking.
That also will come next.
We all are thinking these liver lesions in terms of carcinoma. No, we are dealing with totally different biology of the tumor. The patient dies not due to the metastatic load or something. The patient dies due to liver failure due to replacement of hepatic parenchyma. So whether we need to treat all the lesions is a big question. We can actually observe this with CT, and those lesions who are increasing in size or those are easily amenable for RFA, you can ablate those tumors and actually can wait and see how the tumor evolves. If one lesion is increasing in size, you can go and selectively resect that because you're just delaying the death of the patient. You're making a resetting of the clock. That's what I mean.
So, Sendil sir, is there any role of PRRT in these liver-only lesions?
I think if the surgery or ablation is not feasible, we can think about 2 possibilities. One is starting an octreotide and wait for until the progression happens. That is what the recent RCT has shown. But the NECTAR-2 trial shows there is they're trying it as a first-line treatment itself. There is a good response.
But I think in this particular case we should have some clarity. So I don't know what to do with this patient. What will we do?
So it's pretty simple. If you cannot easily take out all the 4, if it was single lesion, it was very easy actually. But here it's again, as I go with the surgeons, if it's totally difficult to take out all these 4, start an octreotide and observe.
So oncologists are handing over the mic to surgeons. You take out the lesions, you do some ablations.
Lesions.
Yeah.
That you explore, you can remove that, and the deeper lesions, ultrasound guided RFA, should be okay if you want to deal all in the same setting.
It's a little large for RFA, I think. The deep lesion.
Yeah, microwave.
Or you can observe.
Some draining veins are there. Yeah.
So anyhow, I just wanted to show, this is one landmark article which has been in 2008, I think, Sarmiento et al. So he has actually a plea for resection to increase survival. You can see the almost double overall survival after liver metastasis resection. But okay, of course, the recurrence in the liver is increasing even after the resection, but you can have an almost a doubled overall survival. So can you agree? Govind sir.
Whatever behavior we have observed so far, I get totally with you actually. If at all, it should be easy resection. It's not that we should see most of the time your NET patients probably. I would give an example actually. So if a NET borderline resectable NET come to us and give chemotherapy, the patient is more likely the chemotherapy and due to the disease actually. So the selection of any thing on this patient should be very careful. I agree. If it's a easily resectable salt remeds and all, that really helps.
So anyhow, this patient has not underwent any resection in 2016. He was on octreotide. So, but he was actually from a local hospital. So he was referred in 2018 again back to us. So this is only, I am showing only one cut of the dot tapetum which has been shown. So you can see there is a large lesion in the right lobe which is extending into segment 4, another 1 centimeter lesion in the segment 4, segment 3, and another lesion on the segment 8. So what is your opinions? What do you think the ideal management? Manoj sir.
As I previously said, the paper which you have shown, Swami, that actually changed the outlook towards neuroendocrine tumor and secondary in the liver and its outcome after surgery. So surgery gives a better option to treat. Whether to cure or not is a different question. So in this, the right lobe is inadequate in volume. So if you can augment the right lobe and do an extended resections on the right and pick up the metastasis on the left surgically, that would be a better, good option. If not successful in the same setting, you can actually ablate with the RFA and see how the patient responds.
Are we justified in offering this much of an aggressive management to these patients?
Because this patient, if you don't do, the patient will die very soon. This is a young patient. Because the liver is getting replaced. As I previously said, our outlook should be different in neuroendocrine tumor. Patient dies due to hepatic parenchyma replacement. So surgery will be...
So we are thinking about an R0 resection. I am asking what is the role of cytoreduction. Can you just reduce some % of the tumor from these lesions?
Definitely, that multiple papers have come. Like if you do a debulking, the patient survives more. We are not thinking about recurrence. Recurrence is the rule. Patient will recur, but we are actually delaying the death. How far we can give, the progression-free survival and disease-free survival. Even the disease comes back, but the total survival time, what we can do. So cytoreduction definitely got a big role. That's why previously that the Mayo Clinic paper, it actually changed the outlook. They showed double survival time if you resect. Even 75% is okay, 75% reduction.
Okay, so even if you are planning for a cytoreduction, is it the cutoff is 90%, 70%, 60%?
No, this paper itself shown double the survival for 30 months survival if you do a 75% reduction.
Yeah, so I can show again papers. There are around some 30-35 papers, but all the papers are retrospective analysis. There is no level 1 evidence, but still the resection offers the best survival advantage. So even if you can't resect completely, you just go ahead with a cytoreduction. At least a 70% cytoreduction is one. So this is all the papers. This has been, the cutoff has been reduced to 70%, even in non-functional NETs. So my question is, before going to surgery straight away, can you downstage this tumor? Can you give some therapy, and can you think about downstaging the disease? What about systemic therapy in downsizing?
Almost impossible. So we can, whatever I told you as a maximum, we can get a stable disease with systemic therapy. A downstaging to make a meaningful liver resection is unlikely. So there is no, so far, any role of neoadjuvant or what do you say, a downsizing tumor regimen in NET.
So not even this tear, TACE, nothing?
No, so that's a different thing. I think
tear, Sendil sir, what about tear, PRRT as downsizing therapy?
Yeah, there are only case series where they have tried as a downsizing thing, even for the primary and metastatic setup also.
But the response rate after
tear? Not very that good.
Not very good. Okay, so TACE, Arun sir?
Just please go back to the previous slide. Yeah, just see the disease mapping in this PET. This is something like type 2 liver mets. That means the bulk of the lesions in the right lobe and one or two small deposits in the left lobe. Very small deposits.
Yes.
So this is something like we can even treat with an intention to cure.
Sure.
So definitely we need, for a surgeon, two things come to our mind. That is, one is TACE, and second most important thing is portal line embolization. Thanks to Dr. Shashikaran for these images. Just see, play the first video. Just see a large lesion in the right lobe. This is not the case which we are discussing, and a smaller lesion in the left lobe, and a small inconspicuous primary in the tail of pancreas. This is the dotted tate. Again, just see the lesions, 1, 2, 3. Just 3 lesions on the pancreatic primary. 4 weeks after their right portal line embolization, play the video please. Now, we even volumetry is always done, but still, just have a subjective assessment. The left lateral segment especially is hypertrophied very much, and the right lobe has shrunken in size. So this is definitely a favorable situation. Unlike in HCC or even hylar cholangio, a portal line embolization, we have good amount of time to wait. This NET is slightly slow growing stuff. So we have more time in such situations.
Sure. So, will you consider liver transplantation? I will show you 3 scenarios. In which of the scenario you will consider liver transplantation in an NET? If all the favorable outcomes are there, if all our inclusion criteria are met.
I think Dr. Unni will answer it better because they run high volume programs. But let us go back to theory slide.
1, 2, 3.
See, the indications definitely doesn't always depend on the images. There are so many other factors. So definitely it should meet some criteria, not for all, definitely no. Low grade is more important. Ka67 less than 10%. The primary must have already resected and no extrahepatic disease by our pet. And there should be a documented stable disease for the last prior 6 months. And age should be less than 55. And if the bulk is CT tumor volume wise, it should be less than 50% of the involvement. Or if it is for the syndromes like refractory symptoms, the bulk should be less than 75% occupying the liver. And this has to be a strict no-no for a transplant, that is small cell and high-grade tumors, non-GI carcinoids, and tumors which are not drained by the portal system. Anything above the G junction, below the dentate line. That means they won't benefit from transplant because they are not drained by the portal system. And something like an expected 5-year survival of 50%, a 5-year disease-free survival of 75%. I think they won't agree with us because they can give much results in such situations with
So, but I think the Milans has actually given 5-year survival of 85% overall survival.
But this side, I think just like hylar cholangiocarcinoma, we should be very stringent and highly selective in choosing patients for transplant.
So in which condition you will offer transplant, which condition you will offer resection, portal vein embolization resection, and which condition systemic therapy? Which image?
See, the first 2 ones is type 3 liver mets. I think they won't benefit.
But in first one, if you see the entire liver involvement, it's only less than 50%. The primary has been resected after 6 months, well differentiated. All the criteria are met in type 1. Do you agree? Type 2, more than 50% liver involvement is there. Okay, excluded.
The second one, the middle picture is
excluded.
Strict no-no.
Excluded.
Radiologically strict no-no.
Yeah.
First one, if you are very keen and there is a living donor waiting, altruistic, then proceed. Not for the third one.
Third one, we can offer resection, I think.
Resection, you do a left
portal vein
you do a
embolization.
left lobe management first and then.
Okay, so there are a lot of criteria for a liver transplantation like Milan, ENETs. We are not going into the details. So what we did also the same thing. We did a right portal vein embolization. There was adequate liver remnant after 2 months, and there is no disease progression during that time. So we did a right hepatectomy, which is actually extending into segment for like a non-anatomical resection and the non-anatomical resection of the left lobe lesions. So the HPR is like well differentiated NET. Now the grade has increased 8 to 42%, grade 2 to 3. But synaptophytin is positive. So what is the role of adjuvant therapy in this scenario? Govind sir.
Again, the term adjuvant therapy won't hold here actually.
Okay.
Because there is no regimen which is going to kill him. The only thing is that you can put on him on octreotide.
But it is grade 3, 42% K67
yeah, still it's positive. Unless and there's a carcinoma, there's no contraindication for octreotide. That's the only thing which is going to give PFS.
Okay. So there is no role of chemotherapy in grade 3 NETs or nothing. It's only for metastatic disease. The chemotherapy, everything is for already. If the disease is present, you give some chemotherapy, targeted therapy, everything, or you will give all the grade 3.
NET grade 3, the role of chemotherapy is very, very limited actually. So whatever, again I said, the term adjuvant itself is not really the only advanced tumors where you don't have any other options. You try any systemic therapy. Otherwise.
Okay. So he was on octrate, and this is an image in 2020. So you can see the scar has got some dotted avidity, and also there is one bone also. So what will you suggest? Any change in management? Go in, sir.
So no. So from the perspective, there is no change in management. Initially also octreotide. So yeah, that was the right management actually, because once it's a metastatic, it's almost never curable. Though you can say that you increase a 5-year survival or 10-year survival or PFS, at the end of the day, it's a non-curable disease actually.
Will you consider PRRT in these scenarios?
Yeah, who's progressing on octreotide, definitely. PRRT, again, you have to do a dot uptake, which uptake is good enough.
It's uptake, very good uptake.
And it was, did we do a read biopsy?
No.
No. So that is again a query actually. So even if the uptake is good, the grade 3 tumors response to PRRT is very inadequate when compared to grade 1 and grade 2 tumors actually.
So anyhow, we will have some small discussion regarding the basics of PRRT. So which one you consider? You will go step up to PRRT or as the first line in metastatic disease? Which is better?
In NETTER-1 trial, they tried as a second.
But NETTER-1 is for mid-gut NETs, I remember, right? It is pancreas is not there.
Yeah, in NETTER-2, pancreas has been included. More than half of the cases are in pancreatic tumors, and as a first line treatment, they are trying. They have shown very good progression-free survival. There is a good, significantly high.
So that was
and
my
even
second
overall
question.
Response rate is also very high.
Yeah.
42% compared to 9% in the control group.
So that was my second question. There are there RCTs which really support survival advantage? It is no.
Survival advantage, the initial one in mid-gut NETs, it did not show because there was crossover of the patient. Still, there was around 1 year increase in the survival. And in NETTER-2 also, it is not expected to show because there is a chance for a lot of crossover to the DOTA group.
So for the sake of surgeons, what is the dose, duration, how much you will give, what is the endpoint, what is the response rate?
So dose we usually will give 200 millicurie per cycle for around 4 cycles.
Constant for all the patients or depends upon weight?
Standard. Which is being followed everywhere in the world.
And
6
the
to 8
response
weeks
rate?
gap we will give. Response assessment that in NETTER-2 trial, they have shown very good response rate in the DOTA group, 43% versus 9.3% in the other one.
And after 4 cycles, you will do repeat DOTA-PET.
Yeah, CECT or DOTA-PET if it available.
So what is the endpoint? After 4 cycles, there is no response. What will you do?
Yeah, we have to wait and watch. I mean, there is progression. Then maybe we can consider a few more cycles also. Otherwise, any other options can also be considered.
So I think in grade 3, some of the grade 3 diseases, you can consider PRRT with the chemotherapy also. Am I right?
Yeah, provided there's a, I mean, again, very limited evidence. Provided, as I said, when this is the fusion PET shows a, FDG FDT in addition to DOTA FDT, then they may benefit.
Okay. So what is this alpha particle PRRT?
Yeah, alpha particle PRRT is just replacing the lutetium-177, which is a beta particle by actinium-225, which is having very good radiation exertion. And the side effects also is very high, very low, especially myelotoxicity will be very less, but the effectiveness of, in delivering the tumor dose is very high.
So I think this is useful for even for the grade 3, high grade 3 also.
We can see drastic response in such cases.
So he was on lutetium, he gave 4 cycles of lutetium. After that in 2021, he has got some headache and also some seizure episodes. So this is an MRI picture. What will you do? Go in, sir.
So was a systemic imaging done?
There are disease progression. Abdomen, there are a lot of disease.
Okay. So symptomatic for this disease, right?
This is symptomatic.
Okay. So and your it's still at NET grade 2, right?
Yeah, still NET grade 2.
So your only palliation is here is go for a maximum safe resection of the tumor, nothing more.
So yeah. So anyhow, we did a surgical resection, and after surgical resection, 2023, the patient has actually expired. So we'll quickly move on to the case 2. This is a 36-year-old male with no comorbidities, evaluated for vague right hypochondrial pain, and ultrasound shows multiple hepatic complexes. I will just show this diagram. So this is a diagram where you can see there is a right lobe, superior lobe, there is a cystic lesion, left lobe, some 2-3 lesions which are surface, and there is one primary lesion in the head of pancreas. So we did an OGD. OGD showed some nodularity in the D2. The biopsy from both the liver as well as the primary shows well differentiated NET, K67 of 6 to 10, synaptophysin positive, again grade 2, and the DOTA-PET showed no other lesions apart from this. What do you think? How will you approach this patient? Govind sir, Manoj sir, Arun sir. Patient is asymptomatic, grade 2, well differentiated. Manoj sir.
I think maximum debulking should be tried in this case because the primary, this is a well differentiated. What is the age of the patient?
31.
31, a young patient. So we should try for a maximum debulking with concomitant ablation possible.
Do you agree, Govind sir? Surgery or you will straight away go out with some systemic therapy?
So again, very difficult to say in this patient actually, because primary said, secondary said, and maximum debulking at this phase. No, I prefer to start on systemic therapy in him actually and observe.
So will you consider primary resection if suppose the liver lesions are all unresectable? We are not going to deal with the liver lesions. Will you consider primary resection in such a scenario? Is the primary resection such scenario carries any survival advantage? Yeah, go in, sir.
No, when you're not touching the liver lesions and such a small nodularity, that don't really help.
But sorry to say, I can show you again 40s of patients where a primary lesion in metastatic. So this is our meta-analysis. Resection is better, resection is better, resection is better, resection is better, resection is better.
Yeah, so again, there are all, see, meta-analysis finally is a collection of batches actually. So depending on what center you did it and what surgeon did it, that will only
all the meta-analysis. This is the latest one, 2024. This is old one.
1 minute. Whether the location of the tumor affects the
that's what I wanted. I wanted. So
I didn't get you your question.
Because it is head of pancreas lesion, whether the location of the tumor changes
this
the
patient
management. Primary.
Needs a Whipple, because other patients, suppose it is a jejunal lesion, then the easy resection, we would have gone ahead with the resection, compared to a Whipple's which has got a more morbidity and mortality.
Yeah, I understood. But in this case, if you do maximum debulking and if you need to apply radiofrequency ablation, it should have been done before doing Whipple, because hepatocogenostomy will predispose these patients to hepatic abscess.
Even after all the empirical antibiotics. 17%
are very high.
Very high.
So in these cases, the surgical debulking should be done before an hepatocogenostomy of any kind.
Jasir, I have a point to discuss here. I think I tried in ASGK also. That time we didn't discuss because of want of time in that Puneet sir talk. First thing I want to know, is there any role for liver transplantation in our scenario? Because I wanted to know from our all units whether anybody has done a liver transplant for neuroendocrine tumor. Unni is there?
Unni, sir?
I've been trying to avoid getting involved into this. Not that I can remember. We are not
done.
Venu, sir?
Anyone else? Aster, anybody is there?
Biju, sir?
Because this, we had a patient, similar patient, but a better looking lesions, low grade, grade 1, presented with a jejunal ulcer from a pancreatic head NET. So it was a symptomatic NET, and we have a situation here. If we have a role for liver transplantation, there is a point in resecting the pancreatic head. Because without resecting the pancreatic head, you have to give systemic treatment for some time. Without seeing the biology, you cannot do transplant. So if you are saying that there is no role for doing a primary resection, that means you are saying there is no role for liver transplantation in pancreatic NETs. So that point, none of our oncologists agreed for a primary resection, saying that there is no role for liver transplant in this patient. That means we are going to say that there is no role for liver transplant in NET metastasis.
Actually, he is very pro in resecting the primary.
I want to resect the primary.
I want to hear from the oncology
I want to resect the primary.
Side from the nuclear, because they don't allow. They will say that we have enough other treatments. But being said that these are young patients, my patient also was young, and when you give an opinion like that, then the patient will definitely not think about a surgery. They are given an opinion that even with long-acting octreotide and the second line and third line, your PRRT and all later on, they can live longer, and transplant will not add any benefit.
Again, very difficult to say. As you exactly said, no, I think none of the Indian scenarios has any experience with transplant in this patient actually. So again, I would take another example as this actually. If you take the Mayo Clinic for cholangiocarcinoma, transplant is a very pro. You give 5FU with RT and take a 4 transplant actually. But in India, I'm pretty sure that nobody has done that actually. And still, even I come tomorrow for me, even it's a 30-year-old male, nobody's with that going to do. Because at the end of the day, your experience probably or your comfort is more than that. So you give an opinion on liver transplant, you don't know the biology, that's going to be very difficult again actually.
No, but these patients, all the biological predictors are there in front of us.
Grade 1, well
differentiated. Everything is there. So patients are not looking bad like this.
Yeah, again, as your case, I'm not really sure, but is grade everything in NET? I'm not sure actually, because as we have seen, grade 1 creating more havoc than grade 3, because it's a very heterogeneous thing. And if you take the Ka6 of the cutoff, Ka6 is one thing we, as a medical oncologist, is always having a nightmare of actually, because Ka6 is forget about the NET. Even if you take breast, actually, so many things depend on K6N. But K6N is when you when there was a trial on K6N. K6 is a maximum heterogeneous thing which the pathologist comments. So one person comments as 10%, another person can comment as 70% actually. Some even can go up to 95 and 10%. So that is a heterogeneity in this. So your systemic therapy and your tumor biology is very difficult to say with K6N alone actually. Probably over the time, probably we'll get some genomic signatures which down the line, which may help us to predict more regarding the tumor biology. At that point of time, yeah, again we'll be in a much better position. But otherwise, I don't think nobody.
But basically,
But Mazafaro series has clearly shown a huge difference
Huge
between the
5-year
10-year
survival.
survival.
Yeah.
5-year it was not different. But when you see 10-year and 15 years,
Wait.
especially we are looking at patients who are at 30, 35, it has shown a huge difference between the survival of those who have undergone transplant and not undergone transplant.
Yeah.
And they have selected out patients by doing the primary resection. They have given 6 months,
6
1
months,
year,
waiting
and
period.
2-year period on the long-acting octreotide. And they have seen the stability, biological stability, and then they have transplanted at a right time. And he himself has very clearly quoted that when there is a situation when the tumor is progressing on systemic treatment, that time everybody will say you try for other treatments. We have got many references for transplant opinion when the tumor is progressing on systemic treatment.
Yeah.
So that time he has clearly shown that there is no benefit for doing transplant. The transplant is benefited only when you take a decision after 1 year or 2 year on systemic treatment when they are stable. So to do that, you will have to resect the primary. Without resecting the primary,
So
you
yeah,
cannot do that.
so can we put another way? So can we just start on the octreotide and then wait for primary as well as secondary and then decide on what to do
Later on.
after 6 months, because that is
No.
not to harm the primary or.
After 6 months, I don't think there will be any difference in these patients.
Yeah, so then there's again a rule actually. So imagine if we restrict out the primary and start on octreotide, after 6 months if the meds is increasing, then it's again a no for transplant, right? So same thing happens if primary is sitting there also. We can plan the surgery later on also, the primary. It's not that we should start with doing we should have a liver transplant, plan of liver transplant immediately when we see this and restrict out the primary, start on
That's what
octreotide.
I'm
Yeah.
saying.
That's probably difficult to comment actually, saying that
So,
in
yeah.
thinking liver
So-
transplant we should start
So I think
surgery initially.
I think for the want of time we should move forward. So anyhow, our plan was to just go for a staging laparoscopy. We'll take out the primary. We'll think about the right lesion, but we will do some non-anatomical resection of the left lobe lesions. And for the augmentation of the right lobe, we'll think about some right portal vein ligation or something. So that was our plan. But we did a staging laparoscopy. There were multiple liver lesions, omental subdiaphragmatic deposits, which were not picked up in the daughter pet. So I think this is everyone will agree. We won't proceed. We have referred the patient for lutetium. So 4 cycles has been given. So surprisingly, I called upon this patient. This patient was in 2017. I thought he must have died, but currently he's doing well. With actually the disease has come down. The reduction in the disease status also. So one more thing which I wanted to do is like we'll quickly go through case 3. It's a 52-year-old female evaluated for an obstructive jaundice. So this is a picture. You can see there is a head of pancreas lesion. There are 4 lesions in the liver, surface lesions, and daughter petis there is no dissemination. Net pet is P3, and you see the HPR. It's a well differentiated NET, grade 2, but Ka67 is 16/19. So I think nobody will have any difference of opinion. We will go ahead with the Whipple and some non-anatomical resection of the liver, either with an intraoperative ultrasound or something. So I am changing the scenario. So what if the HPR is grade 3, the Ka67 is 30/40, well differentiated. I want Govind sir as well as Manoj sir and AML has to comment. So 3 scenarios I am giving. Grade 3, Ka67, 30/40. Grade 3, Ka67, 65/70. And Ka67, 50/55 with the neuroendocrine cancer. So what will you do? How the management changes? First, I will start with the Govind sir.
In the first 2 scenarios, there's absolutely no change in management actually. You have to do surgery this one. Poor differential NEC, you can plan your chemotherapy initially. Systemic therapy, you can still try because it's a metastatic disease. You can try it. After 3 to 4 cycles, you can go ahead with surgery.
Manoj sir.
Yeah, I'll try to make it simple. See, poorly differentiated means it is cancer. It is like pancreatic adenocarcinoma with metastasis.
True.
Nothing to be done. Forget about it.
Yeah, we should.
Actually.
Then you have another 2 scenarios. So you see the grade of the tumor. The grade is grade 3. Then you look for the K index. So whether to resect or not is the play of the K index. So I don't think the first group and second group differs much because the latest studies have shown that resection offers better survival advantage even if the K index is more than 75. So you can group the first two into a single group and consider the third one as different.
Okay, so why I took up this is because if you read literatures in previous studies and all, if K67 is more than 55, those patients won't perform well after resection. So you go ahead with some sort of systemic therapy, wait for any response. If no response, don't operate. If there is response, operate. But nowadays, the studies are coming, even K67 more than 55, if it is aggressive, you go ahead, resect and then do. So I just wanted to ask one more question. Is there a role of PRRT in grade 3 NET? Sendil sir.
Yeah, in grade 3 we can, there is definite role, but we have to do FDG PET also in
So
those patients.
grade 3 can be poorly differentiated also.
Grade 3, I think up to 55% they are taking up. If the FDG is also positive.
See that 55% is coming up now again.
Yeah,
K67 more than 55.
Has been saying, but if that is not a cause, maybe we can go beyond 55 also. But definitely we have to do FDG PET and see if there is FDG ability. We can include chemo agents also. Like,
so I think the take-home message is like if we can go ahead with an aggressive surgical management of the NET metastasis, it is well and good. I think Arun sir, do you want to say anything about this video?
I think this is a very small video, courtesy Dr. Shashi Kiran. This is something like a right hepatectomy. The right hepatectomy liver is out. Now intraop ultrasound showing one lesion in the left lobe. By the time the interventional radiologist people are informed, open distal pancreatitis splenectomy, ultrasound guided, intraop microwave ablation of the left lobe nodule. Every disease was mapped with 128 slide CT as well as dotatate. Very aggressive resection, but the patient had a carcinoid syndrome actually, and doing well.
Thank you. And we will just wind up with 2-3 spotters because we haven't mentioned about any functional NET. So can anyone guess what this is? Sir, I think to the residents audience. Yeah. So this is a gluconoma where you can see the necrolytic migratory erythema. So who is he? So why he is related with the NETs?
Whipple.
Yeah. So this is Alan Oldfather Whipple. You know the Whipple's triad. And who are these two persons? So it is two persons NET. It has to be only one diagnosis. NET, two persons, and I can give you one more example. Yeah, this is Robert Solinger and Edwin H. Ellison. And one more thing, I think yesterday Dr. Tara must have shown you this picture, but
probably next year your photo will be in between them, right?
That's why you left a lot of spaces.
Ramesh sir, please keep quiet.
So
let
okay.
the residents answer this. I know.
Yeah. Oh,
Diagnosis?
Diagnosis. VHL. Excellent. So what is in the cerebellum? Hemangioblastoma. Yeah. So the one more thing. So this is an Iranian actress. So she was actually after death. She didn't even get a graveyard because she was against religion, because she was doing all those sort of activities.
No wonder you are interested in NET.
I know it's related with NET, but the name of that disease comes from this lady, but that is not this lady. The name of the disease comes from the first patient. That patient's name also surprisingly matches with this lady's name. And this picture you can see there is an immunofluorescence where it's a glucagon, lot of glucagon. That greenish things are glucagon receptors. Can anybody guess this? This is entire pancreas with acinar hypertrophy and glucagon receptors. Only 14-15 cases has been reported all around. What? It's like a glucagonoma, multiple glucagenomas within the pancreas. Only 15 cases till now. So this is something called as a Maharwash disease, where there is glucagon receptor resistance. Because of that, multiple glucagenomas will happen. Maharwash disease. Not because of her name, it is because of the first patient, her name, suppose accidentally Maharwash. That is her first name. So I think, thank you for a wonderful patient listening, and thank you all the panelists. Yeah, discussions.
Sir, we had a patient, 55-year female, who had a history of left nephrectomy for RCC 6 years ago. And now there is an accidental hypervascular lesion in the head of the pancreas, 1.5 centimeter. On Dotabet also no other uptake apart from this lesion. EUS also confirmed hypervascularity 1.5 centimeter head of the pancreas. FNA was not feasible because of the vascularity. They had not taken FNA. So what would you do, sir? Whether you will go for resection?
Resect. 53-year-old head of the pancreas lesion, primary, hyper-enhancing. Resect.
Previous history of renal cell carcinoma, repeat USFNA.
So, sir, we should probably force them to take FNA.
So, no, what is, it's
Like
a controversy,
refused,
there is a
They
controversy.
refuse to take FNA
No,
saying
no.
it's highly vascular, it will bleed.
No,
Refuse to take FNA.
yeah.
So what would
From
we
an
do, sir?
oncologist, from a medical oncologist perspective, you can actually resect out actually, because RCC, even it's a oligomets resistant RCC confers a very good survival just like NET, because you don't have a adjuvant therapy for RCC, so it's okay.
RCCs doesn't respond to any other modality of treatment. Interferons, how does it?
I think the era is over, sir, actually. Right now we have immunotherapy and TKs. It responds actually, but again, solitary meds, your survival, you will get a definite benefit by taking it out. So here there is no question actually. Even if it's both, it's a treatment.
In your regular Whipple, if you say something like 2 to 5% is our operative morbidity mortality rates, you make it a bit more because you're doing a Whipple resection on a single kidney. So something like 5 to 10% of perioperative events.
So, sir, after resection, if like histopathology comes as meds from RCC,
Still it's okay. You are justified. You are justified. The treatment is, if it's oligometastatic, you are justified in going and resecting. So it's okay.
You should be happy because they respond well with
yes,
the
sir, we had a case actually after
Even
MDT,
we are happy.
Patient underwent Whipple resection only, and HPR came as meds from RCC.
So yesterday's radiology teaching, any hypervascular, hyperenhancing lesion during
First is-
arterial phase within the pancreatic parenchyma, NET, isolated med from clear cell renal cell carcinoma,
Or a spleen.
accessory spleen.
Thank you,
Jasil, the slide which you were talking about, grade 3
Yes, yes, sir.
lesions in the pancreas with one liver met and things like that.
Yes.
So before going for Whipple, since it's grade 3, high KISSC7, is there any role for observation with octreotide for a period before you jump into Whipple?
So, we did Whipple basically for a grade 2 disease. Case 67 was 16 to 19. So, other cases also, I don't think if we give octrade and wait and then Whipple,
There are
I think
emerging evidences which shows that the resection of primary
has got
gives
better survival advantage.
I'm asking about an observation period to know the biology.
Will you consider going sir?
Biology, there is nothing called knowing the biology in neuroendocrine tumor. That happens because it is metastatic. It will recur.
It is about grade 2, grade 3.
No, sir, I understood sir's question actually.
Case
but
67
since-
high,
yeah.
case 67
But
high
since it's a
cases.
solitary meds actually, still we can go for surgery actually. I understood your question, but since that case definitely you could have.
Oh. Okay, if no more questions, I think we shall wind up. Thank you. Thank you.
Before we conclude and break for lunch, I would like to say a big thank you to all you participants, delegates, and faculty. Braving the rains, you all came and participated and did your part, and that has made this conference a huge success. And not to forget the hard work by the organizing committee members, the audiovisual team, Ethicon, and Le Meridian for allowing us to conduct this event. A big thanks to you all. Residents, please assemble for a talk on the science of stapling and energy.
Yeah, good afternoon. So, I know it's a post-lunch session, so we'll keep it more practical because these are two things which we commonly, probably we use it in almost every case, but there are some, it's always better to refresh some of the basic principles which are essential. So, when we talk of stapling, okay. So these are some of the questions. Maybe we can, so we'll not have a poll, but I'll ask that the questions are there. So anyone, or maybe show of hands, which of these provide a better clinical outcome for anastomosis? Stapler, suture, both are same. Okay. Which of the following staplers you have used in your procedures? I think most of us would have used all. What type of staple line do you prefer? Bone dry, visibly perfused. Okay. What type of compression is better for stapling? Now let us know, anyway, we will know the answer at the end. So, focal compression, parallel compression. Okay. And how long do you wait for after applying the stapler before firing it? Fine. So, yeah, most of the things are right, but few things, at least I will, I won't say it's wrong. The more the time you wait is better, but the recommendation is 15 seconds as per their, whatever the stapler manufacturers, the recommendation. So, we know there are various techniques. I think if you see the evidence for a few, obviously there's no difference. In some of the anastomosis, stapler has advantages. But there are few advantages, or I would say maybe advantage with the stapler. One is standardization, because if you ask 10 surgeons to do anastomosis, you can see there will be some variations the way they do. But when you talk about a staple anastomosis, that is, I mean, 10 different surgeons is going to be uniform. So everyone will agree that it allows standardization, definitely speed. And there are some areas, for example, low anterior resection. Obviously, we prefer a staple because doing a hands-on anastomosis in that area is challenging. So, so almost all of us will have to use stapler in some part of the procedure. Now, if you, how it works, what is the mechanism of stapling? It's like any other routine staplers which you have. There are two parts, hammer and the anvil. So here the staple is delivered and it hits the anvil into this groove and the stapling is completed. So the same principle is applies to the surgical stapling also. So there are some important parts which we should know. So you can see here, the cartridge has all the staples arranged like this. Now you need something to drive the staples up so that it hits the anvil into the sockets, and because of the pressure, you will form this a B formation. Now this is called the sled. It pushes the staples. Basically, it pushes the driver, which pushes the staple against the anvil. And always you have the knife, which is just behind the sled. So this is the principle in all the staplers. So when you fire, you can see here, this is the sled, and this is the knife here. So the sled keeps on pushing the drivers, which move the staples up. It hits the anvil, and then the B formation happens. So this is how all the stapling is done. And irrespective of whether it's a linear stapler, it's a curved contour, or it's a circular stapler, the principles are same. So you have the driver, then you have a sled, and then the staples are formed by hitting against the anvil. And we know that a good staple formation means this formation of a B, because that ensures there is adequate apposition without a significant bleeding. One advantage, probably I would say, like we have two techniques of suturing, a continuous and interrupted. And although if you talk of evidence, many studies will show there is no difference, but there are some areas where the interrupted suturing is preferred. Now the staples, in the stapled anastomosis, each well-formed staple is like a bite, which means it's like a good interrupted anastomosis. So that's probably an advantage. And obviously we know that when you see this picture, this is not a good staple formation because of the tissue is thick. The staples hasn't pierced the tissue adequately, and it does not have enough contact with the anvil, so the B formation does not happen, and this obviously the outcome is not going to be good. Again, this is much worse than the previous, because in the previous you know that okay, the staple formation hasn't happened, so you know that there is no proper staple formation, so you will take additional steps to correct it. But here it looks like the B formation has happened. It looks like that, but it doesn't. It's not complete. So we may not realize the improper staple formation, and so this is very bad. So this is the ideal staple formation, and you can see here the staples pierce the tissue at 3 places. So one here, and then at the second point here, and after that the tip again pierces the tissue. So each staple is like a 3-point fixation of the tissue. So the tissue gets fixed at 3 points. So that's why the B formation is considered to be an ideal staple formation. If it is just as a V, that means it has pierced only once. Incomplete B, it has pierced only twice, which means the tissue fixation is not adequate. In the complete B formation, there's a 3-point fixation, which means there's a good tissue approximation. That's why we highlight the importance of this good B-shape formation. So what are the factors? What are the factors which determine this good B-shape formation? One is obviously the proper cartridge selection depending upon the tissue, compression, time, and the minimal tissue movement. We will actually discuss each of these components. So we know about this. We have this black, green, gold, blue, and white. The key is the closed staple height, 1.5, 1.8, 2, and 2.3. So you need to choose the tissue according to the tissue thickness. You have to select the cartridge. Frankly speaking, the ideal the cartridge, probably I think that's where the companies are working on. They should recognize the tissue thickness after compression and adjust the staple height accordingly. I think that is the ideal into which the companies are working on. Probably we will get it soon. But till that time, it's our responsibility to select the correct cartridge depending upon the tissue thickness. And one typical example, in a same organ, again, we might have to use the different type of staplers, because we know that the antrum is thicker compared to the body and the fundus. So depending upon, you might use either the black or green cartridge for firing the antrum, and as we go up, we generally use the blue. The next is the compression. So why the compression is important? Because when you do this a pre-compression, what it does is it compresses the tissue. Now the tissue has the tendency to rebound. It tends to regain its shape. So you have a compression, and when you wait for some time, it also regains and it stabilizes. So why the compression is essential or critical is because it adjusts the tissue thickness to the staple height thickness. So the recommendation is you give compression for 15 seconds so that it displaces the extracellular fluid and the tissue elasticity also is regained, and then the thickness is adjusted to the cartridge or the staple height. So the recommendation is 50 seconds. Obviously you can give more, but the advantage you gain with prolonged compression is not seen beyond 15 seconds. The only exception is pancreas, because all the staplers are designed for the bowel or the vessels. None of the staplers are designed specifically for the pancreas, and the pancreas, the tissue consistency is different from rest of the tissue. So that's why we use something called a slow parenchymal flattening or prolonged peri-firing compression technique, in which you compress for at least a minute before you start firing, and with each firing also you wait. So the whole stapling, when you do a distal pancreatectomy, the whole stapling is done over a period of 3 to 4 minutes. And this has been shown to reduce the fistula rate in studies. Otherwise, in the rest of the tissues, it's a 15-second compression. So that's what it does. It prepares the tissue for a stapling. So it's very easy to understand when the compression is inadequate, you have poor hemostasis, leak. When over compression, you have this tissue damage because of ischemia. So it's ideal to have a good hemostasis and secure anastomosis, the optimal compression. Now, so the companies are coming out with some of the modifications, the 3D. So the typical stapling happens in a 2D plane. So what the 3D does is, so in addition, instead of just a simple B, the B happens in a slightly oblique angle. So what I would say is, like, we can understand, imagine the 2D, it happens in 2 planes. The third plane with respect to the sideways movement happens in the 3D technology. To make it simple to understand, so you have 3 staggered rows. When it happens in a linear way, there are some pathways where potential defects can happen. With the introduction of 3D technology, it minimizes those potential defects. So what is the clinical relevance of this 3D? We all know the whatever endostaplers which you use have 3 rows. That is to ensure safety. Now with the introduction of this 3D technology, you could potentially achieve the similar safety with just 2 rows on either side. That is total 4 rows. Now where it can be useful, sometimes like when you, I think people who are involved in transplant, they can understand, like 3 rows of staplers, you lose vessel length. So reducing the rows will help you to gain the vessel length, and probably this is the area where this 3D technology will help. The next is about the focal versus parallel compression. Now, we all know there are many staplers available in the market. But if you go by the technology, on one end you have the echelon where the compression starts the moment you close. In all other technology or the manufacturers, the compression starts after the first firing, which means the compression which you get in echelon is called as parallel compression. whereas in all other technology, the compression is in place where the firing happens. When you do the first firing, it fires, depending upon the manufacturer, 15 or 30 mm, the compression is there. And then it keeps on proceeding. So what is the difference clinically? When you have the focal compression, the minimal tissue movement happens while the firing is happening. But with the parallel compression, with focal compression, the tissue movement will happen as the staples are fired. So how it translates, if you are firing a 60 mm cartridge, if lot of tissue movement happens, the final length of staple, the staple length, would be roughly around 50 mm. It will never be 60 mm. But when there's a minimal tissue movement, then you can expect maybe close to 60 mm, like something like 58, 57, so in that range. So that is the advantage of having a parallel compression compared to focal compression. Then we also, so to improve the stability of the tissue, the other modification which has been introduced is the gripping surface technology. The main aim of this technology is to ensure the tissue movement is further reduced. We know the parallel compression reduces the tissue movement, but in gripping surface technology, what is introduced is this kind of this bumps which are, you can see those elevations. So it kind of holds the tissue and further minimizes the tissue movement as the firing happens. Also, if you see the another variation which has been introduced in GST compared to other is the tip is slightly bent, which allows the staples to engage well into the sockets in the anvil, which again facilitates the proper B formation. So studies done on the tissues which have been imaged with the CT and reconstructed have shown a much better, like the most of the staples achieve a good B formation compared to when there is no such technology, because some of them does not get engaged into the sockets in the anvil, so the proper B formation does not happens. So these are the modifications introduced, which I've already highlighted. So this is the current, I think if you have the best technology available for you is with a gripping surface technology. So you have the parallel compression, then you have the closed channel that's with respect to the cartridge, then the extended anvil pockets, as you can, as I mentioned, with respect to the bend, and then there is no asymmetric staple legs, and lastly, there no lateral lag in staple formation, which means the minimize the tissue movement which occurs during stapling. So this is what is required, and the available technology ensures all these important parameters are fulfilled. So some of them are with respect to our decision, with respect to cartridge selection, compression, and the minimal tissue movement is now ensured by the advancements in the technology. So that's the, as I told you, it's only just about the overview, and any questions we can discuss. Okay, this is just beyond, when you do a low rectal, low anterior resection, so how many of you prefer, I mean, it's not nothing related to, how many of you prefer echelon and others? No, because that's one area I always use echelon, because we know that. Because of this? Yeah, height difference or it's...
Yeah.
That probably because the tissue no longer behaves normally, so probably the displacement, all those things.
So in an edematous bowel, every puncture hole by the stapler is a perforation. It's a microperforation. Doesn't hold very well. So edematous, inflamed, emergency, peritonitis, avoid any staplers.
So when the B formation is proper, overswing is recommended only when you have the spurtus. Because otherwise, for example, the staple formation looks perfect, overswing actually can be counterproductive also. Because you are adding a layer and that can introduce, like it can probably result in ischemia at the staple end. So when the staple formation is good, overswing is generally not recommended. But if you have any doubt or any spurter, then definitely.
Just a comment regarding when we do sleeve gastrectomy, bariatric procedure, Dr. Narvaria from Ahmedabad, their group strongly recommends 3 minutes compression time.
Okay.
For a better hemostasis. Basically, they found it, just apply it for 3 minutes and then only fire.
Actually, this 15 seconds, this is for the displacement of the extracellular fluid. So that's where. Now the compression, what you are mentioning is after, some people do it after firing. They wait before they open the staplers. There probably it's like, for example, when there's a bleeding, you compress with your hand. It causes hemostasis. So the same thing happens like with the stapler in situ. It's like kind of you are compressing the tissue. So probably it results in hemostasis. Maybe there it might help. But the initial thing really does not matter with respect to the hemostasis. The initial is mainly for the good staple formation. After that, at the end, leaving it compressed, probably will help in hemostasis.
Pancreas, which color you use? Distal panc.
So we actually measure the thickness of the pancreas in the CT. We know that we are going to transect, roughly we have an idea. So we measure the thickness. If the thickness is more than 22 mm, which is 2 point, no staplers. Because none of the staplers will work well. Because the staplers have to go through, our aim of stapling is to close the duct. When the tissue thickness is more, then none of the staplers will work. Again, when the thickness is less than 13 mm, again staplers are not good. But if you want to use vascular there. Otherwise, generally we use gold. There's no strong recommendation for that because that is, some of the studies have shown that is appropriate when the the pancreas thickness is between like 13 to 20. So use the gold one, which has a close staple height of 1.8 mm.
So 13 to 22 millimeter.
Yeah, the 13 to 22 is where is ideal for the stapler. Beyond both the ends, both the extremes, the staplers are not that good.
Anteroposterior thickness on CT.
Yeah, on CT. Yeah, so what we do first, in fact, some of them even describe that once you start mobilizing, the intended level of the transaction, you even place a bulldog. So it will kind of compress it, let it. What they tell is the prolong. If you actually see the original description, they do it almost like 7 to 8 minutes also. So general principle is the more compression really helps in the staple formation. So right now what we use, initial compression for a minute, and with every firing 30 seconds. So this is something different from other areas. Because pancreas, as we told, because the staplers are not designed specifically for that. Okay. So the next is about the energy. Again, we are going to discuss the principles which we should understand when we use these energy devices. Commonly, we use electrocautery that is based on the radio frequency energy. It works well, but obviously we should be aware of the risks with respect to the when the neutral plate is when it's not properly placed. You will have this thermal burns. Someone with pacemaker, you can't use electrocautery. And obviously, when you see, it's like the suturing technique, the way people use cautery. Also, there's a wide variation. And especially in laparoscopy, if you're not careful enough, all this capacitive direct coupling can happen. That is, the part of the cautery touches if you're using metal trocar. So all those collateral thermal damages are possible. Not telling it's bad, but when we are using this radio frequency, we should be careful of all these factors. So what we see next 15 minutes is the principle of knowing how these ultrasonic devices work, the properties of the harmonic waves, and some of the tips how to effectively use. The most important thing to realize is these devices do not pass electricity to the patient. That's the most important thing you have to realize. So how it works? It's mainly by friction. Okay, they vibrate at such a fast speed. So any movement is resisted, it generates, because of friction, the heat energy is generated. So we all know about the generators. What the generators do, they give the radio frequency energy. Now that radio frequency energy comes through this wire and reach the transducer. The transducer has piezoelectric crystals which convert this radio frequency energy into ultrasonic waves. And that ultrasonic waves is transmitted into the tip, and this vibrates at 55,000 that's a frequency per second. So that's a rate at which the tip vibrates. So when the tip, which is vibrating at 55,000 hertz, comes in contact with the tissue, it generates friction because its movement is restricted, and that generates the heat energy. So that is the basic principle how the ultrasonic energy device works. So the vibration happens and the tissue comes in contact. So how to improve that friction? To increase the friction, you also use the compression, because by just touching, you just do generate friction, but once you compress the tissue, the friction which is generated is more, which means more heat energy. Because the heat energy is by friction, no electricity reaches the patient, so you don't those of complications related to radio frequency energy or the electrocautery. So when you keep the harmonic open, you activate it and you touch the probe, no heat, you don't feel the heat. But the moment it touches the tissue and then after using it, you touch the probe, you feel the heat. That's because you need a tissue to generate the friction and thereby the heat energy. And the main advantage, you can see the way the probe moves, because we all think that it moves in upward, downward, but it's actually the forward, backward movement. The vibration is in the forward, backward. Because the waves, they transmit in a straight line, and the movement also happens in that straight line. So we all are familiar with the minimum mode and the maximum mode. So what is the primary difference is the amount of displacement which happens at the tip. You can see here there is a minimal displacement, the maximum displacement. So when the displacement is minimum, the speed at which the tissue cutting happens is less in minimum, but the hemostasis is better. But when the displacement increases, then more the cutting power increases. Also, when you have more pressure and also more tension, then the speed at which the cutting is done increases. But obviously when the speed increases, the hemostasis decreases. So when you are at the gastrocolic momentum, you want to happen. So have a good traction. You give a traction, you ask your assistant to give a good counter traction, stretch the tissue, use progresses fast. You encounter a vessel, you reduce the traction, so that the tension reduces and the hemostasis improves. So that's how you use the harmonic when you are using it on the tissue. So you can see here, as tension increases, then the cutting speed also improves. The second, so if you have actually seen the initial generation of the harmonic and the current generation, you can see the tip is much more sharper compared to the previous version, because as the surface area decreases, the amount of heat generated per unit area is more. So which means the dissection happens at a faster speed. So that's the advantage. That's why the current versions, the harmonic HT, they are much sharper compared to the previous. And the next thing also is, there's something called this, you should understand about this harmonic waves. There is what is called as antinode and the node. So where the displacement is less, you can see here, there's displacement, that's called node, and this is where the displacement is more, is antinode. So it's easy to understand. The place where the antinode is there, the cutting is faster. At the node, the hemostasis is better. Now, how to apply this principle while using the harmonic? So, if you see here, so this is the harmonic here. At the tip, you have the antinode, which means the maximum displacement happens at the tip. And as you come more towards the base, we are approaching towards the node. So, when you want to do dissection, you hold the tissue with the tip so that you can do a very quick dissection. When you want hemostasis, then have the tissue more towards the base, because that's where the node is there, which means the hemostasis capability will be better. So don't hold the tissue with the tip and then try to achieve hemostasis, because that will not give a very good hemostasis in the same setting. So as I mentioned, when you want to okay, so there used to be one So for example, you have a vessel where you want to keep the vessel. So we know that here the cutting is maximum and here the hemostasis, but it doesn't mean you get for example, you have a vessel, you don't take it right up to the base. Keep it at the center. The reason is, although when you come close to the base, the hemostasis improves, but when you also come more close to the base, there is a possibility that the part of the tissue will be beyond the active blade. So the active blade may not be contacting the tissue. So you could potentially have a portion of the tissue where the energy is not properly delivered. So keep the tissue in the middle and then apply the energy, and that will ensure that you have a good hemostasis. Some of the additional features of the harmonic is, which we all know, is cavitation. I think which we can nicely appreciate this if you are using it in any hemicolectomies or TMEs. The moment you start using the harmonic, it actually creates the plane. How it does? One is because of forward motion, and then also that steam, the steam which is generated, it actually opens up the tissue plane. So that is one of the useful effect of the harmonic, in addition to when you compare with other energy devices, in addition to the hemostasis and the cutting, the cavitation effect. And also you can use back scoring, which means you just, it doesn't necessarily that you have to hold the tissue to activate the harmonic. Even when the active probe comes in contact with the tissue, because the principle is you are generating friction by resisting the movement. So even with the back end, if you touch the tissue, it will get cut. So you can use, when you want to use back scoring, probably I think the gynecologists, they use it when they do myomectomy. Also sometimes we use when you want to make an enterotomy. And we know that we can make enterotomy. Commonly we use cauteries, especially when you want to make a small, but when you want to make a slightly bigger one, the advantage of using harmonic compared to electrocautery is, when you use cautery, you can see sometimes the mucosa pouts out. But because here it actually also fuses the tissue while cutting, the pouting of mucosa happens to a lesser extent when you open the bowel with a harmonic compared to a cautery. So you have additional advantages of the harmonic. In addition to the cutting and the coagulation, you have this cavitation, back scoring, and also the fusing the tissues or prevents the mucosa pouting. So we are coming to the end. The one of the challenge, or at least a worry we have when using harmonic, is the amount of heat generated, because I think many times when it accidentally touches you, you really feel, okay, we don't believe this much heat is generated. And sometimes we also worry that whether it will cause a lot of lateral thermal spread. But actually it does not happen that much, because the heat is primarily generated in the probe, which gets transmitted to tissue. Although the temperature which is generated is high, but the surface area in which it is generated is very less, which means the temperature increases quickly, also it comes down very quickly. The one way of testing it is you activate it, and probably normally what we do is, for example, there is a portion of tissue which you are going to resect, we intermittently touch the probe into that tissue. And immediately after touching tissue, when you touch, you can see the temperature has come down immediately. So even though the heat generated is more, but it also comes down immediately. But still, when you are using harmonic close to the nerves, still better stay at least 3 millimeters away from that, because studies have shown it can spread up to 3 millimeters. The one way of minimizing the heat generation is, especially when you are near critical structure, is don't keep on activating for a long time. Have a count in you 1, 2, 3. So when you activate harmonic for around 3 seconds, the amount of heat generated is much lesser than when you activate for a long time. So when you are close to critical structure nerve, so that's one technique of using harmonic, short burst of harmonic activation, and that's a safer way of doing it. I think we come to the end. So I think this is the summary. So understanding the principle, it's no electricity to the patient, it's just a friction which generates heat, and all other important tips and tricks which where to hold the tissues. And so once we understand the physics and the principle behind it, then we'll be effectively using the energy devices. Thank you. Any questions? Okay, I think so. Thank you.
Now the residents can move to the skills lab, and the trainers will come there.
power